As we wait for all our delegates to assemble, let me share a few words about our host city and this conference. Coimbatore, fondly called the Manchester of South India, is a vibrant blend of tradition and modernity, known for its industry, culture, and warm hospitality. It is the perfect setting for Kongu Pedicon 2025, an annual state conference of the Indian Academy of Paediatrics Tamil Nadu State Chapter. This year's conference is not only a platform for academic excellence, but also a celebration of collaboration, camaraderie, and the shared goal of improving child health. It is a pleasure to have you all here today. Thank you for being present, and we will be starting the first session shortly. Dignitaries, esteemed delegates, and one and all present here today. We are delighted to welcome you back on the second day of Kongu Pedicon 2025. We look forward to another day of enriching academic sessions, meaningful discussions, and shared learning together. We begin today's proceedings with a panel discussion that reminds us how even the most frequent presentations in the OPD can carry unexpected challenges and important reasons for clinical practice. It is my pleasure to welcome the moderator for this session, Dr. Annamalai Vijayaraghavan, Senior Consultant Pediatrician and Academic Coordinator at Mehta Multispecialty Hospital, Chennai, and former Professor at Madras Medical College. He currently serves as Central IAP Executive Board Member, Associate Editor of the Indian Journal of Practical Pediatrics, and has held several leadership roles, including Vice President of IAP Tamil Nadu State Chapter. We welcome you onto the stage, sir. I invite the speakers for the panel, Dr. R. Ramanathan, Dr. Luke Ravi Chellaya, and Dr. E. Shivakumar onto the stage.
Good morning to all of you. Welcome to the second day's program today. Very happy to be here amongst all of you. I must thank the Kongu Pedicon organizers for giving us the opportunity to conduct this panel discussion. It is my proud pleasure to introduce our panelists. All the three are professors in the government medical colleges. Professor Dr. Luke Ravi Chellaya is the Professor of Pediatrics at Madras Medical College Institute of Child Health. He has been an EB member of the IAP, PG coordinator for the ICH-TNSC, many publications to his credit, expert advisor for CDSO Government of India. Welcome you, sir. Dr. R. Ramanathan, Professor and Head, Government Kadalur Medical College, and a Senate member of the Tamil Nadu Dr. MGR Medical University. He has many national and international publications. Welcome you, sir. Next is our Professor E. Sivakumar, Professor of Pediatrics, Madurai Medical College, ICH and RC. He has been a treasurer of the IAP Madurai branch and secretary, and he has been awarded the Active Pediatrician Award and the District Collector Award, organizing treasurer for the State Pedicon 2022. He has many publications. Today we are going to talk about the common problems which are not simple, and most of the problems which we may encounter in the OPD. So initially we should be prepared whenever we are in the OPD or in the hospital. Emergencies need early recognition. Airway urgencies can become airway emergencies. Identify shock early. Pediatric cardiac arrest is preventable, and timely intervention is life-saving. All of you must be familiar with the PALS guidelines, how we should evaluate, identify, and intervene whenever we see a patient. Initial components of the initial impression of the pediatric assessment triangle, all of you are familiar. It's just to recollect. Appearance, tone, interaction, consolidability, look, gaze, speech, cry, breathing, work of breathing, the rate, increased or decreased, absent or abnormal breath sounds, and circulation. Look for pallor, cyanosis, mottling, and bleeding. Next, the next component of the primary assessment includes the pentagon, the airway, breathing, circulation, disability, and exposure. Following which we have to do the secondary assessment, and in that we have the sample history and also the examination, focused examination. Now we come to the first case scenario, and here we are going to follow the PALS guidelines, and wherever it is not followed, we come across some problems which we will be highlighting. A 5-year-old female child who has received the influenza vaccine in the clinic, the initial dose at around 10 a.m. and after that she was sent away after the injection. She was rushed back at 10:20 a.m. with swelling of the lips, rashes, and vomiting. On evaluation, the child was tachypnic, lethargic, and pink. Airway was maintainable, a little tachypnea. Heart rate was slightly increased, and the child had rashes all over the limbs and trunk, swelling of the limbs. She was afebrile. What is the impression now? With the above clinical features, we have identified that there is a circulatory involvement shock. The severity, it is a compensated shock, distributive shock, probably due to anaphylaxis. How will you manage? We must inform the parents about the severity, then position the head by head tilt chin lift maneuver, provide oxygen 100% through the non-rebreathing mask, and the drug to be administered immediately is epinephrine, adrenaline, 0.01 ml per kg of 1 in 1000 dilution, deep intramuscularly over the lateral aspect of the thigh, over the vastus lateralis. That is the site which has got the good vascularity. So it is the site, and many studies have proved that the best absorption will take place at that site. And it can be repeated if necessary after 3 minutes. Next, we secure the IV access for intravenous fluids, normal saline at 20 ml per kg over 20 minutes. And we must know the oxygen delivery systems like NRM for providing high concentration oxygen. Be prepared with the bag mask ventilation, especially when we have to transfer. LMA is easier to use, costly, but very useful in an emergency management. When do we suspect? All of you know it is diagnosed only clinically with acute onset of skin mucosal involvement or both, with respiratory compromise, either of that, or reduced blood pressure or gastrointestinal symptoms, or acute onset of hypotension, bronchospasm, or laryngeal involvement, even without skin, on exposure to a known or probable allergen, caused by certain nuts, fish, meat, eggs, antibiotics, non-steroid anti-inflammatory drugs. For vaccines, influenza is found to be among the vaccines known to cause anaphylaxis, but the incidence is very less. It is 1.35 to 1.85 per million doses, but we do not know who will get that patient. So we should be careful in our clinic and have the epinephrine ready with us. And the dose already mentioned, I am repeating, 0.01 ml per kg of 1 in 1000 deep IM. Never give intravenously. Drug is cheap, but it has got a short expiry date. And once you have given the treatment, admit the child, because anaphylaxis can be biphasic, refractory, or persistent. Don't waste time in using bronchodilators, steroids, and antihistamines. They are only supportive and they can delay the administration of epinephrine. What are the lessons learned in this child? After vaccination, please ask the patient to wait in the observation area for at least half an hour to observe for any reaction known to occur for the vaccine. You should know the reactions which can occur and be prepared with oxygen and drugs, epinephrine. Advise admission once you have a problem like that, and take precautions during transfer. Know about the contraindications and precautions, and most important, report the adverse effect to the authorities. This is how the epinephrine acts. Next, a 7-year-old male child had complaints of headache for the past 3 months, initially evaluated by the community pediatrician, who attributed the headache to a possible refractive error, and the child was subsequently referred to an ophthalmologist who identified mild refractive error and prescribed glasses. Despite adherence to the spectacle use, the child's headache persisted. Over the next 2 months, she was seen by 2 more pediatricians who prescribed medicines, suspecting it to be a primary headache disorder. However, the symptoms continued to worsen. This child had an assessment, was alert, pink, and had a normal respiration. Cardiovascular was okay. Only thing is, the child had a subtle gait imbalance, truncal ataxia, papilledema, and short stature. What is your impression, Professor Luke, sir?
Good morning, everyone. Morning, everyone. First of all, a very thanks to the entire faculty organizing committee of the Kongu Pedicon and my respected DME sir, and respected all the faculties and my colleagues and other residents who joined this occasion. So as we see, this is a common problem, isn't common. OPD is a very crucial place where we identify which child is sick and which is not sick, and which child needs high priority triaging and which one needs high priority investigations and how early. A child is, we all know a child is different from an adult. They cannot tell the symptoms directly, and we have to pick up the signs and symptoms. So as Professor A.V. sir told, when a child comes with headache, so our first thing, how do we identify is whether he is sick looking or not sick looking. So as per the Pentagon triangle, we have divided and we have got some few points. So we observe the child while walking. So number one is there any cranial nerve palsy along with it? How about the pupils? How about the talk? How about the behavioral problem? And the gait is very important. Then the chronicity. So what comes in our mind immediately? Headache. It starts from a simple sinusitis to a viral fever with a headache to a bleed inside with a tumor, and tumor inside a bleed. So a quick rapid examination. First of all, it is a simple case with a headache alone, or does it have any comorbid factor like a syndromic features or any other deficiency like growth hormone or any other comorbid things. So you take a detailed quick neurological evaluation. So a saying goes in Tamil Nadu, like left la kaiya pottu, right la indicator pottu, nera auto water. So like that we should be, the pediatrician should be have that mind of thing. When you watch, when you examine, you keep your mind open, your eyes open. The parents will say something, the child will tell something, and so we do a detailed examination of the central nervous system, and then we check for the cranial nerves, the tone, the reflexes, the gait especially. Then we also see the eye. Eye's papilledema is a very unique and a very important finding. Then we, of course, this child has got a short stature. So quickly what comes in our mind? Go for an imaging as early as possible, as quickly as possible. So urgent MRI, magnetic resonance imaging, as quick as possible. And before that, if there is a hypertension, we go accordingly. We do an MRI with a MRA, MRV, or the BP is normal, blood pressure is normal, then we go quickly with an urgent MRI. An urgent MRI will 90% will give us a clue as what we are dealing with. Whether we are dealing with a space-vacuum lesion or a bleed or any other mass, either a midline shift, everything it will tell very clearly for us to intervene further. And so urgent brain which MRI which was performed now shows a craniopharyngioma. So a rapid examination with a quick eye opening and seeing, so what the eye see, the mind has to decide, and then only the eyes will see properly. So thorough history taking, a detailed physical examination, an anthropometric examination in the case of a short stature or some sort of a comorbid conditions is very important in the evaluation of the pediatric headaches. And while primary headache, as I told you, is very, very common in children, because it can start from a viral fever, it can start from in a monsoon season, it can come with a dengue, it can got a bleed, anything it can come. So when there is a red flags, so what are the red flags is the sensorium, then any vomiting, giddiness, then any blurring of vision, all these are very important findings to take over the headache part. So these are the learning points when we quickly see a child with a headache. It's very important.
Thank you, sir.
Thanks.
Next, we have a 15-month-old male presented with intermittent episodes of inconsolable crying over the past one day, lasting for 10 to 15 minutes, along with 2 episodes of loose stools which were slightly blood-streaked. No history of fever, but had some lethargy in between the crying episodes, and the intake was poor. On examination, the child was irritable, pale, airway maintainable, respiration normal, cardiovascular normal, and child was afebrile, abdomen was tense, organomegaly, etc. could not be made out, but child became very stable and so suspected to have colitis, managed with antibiotics, and was sent home. Over the next few hours, the child developed bilious vomiting, passed blood in the stool, and was brought again to the emergency department. Now, on evaluation, the child was irritable but had features of shock. And now, what is the problem, Professor Ramanathan, sir?
Good morning, sir. This is a very common condition that we come across in our OPDs every day. We have a child coming with loose stools with blood-streaked stains in the loose stools. So we have a big decision to make whether we have to go for an ultrasound or not in that particular few minutes that we get in the OPD. So we have to be very clear of the differences between an intersusception and infective colitis. So in the second stage where the child has bilious vomiting, it's just a cakewalk. Everybody will diagnose interception. But what we would like is to detect earlier in the first stage of the history itself. So how do you differentiate these two things is if the child has an acute attack, that means dysentery will come progressively slowly, the child will have a fever, then the child will have blood in stools, and then slowly it will be progressive. But in spite of that, if there is an acute attack with blood in stools, then you think of interception. The second point is in intersusception, the colicky nature of the pain is regular. That means every 10 minutes once the child will have pain. Whereas in a dysentery, it will be persistent throughout the day. There won't be a paroxysmal structure in that. So if a mother says every 15-20 minutes the child is repeatedly having pain, then you again think of interception. One more clue that we get in our OPD practices, the mother will say the child is drawing up its legs and trying to crawl over the surface. When you put the child on your shoulder, the mother will say, "Kolanda vandi amala eri podu, kaala madakranga, abdi ambu mari valairanga." These are all some subtle clues that will tell you that this could probably be a intersusception. And in intersusception, the child will be lethargic. Whereas in a child with dysentery, the child will have high-grade fever and the child will be toxic. So you have to know the difference between these two aspects, whether it is toxic or lethargic, whether it is acute or it is slowly progressing, whether the child has the paroxysmal in regular patterns. That means you should think in favor of intersusception. So the first investigation that we have is, fortunately, we have an ultrasound in every corners of the city nowadays. So you can just ask for an ultrasound immediately. We don't have time to do a barium meal or something like that. So ultrasound is a very easy methodology to diagnose interception. So whenever the child has got blood in stools, always rule out interception. The parents will try to convince you that it is dysentery. You will try to convince yourselves that it is dysentery, trying to push the ultrasound for the next day or the second day. Don't do those things. If you are in suspicion, err on the higher side and please send them for an ultrasound. Even if it is normal, it is not a problem. But if you miss an interception, the next day you are going to land up with gangrene, which is going to be more complicated for the child.
Now,
So
what must we look for when the child comes with an abdominal pain?
This is one of the most commonest condition that we get in our OPD, next to probably like fever and cough and cold, is your abdominal pain. So every other day you have about 4 or 5 children coming to you with abdominal pain. So we should rapidly diagnose whether they are having functional cause or it's a organic cause, because many children nowadays are having functional abdominal pain. But what you should tell the parent is, you should not tell them that the child is mimicking or doing something out of just try to conversion disorder. You should tell them that this pain is real, but it is not dangerous. That is the most important thing that you should tell the mother. And most probably the functional pain is above 5 years. Any child who has abdominal pain below 5 years, take functional abdominal pain as a second cause. You think of more of organic causes. And the functional pain, abdominal pain will always be umbilical. So ask the mother where is the site of the pain. If it is in the umbilicus, it is most likely to be functional abdominal pain. If the pain is away from the umbilicus, it is most likely to have an underlying pathology. So the site of the pain will give us a clue of what is happening inside. And less than 5 years, you think of organic causes. Then always ask in the history along with the abdominal pain whether there are some other clues for the significant organic cause like fever, jaundice, if they have any difficulty in passing urine, dysuria, if they are having loss of weight, if they have blood in stools or bilious vomiting, these comorbid signs or symptoms will give us a clue that it is an organic cause. And always have the habit of palpating the abdomen whenever a child comes with abdominal pain. Even if you have a busy OPD of 100 patients per day, please do not forget to put the patient on the couch and examine the abdomen. Otherwise, you will miss the mass. You will try to put the patient on the mother's lap and put your hand inside the abdomen. You will not palpate a mass. You have to put them flat on the couch and then palpate. See for any organomegaly, if there are any grunting or if there are any guarding or rigidity, then any other, and always have a look at the rectum also. One area which we miss when we have abdominal pain is we don't look at the rectum. It could be a small, simple constipation causing abdominal pain. We don't ask for the history of whether the child has passed stools or not. We send them for ultrasound, CT abdomen and everything, and finally the mother comes and tells us, "Moonala motion polo kolandandra." So that is the commonest, one of the very simple reasons to treat your abdominal pain. Associated systemic features like rashes, joint swelling, those things also should be thought of to see any systemic causes. So that they are all very rare causes. But functional abdominal pain is becoming very common now, which is otherwise called as centrally mediated abdominal pain or brain-gut dysfunctional problems. So there is a problem with the brain and gut. So nowadays we are giving probiotics in the form of Lactobacillus rhamnosus GG. Sometimes these children benefit out of that also, and they grow out of it. So any child who has a abdominal pain more than 4 times a month, continuously for 2 months, and you don't have any cause, you just term them as functional abdominal pain and tell the mother to review again and again and tell her not to worry and give her more counseling. Some investigations that we usually do is your ultrasound abdomen, which is very readily available for us. It will give you a lot of clue. Recently we saw a child with abdominal distension. It was being passed on from pediatrician to pediatrician. Then we did an ultrasound. It had shown a huge tumor inside the abdomen. So sometimes we miss these conditions. And if you have fever, always go for a complete blood count and ESR. The lessons learned here are, if there is an abdominal pain, give it some importance, ask the history, look for some red flag signs or danger signs, and if necessary, please investigate them and don't tell them it will become better by itself. And if you have a surgeon near you, if you feel it is a surgical condition, especially if they have bilious vomiting and abdominal distension and hematochezia, ask for a surgical condition. These are some lessons that we are trying to learn from this small session of abdominal pain.
Thank you, sir.
Thank you, sir.
This is the target sign on the ultrasound which can easily make out the condition. Next is a 4-month-old female child brought by the mother with history of fever of 2 days, incessant cries since morning, fast breathing. Mother has given paracetamol 4 ml 6th hourly, following which the child developed vomiting and lethargy. This child on evaluation was found to be afebrile, airway was open. Initially the child was lethargic, respirations were normal, cardiovascular, only signs of shock with hypotension. It was pain responsive and the blood sugar was 40. So what is your impression now?
So, good morning, sir. So, from the history, the child has been given paracetamol 4 ml 6th hourly, which is a high overdose. Actually, they have misinterpreted 0.4 ml as 4 ml and has given high dose. The child is in the OPD in emergency room with the features of impending respiratory failure and the hypotensive shock, and also there's a hypoglycemia also noted in this child. So the child was treated initially with oxygen with the JR circuit and further managed with mechanical ventilation, and hypoglycemia was corrected with the dextrose bolus, and after that, after stabilization, we could not do paracetamol level for this child, so we have straight away started on N-acetylcysteine. Meanwhile, we are ordered for investigations. So investigations give clue about the status of the poisoning, even if the paracetamol levels are not available. So liver function test here comes. So SGOT and PT levels are raised. SGOT is the earlier one to rise, and INR also raised for this child.
But the baby expired after 8 hours after admission in spite of the treatment due to acute fulminant liver failure. Who are the patients you have to assess
So if you
for paracetamol overdosage?
Sir, if there is an acute ingestion of 10 times the therapeutic dose, that is more than 150 milligram per kg, you have to suspect paracetamol poisoning. And also sometimes there will be repeated supratherapeutic dosing, more than 90 milligram per kg per day or the few consecutive days. It is also, the child also required admission. And sometimes there will be ingestion of unknown quantity. They may have accidentally drink the whole bottle. So deliberate self-poisoning. Sometimes symptomatic child, no history, the child is brought with the symptoms of acute liver cell failure. Sometimes we can receive.
What is the mechanism and stages of toxicity?
So paracetamol toxicity results from due to the formation of the metabolite NAPQI, which is N-acetyl parabenzoquinonimine, which is normally detoxified by the glutathione. What happens is paracetamol poisoning leads to depletion of the glutathione stores. So NAPQI will cause hepatocellular necrosis. During the initial first 24 hours, the child will be asymptomatic or non-specific symptoms only. The child will have nausea, vomiting, and malaise only. Over the next 24 hours, there will be rapid course. There will be abdominal pain, upper abdominal pain, especially. And if you have liver enzymes elevated in this period only, it will start rising. And the peak enzyme level will be around 3 to 5 days. So you have to suspect early and you have to treat it.
What is the management?
So if the child is received within 4 hours, we can go for gastric lavage or sometimes decontamination with the charcoal, especially 1 gram per kg, maximum of 50 grams. If the child is received within 8 hours, we can go for N-acetylcysteine. So N-acetylcysteine is a precursor of glutathione. If it is given within first 8 to 24 hours, it will be well and good. It is given the dose of 150 milligram per kg as bolus initially, followed by 50 milligram per kg over the next 4 hours, and next 16 hours around 100 mg per kg. For single acute ingestion, we can have paracetamol values. If we have serial values of paracetamol, we can use the Rumac-Matthew nomogram by plotting the paracetamol levels against the paracetamol ingestion hours. So x-axis, we can see the ingestion of paracetamol hours over the 4 hours, 8 hours, 16 hours. Meanwhile, the values of paracetamol level. So it can be plotted, and if it is in the poisonous toxic dose, you can start in acetylcysteine. So sometimes we have to go for liver transplant also nowadays. So what is the indications? It is when the pH is less than 7.3, INR is more than 6, serum creatinine is more than 3.4, or grade 3 or grade 4 hepatic encephalopathy. So the lessons learned from this is paracetamol overdose and poisoning is not uncommon. We had 2 cases over the past 6 months in our institute. SGOT-PT are the earliest one to rise, especially SGOT is the earliest one to rise. And N-acetylcysteine has a good value if it is given within 8 hours of intake. One important thing is knowledge about the dosage and preparation, about the strength. It should be insisted to the parents. Nowadays, various strengths are available. 500, 5 ml, 1 ml, 150. Government setup itself, 1 ml, 150 is available, 1 drop. So you have to be very cautious in insisting the dose also.
Thank you, sir. All of you must understand that paracetamol, though a very safe drug, you must have seen even in yesterday's presentation, Dr. Puvaligi was talking about it. And today again we are talking. That shows that I had a patient who had come, both the parents were doctors, but not pediatricians. And for a 7-month-old baby, they are given 10 ml of paracetamol because they did not hear, they didn't want to cross-check again with the doctor about the dose. And later the child developed vomiting and had to be rushed to the emergency, and they called up over, and they I told them that the dose was high and immediately it has to be treated. So what I'm coming to tell is that even doctors have known to make mistakes because there are so many preparations available in different strengths. And the best way is to cross-check with them with the dose or whichever syrup they are getting. My senior colleague, my friend Dr. Thangavelu, in his OP, I learned from him. He actually will call back the patient into his OP and ask them to show the bottle, tell the dose again, and make sure that they have understood correctly. That is the precaution which all of us should follow. Thank you, sir. Next is a 2-year-old boy who was brought with pallor, bruising, petechiae, and epistaxis. The bruising was first noted on both lower extremities 3 weeks prior following a fall that resulted in a minor lip laceration which healed spontaneously without prolonged bleeding. The child remained active until the day of admission when the parents noticed lethargy and pallor. On the day of presentation, he had 2 self-limited episodes of epistaxis. For that, they brought the patient to the doctor. On examination, the child was pale, lethargic, the airway was maintainable, the respirations were normal, the cardiovascular was normal, the child was awake, lethargic, tone reflexes were normal, and on exposure the child had a oral mucosa which was dry and pale. Dried blood was noted on both the nares. Extensive ecchymosis observed over the upper and lower extremities. Petechiae were also present there, but there was no evidence of any lymphadenopathy. Dr. Luke, sir, what is your impression now?
So a child which comes with a bleeding, the utmost first point is make the child lie down with head slightly raised and check what kind of bleeding are we have, whether it is internal bleed or an external bleed. Here we have a classical history of a bruising and a bleeding from the nose, that is epistaxis. So quickly we do the ABCD as what sir has told, as per the diagram we do that, and then we quickly try to find out the reason. So what common reasons we have? Bleeding and having an ecchymosis. We do a quick rapid clinical examination, we find ecchymosis. We mostly go for thinking of a coagulation defects immediately. So widespread petechiae with a bleeding and quickly examine the abdomen. Organomegaly, bleeding with organomegaly, without organomegaly. We all know very well, without organomegaly goes towards ITP, with organomegaly goes towards our lymphoproliferative malignancy. So quick rapid examination, then checking for the pallor, a disproportionate pallor will again give us a clue, coagulation defects. And then quickly we do a bedside counts, a CBC. A CBC will give us a very important clue of what kind of pallor we are. Is it a red cell aplasia? Is it a thrombocytopenia alone? Then we do a very good peripheral smear morphology. It's like our horoscope, like our jadagam. So we do a very rapid peripheral smear with a good pathologist, with good eyes on microscope. We can easily detect 90% of diagnosis we can have it. So we have bleeds, we have platelets, we examine the platelets, and the dengue season again we have to be careful. So platelet, qualitative defect, quantitative count. Then after that we can, if available, we can do a prothrombin APTT depending upon the findings. And then when everything is normal, we go quickly for a bone marrow aspiration. So in the peripheral smear we can easily see, and then we can also see in the bone marrow when there is increased megakaryocytes, of course points towards ITP. So a little bit of findings. Then there is a bleeding with all 3 cell lines being low. We think of a marrow aplasia, aplastic marrow. So a complete bed count will give us an idea of the pancytopenia. A peripheral smear, of course, as I told you, will give a pancytopenia with blast cells. Then BMA will tell us, bone marrow aspiration, and biopsy will tell us whether we are dealing with a lymphoproliferative malignancy or not. Less than 5% blast are normal. Then as per the diagnosis and etiology, we can initiate the management. So quickly you make sure the child does not go for a hypotensive shock. So quickly you transfuse the packed blood cells or platelets as in when necessary. And when we find an increased megakaryocytes, quickly we go for IV methylprednisolone or an IVG as per the indications warrant. So a bleeding child, a rapid quick assessment and a very good bedside clinical examination and a bedside laboratory examination is a must to find out the causes for the bleeding. Thank you.
What are the lessons learnt in this child?
So lessons learned, as you say, a leukemia, a night pain, a night limb pain is classical of lymphoproliferative malignancy. The mother will come and tell, midnight, 2 o'clock, a child screams by catching the shin, the tibia, the bone pain, a classical of an acute lymphocytic leukemia. So that gives a clue as to how it can differentiate from the malignancy. So learning points, again, as I told you, a good clinical examination, thorough examination, and good ABCD examination, then having a good laboratory setup with a good physical examination will give us a clue towards a diagnosis.
Thank you, sir. Next, we have a 15-year-old girl studying in the 10th standard, came with vomiting of 3 days and given some medicines for the vomiting and had mild abdominal pain. On examination, the child was clinically normal, but investigations, what are the investigations you plan, Dr. Sivakumar?
Yes, sir. So this child with vomiting, so commonly food poisoning in this age group commonly we think of. Apart from that, we can go for, if it is not due to gastritis, we have to think of any UTI or any hepatitis or the common things we have to rule out. So in this case also we have ordered for the above investigations. Next slide, sir. But surprisingly,
when do you suspect child abuse?
So for surprisingly, this child for urine routine was normal and liver function is also normal, but ultrasound abdomen revealed an intrauterine pregnancy of 8 weeks gestation. So regarding suspicion of sexual abuse, there are many number of presenting complaints. Common things are genital injuries or anal injuries or genital infections, urinary tract infection, abdominal pain, constipation, behavioral problems, and also now vomiting also you can add. So
is it only the tip of an iceberg which gets reported?
Yes, sir, definitely. We have a lot of undisposed cases because young children don't have the vocabulary to express what's happening. They feel embarrassed to speak. They feel ashamed to speak. They are unaware that what the experience is a sexual abuse actual. Then there is many social taboos and stigma there. Most important is about the fear of media. The parents are fear about the media. So
what is POXO?
So POXO is Protection of Children from Sexual Offences Act. It is 2012. Any sexual activity with the child below 18 years, whether boy or girl, is a crime. The sexual offences include penetrative sexual assault, non-penetrative sexual assault, or sexual harassment, or use of a child for pornography. There are many sections, 46 sections around.
What are the guidelines we need for medical doctors?
So there are many guidelines given. So all the faculties, whether in government setup or private setup, they have to provide first aid and immediate treatment free of cost to the victims of the sexual offences. And we have to report all the cases. It will be mandatory MLC. So report it to the police, and failing which we can go for punishment or even fine.
What are the lessons learnt in this?
So healthcare professionals must know about the mandatory reporting of sexual abuse in children, and the lapse in reporting will lead to punishment, whether in imprisonment or fine. And boys are equally vulnerable for abuse as well as girls. The important treatment is psychological support should be given apart from the medical treatment and medical legal procedures.
Thank you, sir. The last case, a 3-year-old female brought with 5 days fever at around 11 a.m. Child had vomiting, abdominal pain, but child was afebrile, heart rate of 120, respiratory rate 24, auscultation of chest was normal, abdomen was normal. Child prescribed some antiemetics and sent home to get admitted if the pain gets aggravated. Child brought to the hospital at 5 p.m. Airway was maintainable, tachypnea, tachycardia, evidence of shock, CRT prolonged, lethargic child, afebrile. Now the status is hypovolemic, hypotensive shock. Intervention as the child is in shock, airway breathing taken care of, and the IV access, normal saline boluses were given, but shock persisted, inotropes were started. Child developed bleeds and had a serious course in the PICU and developed complication of DIC and AKI, needing CRRT before recovery after 1 week. What are the lessons learned in this? We should evaluate completely as per the BALS. CRT was not checked in this child. Core peripheral temperature not checked. BP was not checked. And being an endemic area for dengue, we should always suspect dengue even if the child is afebrile. And do the simple diagnostic tests like PCV, platelets, NS1. Advice on the urine output monitoring, pre-hospital stabilization as the child can progress from hypotensive shock to death very soon. So we should assess early, and in dengue endemic areas, we should always remain vigilant. Lesson learned is that we should do the initial impression, primary assessment as per the ABCDE, secondary assessment with focused history and focused examination. Now final messages from our panelists. Professor Luke, sir.
So the cough isn't just a cough. Anyone comes with a cough. So what type of cough? A night cough or a brassy cough, or any foreign body also can present like a cough. So age dependent cough, less than 1 year, 1 to 3 years, 3 to 5 years, 5 to 7 years. Again, take a thorough history. What time is the cough, even before feeds or after feeds, whether it is a night cough. So we have so many things, foreign body, gastroesophageal reflux disease. Then we have simple pneumonia cough, we have allergic bronchitis, whoop. So a good clinical examination is extremely important, where our next speaker, our DME sir, is going to tell about the art of pediatric examination. A classical pediatric examination is always very, very important, because a physical examination is very important and history taking is also very important. These two is slowly going down, I think, nowadays, but these two always play a very golden role in getting the clinical examination, and with a good imaging. These three will be most sufficient. Thank you, sir.
Thank you, sir. Next, I asked Professor Ramanathan, sir.
Already discussed abdominal pain in children. We just have to look for the red flag signs in the history and also in the physical examination. And if it is functional or organic cause, just 2-3 things that we have to think. And please use ultrasound abdomen and urine routine liberally in your practice, so that you can pick up a lot of severe causes for abdominal pain.
Message from Professor Sivakumar.
Viral fevers are the most common, but always rule out other problems also. Rule out UTI, and in community setup, you have to think of dengue and rickettsial infections also. And if it's prolonged, means you have to go for other workup also.
Thank you, panelists. I conclude this. Common problems are not always simple, and always follow the PALS guidelines, evaluate, identify, intervene. Thank you all for the patient hearing.
Thank you very much, sir. We have a question from the audience. Before that, I'd like to inform the delegates present here that this is the QR code that we are displaying. Delegates can scan this QR code in order to pose questions to the speakers onto a platform where even the speakers can reply directly to your questions. Now we have a question for the panelists from Dr. Kausalya. Adrenaline injection should be administered only in the thigh for all age groups, or can it differ in adolescents?
The best place, as I told you, many studies have shown that that's the best place to give. Vastus lateralis is the muscle which has got a good vascular supply. So anterolateral aspect of the thigh, that's the best in almost all age groups. Of course, we are talking only about children now.
Thank
And
you, sir.
never give intravenously, subcutaneously. It has not been recommended and it has been found to be not so effective as deep intramuscular, that too especially over the vastus lateralis. Of course, you can give over the thigh, but from studies, lateral aspect, vastus lateralis is the best site to give.
Thank you, sir. With that, we come to a conclusion of the panel. On behalf of the organizing committee, we extend our heartfelt thanks for your time, effort, and generosity in sharing your knowledge. Kindly accept a token of gratitude on our behalf. We request Dr. Annamalai sir to present tokens of appreciation to our panelists. I then request Dr. Ramanathan sir to kindly present our moderator with a token of gratitude. Thank you all. Moving forward to the next session, it is a great privilege to introduce the chairperson of the next session, Dr. Nedunjelian, who is the head of research and academics at Mehta's Hospital, Chennai, emeritus editor-in-chief of the IJPP, and retired professor of ICH. Sir can be called the doyen of pediatrics and is a great teacher and mentor for most of us here. We welcome you onto the stage, sir. I would like to introduce the first speaker for the session, Dr. A. Somasundaram sir, President-elect of IAP-TNSC 2025 and IAP Chennai 2025, a dedicated pediatrician, academic leader, and recipient of the IAP Fellowship in Oration Award with vast contributions at state, national, and international levels. Welcome, sir.
Respected Chairperson, Professor Nedunjelian sir, respected dignitaries, teachers, seniors, and my dear friends, a warm good morning to you all. So with pranams to my alma mater, my UG College Tirunelveli and my PG ICH, and my teachers during my post-graduation of G7 ward in ICH, and Professor G. Kumaresan and Professor Jayantri, who created interest in pediatric neurodevelopment in me. I usually start the talk with these words from Ronald Illingworth. I regard developmental examination as an essential part of everyday practice with a minimum equipment in an ordinary mixed clinic, not in a special room, not at a special time, not with a special equipment or by a special doctor. So it is me, you and me, who has to do the developmental screening or assessment for the children who come to us as we do a nutrition counseling or an immunization advice. So the neurodevelopmental problems are becoming a new morbidity in childhood. This is from American Academy of Pediatrics that conquering all the gastrointestinal and infectious diseases, now it is the neurodevelopmental problems which are becoming increasing the new morbidity, and it is the time for every pediatrician to get updated on finding out the neuro. So there will be children in every classroom with these types of learning difficulties. So they land up with poor school performance. So whenever you come across a child with poor school performance, means that the child's achievement is below the expected for the given age for his cognitive skills and his level of schooling. So what is the magnitude of the problem? A poor school performance in Indian children in the age group of 5 to 8 years is almost 10%. So if you have a classroom of 100 children, 10 children are not adequately studying in their classes. In this, the prevalence of learning disability is about 9.6%, which is about, in a class of 100 children, 10 children are having learning disability. This is a statistics from India also. The beauty is 52% of school teachers have poor knowledge on identification of learning disability. So the main problem of poor school performance, what will be there? The child will have a low self-esteem, the child will have a negative impact on social functioning. Usually they are branded as lazy. No, you are not good at studies or something like. It will affect the school completion and higher education and finally employment and marriage. So how will this school performance present with? It will present with a failure in examinations, not writing down the notes in the classes. The child will forget. Mother will say, I see, next day school. The child is not concentrating in the studies. Reluctance to school. Every day the child will come out with some various problems, headache or stomach ache or something like. Low self-esteem, behavioral problems. Because the child is not able to perform well as his peers, he will start behaving badly in the school and in the class. So what will be the etiology of a poor school performance? If a child is not performing well in the school, it is like a fever. You don't treat paracetamol, only give paracetamol for about 7 days or 8 days for fever. You find out what is the cause for this poor school performance. Likewise, a child with poor school, getting poor marks, you should always find out the etiological cause, why this child is not performing well. So the factors could be in the school, it could be in the home, it could be in the child, or it could be in the environment. So what will be the child factors? The child can be a slow learner. Probably the IQ is between 80, 70 to 90, because we have more than 90, we call it as a normal IQ. 70 to 90, the struggle with the cope up in the studies. Or the child can have an intellectual disability, meaning the older terminology of mental retardation, can have a mild or a moderate ID, irrespective of the etiology, can present with academic failure. Neurodevelopmental disorders, specific learning disability, ADHD, developmental coordination disorder, cerebral palsy, developmental language disorder, autism spectrum disorder, all can present with. The important chunk of problems which you should not miss is the medical factor. Nutritional deficiency. The commonest one is anemia. A child with anemia cannot perform in the school. The child will be attention deficit will be there. The child will not have a proper sleep, nutrition. Vision problems can be missed, and this can cause very poor school performance. Hearing problems, hypothyroidism, chronic illnesses, epilepsy treatment, obstructive sleep apnea, very, very important cause. A child with adenoid hypertrophy will not be able to sleep well in the night. The next day the child will not be able to concentrate and can land up with poor school performance. All these factors are common in this child which should be picked up. School factors, being bullied, not getting along with the teachers, frequent change of school. Father goes from Chennai to Pune, there is a change in the school. Frequent change of curriculum or the board. One parent says, no, CBC is good, not good, you go for IGCSE, immediately parent that changes the school. More extracurricular activities. No, my child is very good in cricket. He should spend more time in cricket, he should go for all the competitions and those things, etc. School factors, family factors, poor socioeconomic status, unsatisfactory or unsafe home environment, poor motivation to the study. The parents are not at all. The parents think now, building money is the one thing which I can give to my child. They are not concentrating on the studies of their children. Chronic neglect, sexual abuse, dispute among parents, losing a family member, all these are family factors. Environmental factors, the child is not able to read. The mother or the grandparent will always have a noisy TV, noisy environment, screen time, gaming addiction, internet addiction, all these are the environmental factors. So looking into the factors, look out for physical factors. If there is no physical factors, look at IQ, which is an intellectual disability, or look for whether there is a poor motivation, or if there is an ADHD or not, or there is an emotional conduct or a psychological disorder or not, or finally, it can be a specific learning disability. So the things which should not miss are intellectual disability should not be missed, neurodevelopmental problems, learning disability and ADHD should not be missed, medical factors should not be missed. In this, I am going to look into how we can go ahead with the learning disability. So specific learning disability is an invisible handicap. The other things are all very, very visible, which you can easily pick it up. So this is the dyslexia definition. Can any one of you read what is this definition of dyslexia? So this will be the way a child with dyslexia will look into the notebook or the textbook. So definition is, dyslexia is trouble with words, a disorder in which the psychological process of using the spoken or the written language, where there is an imperfect ability to listen, read, spell, or do the calculation. Or in simple words, the child is having difficulty to read or spell, read, write, or calculate, despite conventional education, normal intelligence, normal socio-cultural opportunity, proper motivation, and without any sensory deficit. All these have been ruled out, and even then a child will have a normal IQ. Even then the child is not able to perform, you should think about a learning disability. Incidence, 11.8% of children. So dyslexia, it can affect 80% of children with the learning disabled can have this. These are the various forms of dyslexia. I am not going into the detail. The core deficit is the phonological awareness. A child is not able to go into the phonology of what is there. The most of the children with dyslexia will have a reading problem. How does this manifest as? Reads very slowly, constantly loses place, missing out lines or reading the same line again, therefore needs to keep the finger below the line being read, hesitates to read loud. When you ask him to read, he will just open the lip and read. He hates reading and refuses to read. This will be the manifesting of a reading problem. So, but whenever he is asked to read, he will read it as B-E-G, but he will pronounce it as bad. Ignores the punctuation, often confusing the meaning of the text. Confuses with the alphabets. Whenever you ask him to read, B will be read as D, U will be as N, W as M, and confusion in the words. On will come as no, was as saw, felt as left, act as cat, everything will be there. There will be an omission. Bet, instead of belt, he will read as bet. Went as wet. Play as will be as played. Addition will be there. Use, if you ask him to read use, he will read it as useful. Substitution can be there. Instead of home, he will read it as house. Mispronounces some words. Instead of held, he will as help, as he will as held. Portion, position, horse, house, animal, aminal. All these are the various things which a dyslexic child, that is a reading disability child, can have. Dysgraphia, that is a writing disability. You can have, there is an abnormal grip. He will go start from this part and he will go upward like that, abnormal grip. Notes are incomplete, do not make any sense. Poor in remembering certain alphabets, are unable to copy from the board. Shows mirror imaging, P as D, P as Q, B as D, write letters in the wrong order. If you ask him to copy from one book to the other, the original word will be Simon, but he should have written as S-I-O-M-N. The original word will be what? He should have written as W-T-A-H. Reverses the letter and the words. Inverts the letters, N as U, W, M as W, D as P, P, all these are told. Omits the letters, that is the limp instead of, limp has been written as lip, string as sing. Adds letters, everything will be part of a writing problem. So this is a 7-year-old writing ABCD. See, there are various, the incomplete, the handwriting grip is not good. The child is having reversal of letters. Even the name, the child is not able to write it normally. So the child will be having a weak in punctuation, capitalization, and ineligible handwriting. As I told you, the child will start in one corner of the page and go downwards or upwards. I am a boy, I like to play. So this is there is no concept of punctuation, where to stop and where to put the full stop and those things. Poor organization of ideas and structure. The owl was a bird. This was the thing which the child was asked to write. But see what he has written. T-H, has changed into saw. So these are very, very small mistakes which the teacher also ignores, the parent also ignores. So finally what happens is, when the volume of the studies increases by about 7 years or 8 years, they land up with the problem and then they come. So this is the child writing something which has the father has, the school has asked it to write. I am a school. See, the teacher has written, punctuations are poor, limited ideas, needs to be organized, spellings to be reduced. So all these are there. If a child is having dyscalculia, this is very minor, but many children with dyslexia can have dyscalculia also, or present exclusively with dyscalculia also. Use fingers for calculations even after 8 years. Difficulty with multiplication tables. Confuses the basic operations, plus, minus, into, division. Has difficulty to understand statement problem, deciding on operation. Understand the concept of calculation but cannot work up on a paper. Will not be able to do that. So this is the child has written well in the fair page, that is 544 plus 432 is 677. When the rough column, it is 967. When it gets converted into the normal fair page, the numerals has been altered. So reversing the digits, 12, 21, 16, 16, 1008, if the teacher asks to write, the child will write 1008. If the child asks to write 450, it will be 450. So lack the knowledge of carryover, everything will be problems with the dyscalculia, dyspraxia, very rare, poor posture, clumsy, poor handwriting, lack of awareness of the difficulty writing, speed writing and handwriting problems are there with the dyspraxia. So
certain
finally,
pattern to it. Have you noticed that?
Pattern?
so this is a concise of what I have spoken in the last 10 to 15 minutes. So most parents think that this is the problem, but actually this is the problem, you will not be able to read. Now coming to the major comorbidities what this learning disability can have. This learning disability can be associated with the gross motor skills, language problems in the initial period, behavior, memory, attention problem, academic skills, social development. The child will not socially interact with many people. But the point is, 30% of children with the learning disability will have ADHD. If you correct that ADHD itself, the child's attention will improve, the child will learn more. So you should pick up this comorbidity in this learning disability at the earliest. Now coming to diagnosis. How am I going to assess this child? So assessment is not very simple by a school teacher or by a normal pediatrician. The pediatrician can take a clinical history, will do a physical examination, exclude the medical causes. A counselor will rule out whether a family problem is there, a school problem is there, or a home problem is there, or an emotional problem is there in the child. A psychologist will first do an intelligence scoring. That is a very, very important factor, because this child with learning disability can even say about the flags of 100 countries, the presidents of 50 countries, everything he can say, a 10-year-old child, but he will not be able to read from the book and then tell it something. So that's the problem. So IQ will be even about 110 or 120, but the problem is there in the learning disability. The special educator will find out the academic achievement. So only two important assessments are needed. One is the academic level achievement and IQ assessment. Never entertain a diagnosis of learning disability in a child with normal intelligence quotient. That is a very, very important point. So child psychiatrist, if needed, will treat the ADHD, will confirm the diagnosis of ADHD if there is a need for medical management or a drug management. A drug is not going to do wonders in learning disability except for a ADHD problem. A role of a pediatrician, as I already told you, inquire the child's performance during the examination, because mothers will not say, என் குழந்தை படிக்க மாட்டேங்கிறான் சார், எந்த பீடியாட்ரிஷியன் சொல்றது ரொம்ப very, very a tough job. So you should always find it out, and you should have a right person, as I already told you. So this will be the flow chart. Find out the academic psychiatrist, academic difficulty, emotional problems, hearing, vision, pediatrician, cognitive assessment, academic achievement, and you can have a case conference. So as I told you, this will be the thing. Remediation, if a child cannot learn the way we teach, we should teach the way they learn. So that's the very thing of remedial education. A learning disability cannot be cured or fixed. It's a lifelong challenge. So however, with appropriate support and intervention, people with learning disabilities can achieve success in schools, at work, at relationships, and in the community, which is very, very essential for these children. So first, find out the core deficits, counseling to bring down the negative impact of the child, treat the associated comorbidities. So this will be the management team. A developmental pediatrician, a psychiatrist, psychologist, occupational therapist, speech language pathologist, school teacher, behavioral therapist, everybody will be there. So this is the management outline, as I'm not going to go into that. So find out the academic intervention should be there. Individualized education plan should be there with the modifications. Remedial education is giving a process to help the child acquire the age-appropriate skill in all his foundation areas which are required for attaining the knowledge at his pace and at his potential. That is remedial education. Don't confuse remedial education with the tuition and special education. இதை பற்றி சொன்ன உடனே many parents will ask, அப்போ டியூஷனில் சேர்த்துடலாமா? Tuition is not equivalent to remedial education. Tuition is ஸ்கூலில் சொல்லிக் கொடுக்குறது அப்படியே ஒரு 5 பேருக்கு ஒரு டீச்சர் சொல்லிக் கொடுக்குறது is tuition. Special education is a place where the child's IQ is very bad. So you are going to put him in a special education. Here, the child needs only a remedial education. This is something different. The same subject is taught in a different way by the remedial educator. So early identification, as I told you, is the key. Find out, ask for the language delay at the earlier period, whether at 4 years, whether the child had got mirror imaging and those things. You should pick up a learning disability before 7 years. not after 7 years. That's the very thing. We have very many options for these children who have been provisions are there, 1 hour to, or 25% extra time in public exams. All the boards have this as this in India. No mark reduction for grammar and spelling mistakes. Can use a calculator in the max examination. Exemption from writing one language. Can use a scribe or type the answers on a computer. 20% grace mark. So if you pick up these children, they can be able to get a certificate. LD is considered as a disability. In 1995, it was not considered as a disability. Now in 2011 amendment, the rights of persons with disability, it has been included as a disability, and children can get these benefits. People with like Albert Einstein who are learning disabled, who have done wonders. Probably if this child is not able to read and write, you can put it in a different way. Make him as a guitar master. He can go perform in world-class plays or concerts. Make him into a pilot. So there are other various intelligence options which you can make this child. So the final take-home messages will be, specific learning disability is an important cause for poor school performance. As I already told you, 10% of children will have learning disability. Rule out other medical and neurodevelopmental causes before going for assessment. It's a lifelong problem and no cure and remediation is the key. Treat the comorbid conditions. So this is only a small move to find out the ability in the disability. Don't brand these children as disabled. You should find out how this ability, what ability they have in their disability. Never label them. Enable them. Do the maximum and enable them. And thank you, the organizers for this opportunity, and thank you one and all for your patient hearing.
Thank you very much, Somasundaram, for covering almost all aspects of learning disorder. So we need to actually be aware of these conditions and able to pick up day-to-day clinical practice so that they will be actually put in needed remediation procedure, and we can help these children also to become one other Albert Einstein. Thank you very much.
Thank you, sir.
Any questions, ma, from the audience?
Not at the moment, sir.
No,
We will
no.
recheck at the end of the session.
Thank you. ஈன்ற பொழுதில் பெரிதுவக்கும் தன்மகனை சான்றோன் எனக் கேட்ட தாய். இங்கே அந்த மாதிரி தான் இங்கே 2 children. ஒரு child already heading the highest post in the IAP. He is going to actually become the president of IAP-TNSC next year. Now he is the president elect of IAP-TNSC. And the other child, he is the director of medical education now. Maybe there won't be any proud situation more than this to see a student becoming occupying in the highest position where we are actually here. Medical director, the director of medical education is going to be the highest post in the state he is holding. I am very proud of these children, 2 children. Now, and coming to this lecture, maybe this is going to emphasize the importance of clinical examination. Almost in this era, we have actually, from the beginning, very beginning, Dr. M. Ramasamy, when he started actually insisting that AI alone is not going to be the answer in the future, we need to have a clinical skill based on that. It should be taken as a supportive thing, not as a primary one. You should not fully rely on or fall prey to AI. That lesson is being carried away through maybe one other lecture we heard that the clinical examination is going to be to reiterate, none other than our Director of Medical Education. He is actually going to deliver his lecture. We will listen to him. Open now. The platform is for you, Tharani.
Sir, very good morning to all of you, and my sincere thanks to Professor Nedinian sir and PRC sir and other seniors professors who have come for this conference. And it's a great opportunity for me to share this topic and why I have selected this topic. Because post MBBS, many students has got an hesitancy in selecting the topics. When you ask them which specialization which you want to do, there will be a little bit of hesitation in taking a pediatrics, because most of the time either the child is crying or the mother is crying. So when they come for a consultation, it's very difficult to get the complete examination in a stipulated time. So that is why this topic is chosen. Once you know the knack of examination of pediatrics, it's very good. In a golden minutes, you can arrive at diagnosis and you can make a change in the life of this child. The first is My topic, I'm going to cover how the environment to be in the OP department as well as in the inpatients of pediatric ward, and what are the initial steps, and how to prepare yourself, and what are the prerequisites for the examination. How history should be. It should be a focused history. Many times in the examiners get bored because you try to give most of the negative history rather than giving a focused history. So focused history is very important rather than giving the negative history. Finally, it comes in examination. In the pediatric examination, we need to concentrate inspection and observation. 70 to 80% of your clinical signs and symptoms can be easily elicited by your inspection alone. So the remaining 20% only needs examination. If you learn the technique, then it is very easy. So this should be your examination. This is the outpatient department. Child-friendly environment should be created. See, in 2014, when I was heading the Department of Pediatrics at Vellore Medical College, I established a child-friendly outpatient department. This concept you learned in Malaysia and as well as in the United Kingdom. Wherever you go, you know where is the outpatient department of pediatrics, where is the inpatient department of pediatrics, because all this children-friendly park will be there, and toys will be there, and the coloring of the environment. All those things are very important. So at the same time, the color should be a pleasant one, and the area should be very, very comfortable one. Once the child enters into this room, the child will try to explore, and the child will be very friendly, and the child definitely will stay with you throughout the examination. That's why I put this slide. And after establishing the child-friendly concept, now how many of you know about the assembly announcement? In the assembly 2025, our Honorable Health Minister has announced that 11 medical colleges are going to have child-friendly outpatient department as well as inpatients. So for that they have allotted money, and I've already sent the proposal to the government, and they started working in Tiruvallur Medical College and other places as well. So this is very important. It should be a quiet area, comfortable place is important, and minimal physical distance should be. Immediately lifting the child, putting the stethoscope on the stethoscope over the chest, all those things should be avoided. And especially when you handle adolescent children, male or female, privacy is very, very important. And you should make them very comfort. That is very important. And systematic, gentle approach is very much needed, especially when you handle pediatric children. And when you receive them in a very warm welcome is very important. You can see the doctor smiling, and make them to sit in a comfortable position, and child also will be comfortable without separating the child from the parent. That is very, very important. The second thing is, the art of examination is, it differs. It cannot be common for all age group. For example, if it is a newborn, the newborn should be examined in the mother's lap. If it is a toddler child, or if it is a preschool child, and you have to bend down to that child's level. And then if it is a sleeping child, and sleeping child should not be disturbed. That's a golden opportunity for us to examine the cardiovascular system. You do the heart examination, auscultation, and do the even our respiratory system. You can put your stethoscope over the back, and then see whether the breath sounds are heard or not, and then whether added sounds are there. In the same way, if you are examining the adolescent girls, and make sure that you are keeping a nurse along with you. If the child is not comfortable with the parents, you should gently have to tell them that the parents should be away from the examination site. But at the same time, you should have a female nurse along with you. And when you are taking examination of the adolescent boy, the important thing is see, I think I already told you, alter your vocabulary according to suit the age of the child, especially in the toddler age group. And approach a child at the eye level. Eye level should be there, and kneel down to the level, and do not examine the child in a standing position, or do not take history in a standing position. That is very important. And confidentiality is very important, and consent to sensitive topics. For example, if the child has got an habit of smoking or alcohol, you cannot directly ask, do you smoke or do you take alcohol? That is not the way to ask history. Just in that way, you just change the phrases, and you can tell that in your age group, children normally smoke. Your colleagues also you would have seen. So in that way, if you are anytime you have any habit of taking alcohol or smoke or anything like that, If you put it in that way, they will definitely accept it. And then you will come out with the history, that the history of smoking and other things, and easily you can understand. The same way, and even health and the sexual health habits also you can elicit. And if the child has a suicide tendency, that also will be elicited. HEADS is an important topic often asked in the UG examination. HEADS is nothing but home environment, whether the child is living in a separated family, or say a single parent, or any alcoholic parents, or a drug addicts. And the educational activities of the child should be explored in a gentle way. Again, activities after the school hours, what the child does, whether the child goes to. For that also, again, you have to ask them in a simple way or in a very modest way. You have to ask whether in our age group that normally they go to pub, what about you? That is how we should put a leading question to the child. And sexual health, I already told. And prerequisite for the examination is, whenever when you see a child with an abnormality in the face, immediately don't come to any conclusion. Just ask the parents and ask them to come into our clinical or examination suit and see and compare with the child. If it is similar, then exclude that it is not a dysmorphic child. Genetic constitution is the very important thing. Only when there is an abnormality, again you have to put a question to the mother, and you have to ask whether the mother is convinced that the dysmorphism or not. And begin the examination always from the periphery, not to directly to the heart or respiratory system or neurological system. Start with the peripheral examination, place the child's hand in your palm and compare the color of your palm and the child's palm, and then turn the fingers and look for any clubbing, chylonychia and other pallor and other things. And try to avoid aggressive toys. Aggressive type of toys or anything which can hurt the child should not be kept in the examination hall. So pulse, normally radial pulse, it's very difficult to examine in a pediatric age group. You go for a brachial pulse, compare with the other arm. And if there is any abnormality, then then you can compare with the femoral and other things. And if it is an older child, radial pulse is okay. And especially mouth, cyanosis, ulcers, and macroglycia. When you find any node, when one side also, it is mandatory to examine other sides. A generalized lymph node examination is mandatory. And if you are convinced that if the child has got a generalized lymphadenopathy, then you have to subject the child for complete examination rather than asking for a high-end investigation in the first site itself. If it is a single node, then you just do a CBC and start antibiotics and ask the child to come for a review. And if it still persists, then you go for biopsy and other FNAC and other form of investigation. And when you see a food anomalies, club food and other things, good that now government medical colleges has a DAC, District Health Intervention Center. At birth itself, all the congenital anomalies are excluded. In that way, the anomalies can be easily. And motor, this is a gross motor and fine motor and developmental milestones. The developmental milestone, it is only an observation. See, just imagine if you get a child with a Down syndrome, or if you get a child with autism, is it possible for us to do a complete chronological order of a developmental milestone? That is not at all possible. So by observing the child, you just see how the child is jumping, whether the child is able to climb upstairs, and all those things you can note down. And the principle behind the developmental milestones for gross motor is it is a cephalocaudal in progression. After attaining the head control, only the spine control will occur. And then after that, it progresses to the child standing with support and walking with step, all those things will come. In the same way, fine motor vision, if you want to do the fine motor, the eye should be intact. So if the child has got a good vision, then only the child can do all the fine motor activities. Without assessing that, immediately asking the child to do or drawing, the scribbling and all those things is not at all possible. In the same way, if you want to assess the language, hearing should be intact. These are all the basic principles when you do developmental milestones. And the social and emotional. So why the child is able to have a small social smell, able to recognize the mother first? Because the newborn baby has got hypermetropic eyes. So the child, during breastfeeding, feeding time, it fixes the mother's face. The distance between the mother's face and the baby is almost 45 centimeters. So that is constantly the child is having the presentation of the baby. And finally, the child is able to recognize the mother first, and the social smile also occurs earlier. The same way you can do other developmental milestones. For that also, you need only observation. Many times you can get all the developmental milestones in a minute time. So when you're starting the head to foot examination, you start the examination with the pupillary reflex and red reflex in a newborn babies. And you look at the size of the head, whether the child has got a microcephaly or macrocephaly, and any abnormalities in the abnormalities in the head, and the sutures, any wide opening sutures, and all those things you can easily assess. And anomalies should be identified in the cleft lip, cleft palate. When there is a abnormality in the face, look at the heart. That is a basic principle. When there is a murmur, look at the face, whether any dysmorphia in the face. Chromosomal anomalies, association of heart disease is very high. So when you get these kind of anomalies, evaluation of heart is a mandatory. So child which has signs of any abrasions, ecchymosis, or bite mark, you should have a strong suspicion of child abuse. When you have a child, when you suspect child abuse, child should be explored for other injuries like rib fractures, retinal hemorrhages, and any subgaleal hemorrhage. All those things should be explored one by one. And then proper history is very important, and then the child has to be assessed for the clinical complete point of care. Examination is a must and should be examined at one time with the pediatrician. If it is a sexual abuse, and the involvement of obstetrician is very important, the POXO Act and other things and all is there, and then you can easily identify this. This is the lymph node enlargement. So when you go to the respiratory system examination, you all know inspection, palpation, auscultation, and you can completely do this. But at the same time, by inspecting the child, you know whether the child has got any tracheal tug or not, any chest wall deformities, pectus carinatum, scar, and counting the respiratory rate for 10 seconds and multiplying into 6, you get a 1 minute respiratory rate. And at the same time, look at the chest, whether the child has got any pulling of heart, any chest indrawing, a suprasternal recession, or intercostal recession. All those things definitely will tell you whether the child is in respiratory failure or not. Harrison sulcus is indirect evidence that the child has been having a chronic obstructive airway disease or an asthma child. So the external clue markers also you have to look for it when a child comes for a physical examination. And the child has got a crowded lip with overcrowding, that also shows that it is a chronic obstructive airway disease. Normally the anteroposterior diameter of the chest wall will be increased in a case of COPD and asthma. So these are all the examination and inspection findings. So chest expansion you can easily assess, and after assessment you do the percussion, and then you do a gentle percussion without hurting the child. The percussion should be done. If there is a resonant note, it is a normal thing, and hyperresonant you get it in a pneumothorax, and dull and stony dullness, all those things, you know it is a pleural affection. When you are doing an examination of the chest, you place your palms on both the sides and then look for the apical impulse. If the apical impulse is well heard on the right hand side, it is morely dextrocardia. This dextrocardia associated with cartilaginous syndrome and other things. So that is very important. So apical impulse also should be palpated bilaterally. And auscultation, wheeze, ralls, and striders and crackles. So don't do immediate auscultation post-nebulization. Post-nebulization, you can get some ralls in the basal region. Don't come to any conclusion immediately. So at the time, just wait for some time, and then you do the auscultation and find out whether there is any ralls or not. Strider, obviously, you can hear it with your ears itself. And crackles, you can get it in the pneumonia and other conditions. So in abdominal examination, again, inspection, palpation, percussion, auscultation. Why I am telling this art of examination, when you are doing a general examination, at the same time, simultaneously you have to look at the child's face, whether the child is having any pain or anything. If the child has a pain, there will be changes in the face. Simultaneously, you can look at that. And always start with the warm hands. That is very important. Kneel down yourself and then put your palms over the right iliac fossa. Gently you start examining the abdomen, starting from the right iliac fossa to right hypochondrium, epigastric region, left hypochondrium, then finally you come to left iliac fossa. So, and especially when a child has an abdominal distension, exclude urinary bladder distension. And bimanual examination is very important, and gentle examination, and at the same time, you look for any scars at that nerve. Please avoid rectal examination in pediatric examination, even though it is a part of the abdominal examination, and if it is really mandated, then only you can do the rectal examination. Otherwise, you please skip that examination. And percussion, finally, you have to do percussion and then auscultation to look for any bowels and other things. The cardiovascular system examination, again, you have to look for cyanosis, whether it is a central cyanosis or a peripheral cyanosis, and clubbing is very important. Jugular pulses normally less than 10 years, we don't look for it. If it is older children, you can look for JVP, otherwise it is not needed. And auscultation, especially when you are starting the auscultation, in the mitral area, concentrate your first heart sound. Don't give any importance for the second heart sound. Only you concentrate on the first heart sound. If you want to know the quality of second heart sound, you go to the pulmonary area and concentrate on that area. So first and second heart sound in the mitral area plus added murmurs, then you have to exclude whether the child is having any radiation of this murmur towards the axilla or not. All those things I don't want to explain, you all know. Just the method of examination is very important, and then especially when you come to lower sternal region, if the child has a harsh pansystolic murmur, you know that it is a case of a ventricular septal defect. And in a musculoskeletal system, the examination should be done according to P-GALS. I don't know, the P-GALS examination is not routinely practiced in pediatric. P-GALS is nothing but pediatric gait, arm, limb, spine examination. A video is there, and all of you go through that video. It very clearly gives that video. Before you start the examination, you need to ask a few questions, whether the child has got a pain or not, whether any difficulty in wearing the clothes or not, and difficulty in wearing the chappals and other things. So if you follow that way of examination, the pediatric examination, you will come to know how many joints are involved, whether the child has got a polyarticular type of arthritis or not, or monoarticular, all those things can be easily identified. Neurological examination. See, this is a child has come to outpatient department. By observing the child, you can get many points. Look at the child. The child has got a microcephaly. The child is not at all looking at. The child also, signs of mental retardation is there, and squint is there. All the limbs completely scissoring type of gait is there. The tones are increased. You can see the thumb twist. At the same time, the knee joint is flexed, and the ankle is flexed, hip is flexed. That all shows that the child has got hypertonicity, and there is a gross wasting of the child. And nutritional wise, the child has got grade 4 nutrition deficiency. And also you can look for any abdominal distension or not. These children are more prone for constipation and other activities. All those points can be, by observation itself, you can elicit. And the thing is, limb tone and deep tendon reflex. By just tapping at the knee reflexes, you know whether the child has got exaggerated knee reflexes or not. You should know, without hurting the child, you can complete the examination. And especially when you get a child with cerebral palsy, it's a mandatory to do primitive reflexes. The golden rule is persistence of the primitive reflexes and delay in the developmental milestones. If you complete that, then you know whether the child has got what type of a cerebral palsy. This is obviously the child has got a quadriplegic type of cerebral palsy with the mental retardation. Other findings are squint and other things. You need to rule out, and by taking a focus history, whether the child has got any seizure and other things and feeding issues. So multiple approach is important in the child with the cerebral palsy. By completing this in a comprehensive care, if you provide, definitely the quality of life can be improved, and the child will be free from the other symptoms. So this is a simple way of, I just took one video, how easily we can complete the neurological, that is a cranial nerve examination in 2 minutes. You just take one red ball, it is attracted by children. Just hold the red ball. By showing that, you can elicit, we can complete the cranial nerve. First, now if you want to do the cranial nerve examination in a newborn, the child usually turns towards the breast milk. By the smell of the breast milk only, the child turns towards that. That shows that the intactness of the first cranial nerve. The second cranial nerve, can be excluded by the red reflex and pupillary reflex and so on. And 3, 4, 6, just hold the ball and take it, the red ball, move upwards and downwards and lateral aspect. Lateral aspect, if the child is able to see, that means the intactness of the 6th nerve, 3 and 4, up and down. So these movements will tell you that the 3, 4, 6 is intact. The same way, during sucking time, the vigorous sucking will tell you the 5th nerve is intact. 7th nerve, while crying time, the child deviation of mouth or any difficulty in closure of the eyes tells 7th nerve is intact. Any gargling, difficulty in swallowing and pooling of secretions and gargling sound, that tells that the 9th turn is affected. And the 11th nerve, turning of the head from one side to one side, at the same time you can check for the 11th cranial nerve. And looking at the mouth, you know whether the child has got any fasciculation or any deviation in the mouth itself. So 12 cranial nerves, just in 2 minutes time you can complete it, and you can come to a conclusion that the child has got any neurological involvement. At the same time, the posture of the baby will tell you whether the child has got any hypertonicity and other things. You describe the posture, how the child is moving. Any child in less than 1 year having paucity of movements on one side indicates that it is an hemiplegia. So even for other type of cerebral palsy, you can easily elicit the reflexes and the tone of the child. So with this, I complete my examination. A perfect pediatric examination is to listen with eyes, speak with the hands, and heal with the heart. With this, I conclude my speech, and thank you for the wonderful opportunity given to me. And maybe it's a very basic thing, but still it needs to be implemented. Thank you, one and all.
Dr. Dharani Rajan. Thank you very much, Dr. Dharani Rajan, for covering the main clinical examination as well as going into some nuances of clinical examination, which we have usually used to avoid. We don't take care at all when we actually start clinical examination, namely prerequisites for clinical examination. What we will do is, maybe ஒரு child உள்ளார வந்ததுனா உடனே maybe suppose needs to be examined, abdomen needs to be examined. படு மேல உடனே the child will be struggling that much in the fear. But we won't be able to approach the abdomen. To that extent, the child will be struggling. We will be actually starting examination. The findings at the end will be zero only. Maybe sometimes it will go in the negative side also. So we need to have all the prerequisites to aid for a good clinical examination that you have insisted very much. That is an eye-opener again. With this, actually, I will go open the paper for discussion. Any queries?
Yes, sir. We have
Maybe our seniors, our teachers.
Yes, sir. We have
Nobody will say that it is clinical. There is a query, is it? Nobody will say that the clinical examination will go next to the thing. To that extent, maybe we need to be perfect. Suppose you have a perfect clinical examination, then to the tune of 99.9%, you should be having the diagnosis at your hand, at least a differential diagnosis, in that maybe that order should fit if it is going to be a perfect clinical examination, maybe to aid to a maximum extent, maybe 5 to 10% it is going to help. It should be that way, the clinical examination should be perfect. Yes, ma. What
yes,
the
yes,
query?
sir. We have some queries from the audience, sir.
Yes.
So, the first question is writing reverse letters always dyslexia, and when should we start to evaluate it?
See, yeah. So, reversal of initial period when the child starts writing, there can be reversal. If this continues, and even with the assisted support, if the child is not able to change, and when the child is started forming words also, the child continues to do so, then it's the right time to get the child evaluated.
Thank you, sir. As we are running short of time, we request delegates to post questions and other speakers to respond on the platform itself. Thank you, sir. We thank the speakers and the moderator for such an insightful session. Kindly accept a token of appreciation from our behalf. We request Nedunjalian sir to present our speakers with a token of appreciation. I request Dr. Somasundaram sir to present our moderator with a token of appreciation. Thank you all. With that, we proceed to the next session. It is an honor to introduce the chairperson for the next session, Dr. Uttaraj P. Our chairperson for this session is a highly respected senior pediatrician from Pollachi. He has been a guiding force in our fraternity for decades and is also the organizing chair of the Kongu Pedicon 2025. In recognition of his tireless and selfless service to the community, he has been honored with Lifetime Achievement Awards by both the IMA and the Rotary Club. We are privileged to have him with us today to lead this session. Welcome, sir. I would also like to introduce the first speaker for the session, Dr. Rajendran K., Professor and Head of Pediatrics at KMCH Coimbatore and President IAP-TNSC 2025. With his expertise in pediatrics intensive care and child health and decades of contributions to academics and leadership, he continues to inspire pediatricians across Tamil Nadu and beyond. Welcome, sir.
Thank you. At the outset, I thank the organizing team and the scientific committee who has given this opportunity. And next 20 minutes, I am going to talk about acute stridor, how to quickly recognize and how to manage effectively. So start with some question. 1-year-old boy with a progressively increasing noisy breathing with a respiratory distress. He has low-grade fever with a barking cough. It's coming to ER with subsequent evaluations was no drooling of saliva. And using the pediatric assessment triangle, so whenever the baby is coming to ER, we have to start with a quick review by either it's a doctor or you can staff nurse, they can do it. It's a novel tool also. And you can look for how the baby is lethargic and normal tone and posture. And airway is obstructed but maintainable, noisy breathing, and child is having definitely respiratory distress, and saturation is maintaining, and tachycardia, and no signs of shock. This is a child you can easily care that stridor. This stridor is nothing but is a coarse, high-pitched respiratory sound. It's usually inspiratory and monophonic, secondary to obstruction of upper airway. And how to approach a child with noisy breathing. So once a baby is coming to ER with noisy breathing, so you have to look for this airway. So if the airway is unstable, you have to go for emergency department, you have to go for ABC. And you have to go for that complete history and physical examination, clinical examination also. So many conditions produce noisy breathing. If you are younger the child, you can see that snuffles like cold. Snoring, mostly in so as a younger child, you can get it adenotonsillar hypertrophy. And wheezing. Okay, wheezing, it's an acute. If with fever, you have to think of bronchiolitis. Any acute episode, you can think of foreign body also. Lower airway, foreign body also may produce wheezing. And in child having recurrent and persistent wheeze, you have to think of some chronic conditions. And grunting, as you are aware that it will be a lower airway pathology like pneumonia. So coming to the stridor, either it's an inspiratory or it's an expiratory. So once inspiratory stridor, you have to look for the voice. It's a normal voice. With fever, you can think of retropharyngeal abscess. Without fever, you can think of laryngomalacia. If the voice is coarse, with the fever, you have to think of croup. And with no fever, you can think of laryngeal pathology, vocal cord paralysis. Usually, it will be in the younger the age. So coming to that, there's a acoustic of stridor. When airflow is forced through the narrow tube, local area of low pressure creates a vacuum effect to distal to narrowing. So this focal area of low pressure distal to narrow area, airway, causes airway to collapse and vibrate. So this generates a characteristic and sound called stridor. So we can go for that larger airway, you can divide into extrathoracic and intrathoracic. So extrathoracic and supraclatic area, clatic and subclatic area. In intrathoracic, you can divide again extra and intrathoracic. Stridor can be caused by obstruction in various locations in case of extrathoracic or intrathoracic. Sometimes multiple sites of central airway narrowing that may produce stridor in either phase of breathing. So in case of extrathoracic airway obstruction, during forced expiration, intratracheal pressure exceeds the pressure around the airway. That means it's a atmospheric pressure. lessen the obstruction, so it won't produce stridor. In case of inspiration, when tracheal pressure falls below that atmospheric pressure, the obstruction worsens, resulting in flow limitation. That's why in case of extrathoracic airway obstruction, produce inspiratory stridor. So in intrathoracic airway obstruction, during post-expiration, intratracheal pressure is less than the pleural pressure, so producing the worsening obstruction. That's why in case of intrathoracic airway obstruction, so produce expiratory stridor. Whereas in during post inspiration, tracheal pressure exceeds the pleural pressure, so lessen the degree of obstruction. So these are the basic things you have to aware before going for the upper airway obstruction pathology. So how to approach a child with a stridor? So you have to look for the age group. So that early infancy mostly will be a congenital conditions like if you are going for birth, you can think of that's a vascular pathology. And another thing is you can go for vocal cord paralysis, laryngeal web also. In case of usually that 6 months baby, you can go for usually manifestation of laryngomalacia will be there. Whereas if you are coming to the older children, so 1 to 4 years, you have to think of acquired conditions like croup, epiglottitis, foreign body as well as retropharyngeal abscess. So what are the precipitating factors? So one, that the child is worsening with straining or crying. You can see in the case of laryngomalacia. With the supine position getting worsening, you can think of laryngomalacia, tracheomalacia also. In case of night, usually in early morning conditions, the child is having cough, usually the viral or spasmodic group. Worsening with feeding, you have to think of tracheoesophageal fistula, again neurological disorder also. And sometimes if you are preceded by URI, so either you can have a viral group or you can have bacterial tracheitis. Sudden choking or gagging, you have to think of foreign body. What are the associated symptoms you have to look for? If a child is having barking cough, you have to think of a group. Whereas a brassy cough, you have to think of tracheal lesions. And baby with drooling of saliva, fever, toxic look, you have to think of epiglottitis and retropharyngeal abscess. And weak cry, definitely you have to go for, with hypotonia, you have to think of laryngeal anomaly or neuromuscular disorders. Muffled cry, you have to think of supraglottic lesion and hoarseness group, and in case of snoring, you have to think of adenoid and as well as tonsillar hypertrophy. So child coming with dysphagia also, supraglottic lesions also you have to think of. So past history is a very important thing. In case of perinatal asphyxia, cardiac problem, you have to think of which are predisposed to vocal cord paralysis. And atopic history also very important. And more than that, if you are in case of hypothyroidism, Down syndrome because of airway edema as well as hypotonia may produce stridor. Coming to the physical examination, so quality of stridor is very important. If a child is having inspiratory stridor, you have to think of extra thoracic obstruction. Whereas expiratory stridor, you have to think of intrathoracic obstruction. Whereas biphasic stridor, you will get it in the central obstruction. The position of child is a matter. So if child is having hyperextension of neck, you have to think of extensive obstruction at or above larynx. Whereas leaning over, drooling or tripod position, you have to think of in epiglottitis also. And these are some positions we can see that in case of epiglottitis, tripod position and a significant posture. So coming to the osculatory finding, if prolonged inspiratory phase, it's a laryngeal obstruction, whereas prolonged expiratory phase is a tracheal obstruction. And unilateral decreased airentry, you have to think of foreign body aspiration. Sometimes if a child is coming with cutaneous manifestation, so with coming with stridor, you have to think of subglottic hemangioma also. Peripheral neuropathy, you have to think of vocal cord paralysis. Whereas urticaria, you have to think of angioneuritic edema. So how will you differentiate differential diagnosis so you can approach acute stridor? If a child is coming with a drooling of saliva, you have to think of supraglottic pathology. Whereas if a child is coming with no drooling of saliva with the presence of barking cough, you have to think of glottic or infraglottic pathology. So the clinical approach, your child is coming to ER with a stridor with the febrile, but a low grade, you have to think of acute group. Whereas high grade fever with stridor, you have to think of epiglottitis. bacterial tracheitis or retro or parapharyngeal abscess. Whereas afebrile conditions, commonly the younger the child, you have to think of foreign body and angioedema also you have to think of. Degree of obstruction may vary from the mild, moderate, severe. In mild cases, child able to speak and usually minimal retraction will be there. Whereas moderate to severe conditions, you can get it respiratory distress only, not in failure, and some kind of hypoxia will be there. Whereas complete obstruction, you can make out no effective airway movement, and either the child is having respiratory distress. So increased respiratory rate, increased work of breathing, it is called respiratory distress. Whereas decreased respiratory rate, decreased work of breathing, or extremely increased respiratory rate or decreased work of breathing, you can term it's a respiratory failure. So respiratory failure, you can clinically only make out with the cyanosis, mental alteration status, or bradypnea or tachypnea, decreased swallow movement, you can make out. So coming to our case proper, since this is a child with acute group, is may produced by viral, almost para-influenza, almost 70% with influenza also. So we can use the severity assessment in group. So there is a score is called Wesley. Wesley score, it is level of consciousness, cyanosis, stridor, air entry and retractions. So score of 6 to 7 you can think of severe group, whereas 12 to 17 it's a impending respiratory failure. So using that score easily you can assess the severity. So once that baby is coming to ER, use the pediatric assessment triangle, so and followed by pentagon, also ABCD approach. And you have to ensure that limit the examination. Do not insert tongue depressor, don't disturb the baby, and avoid sedations particularly. In case, so if the child is having mild to moderate group, you give a single dose of dexamethasone oral 0.6 mg per kg, or you can go for prednisolone 1 mg per kg also. If not to give oral, not tolerating, we can go for budesonide, 2 mg per kg nebulization we can give it. If observed for 4 hours, baby is improving, you can inform the parents of the warning sign, you can discharge. Whereas in severe life-threatening conditions, you have to give, apart from giving dexamethasone 0.6 mg per kg IM, you have to use the nebulized undiluted adrenaline. That's a very important thing. If your baby is having 6 kg baby, you can use of 3 ml of adrenaline along with 2 ml of normal saline. That means to make it a 5 ml, you can give nebulization. If necessary, you can repeat after 4 hours also. If a baby is having good response, you can observe 4 hours and inform the parents about the warning signs, you can discharge. If baby is not poor in that response, you can give repeat dose of adrenaline nebulization, and steroid dose dexamethasone you can repeat after 24 hours. So you have to either if the child is sick enough, you can admit in ICU, or otherwise you can observe in the ward. So come to the next case scenario, the 3-year-old boy with the inadequate hip immunization, muffled voice, sudden onset of high-grade fever, hyperextension of neck, no torticollis, dysphagia, pooling of secretion, drooling of saliva also noted. So it's a noisy breathing. It's a baby is agitated, airway obstructed, but respiratory distress noted, it's inspiratory stridor. And tachycardia is noted, no shock. It's a child, you can see that inspiratory stridor. So that the diagnosis acute epiglottitis. This is either it is an infection, commonly Haemophilus influenzae, and inflammation also. Sometimes non-infectious conditions like caustic ingestion and direct trauma also you have to suspect. It is a it may progress to life-threatening airway obstructions. So clinically only suspect. Younger than less than 6 years, any acute onset with fever and stridor, drooling is present, and usually cough absent and tripod position, and is reluctant to lie down. These are conditions you have to suspect acute epiglottitis. And whereas in older children, epiglottitis should be suspected, in whom the severity of sore throat is out of proportion to the physical examination. So you can use that X-ray, that thumb sign also you can get it in X-ray, and this is a child with direct examination after stabilize the child with swollen red epiglottitis. It's a management is very clear. This maintain the airway is a priority, followed by appropriate antimicrobial therapy. So we are going for appropriate antimicrobial therapy. This we can use third generation cephalosporin with vancomycin is ideal drug. We can use it. So after obtaining culture, we can do it. In case of airways, admitting the child with airways not maintainable, so you have to go for begin with bag and mask ventilation and intubate the child by rapid sequence intubation. And if not to intubate, we can go for needle or surgical cricothyroidectomy and obtain culture, start antibiotic therapy. In case of airways maintainable, so you have to go for a severity assessment. So admit in ICU. If a child is epiglottis is confirmed means, so you have to go for that means less than 6-year child with older children with 50% of airway obstruction, and you can admit and you can start antibiotic. So next case scenario is 2-year-old child with sudden onset of high-grade fever. Here is a hyperextension of neck with distress. You can see the child with neck pain with stiffness also, drooling of saliva, but toxic looking, no barking cough, agitated again, his airway is obstructed, but the respiratory distress. Inspiratory status is noted and saturation hypoxia, but tachycardia is there and but no shock. So child with subsequent diagnosis so that retropharyngeal abscess, it is a collection of pus in the retropharyngeal space, and you have to look for the symptoms. How can you clinically you can make out? It's usually that less than 5 years history of URI will be there, dysphagia, and group, and as well as torticollis. The important thing is the child come with the torticollis. Signs is as already told you, this is ill looking and febrile. Hyperextension of neck will be there, hot potato eyes, and neck swelling with tenderness. If after stabilizing the child, you can go for local examination, you can see that a unilateral bulge on posterior pharyngeal wall. This I make a diagnosis of acute retropharyngeal abscess. And usually that retropharyngeal space normally measures 1/2 of the width of the adjacent vertebrae, whereas in case of retropharyngeal abscess, it will be a match with that vertebral body. So that one clue you can get it. And solely approach. If a child is signs of severe respiratory obstruction, you have to emergency call for the ENT as well as that anesthetist to stabilize the child. And you have to, first of all, you have to secure the airway, and you have to make a diagnosis. You can go for surgical drainage of the abscess. And if first you get it, you can send for a culture and start antibiotic. If not get it, you can start empirical antibiotic you can give. Whereas if a child is having stable but otherwise okay, you can go for CT. That's a very important thing is CT, you can do it. If a well-defined abscess that more than 2.5 centimeters square, you can go for surgical drainage. In case the child is having less than 2.5 centimeter, definitely you can wait for the antibiotic another 24 to 44 hours, 48 hours. And if subsequently baby is not improving and worsening, you can go for next, you can repeat CT after 48 hours. If more than 2.5 centimeter, you can go for drainage. So otherwise, you can continue the antibiotic. Next case scenario is 1-year-old previously normal child with coming with playing sudden onset of stridor, cough, and choking. And it's a child is alert, a normal tone and posture. And baby is having expiratory stridor, and subsequent evaluation says reduced air entry with the wheeze on right side. And so child is having respiratory distress. Otherwise, child is not in shock.
First aid procedures.
So usually that less than 1 year baby and less than 3 years should not give any odd objects. So that's a very important thing. Commonly, so what we are in petal net we are using, and toys also, small toys also. So you can use algorithm for approach. Any child with suspected or known foreign body aspiration. Child is symptomatic. That means child is having breathing difficulty and all signs fit into the that's foreign body aspiration. You have to emergency. You can directly you can call that either it's pulmonologist or ENT surgeon. They are removing foreign body. But asymptomatic child, so that any foreign bodies usually start with a symptomatic period, and again it's asymptomatic period 7 to 10 days. Again the third species is may go for infection, may get symptomatic. So symptomatic, asymptomatic, symptomatic. This is a 3-way it may present. If a child is coming to asymptomatic, you can go for plain radiograph. That's you can do it. And if radio opaque means you can visualize in the X-ray, you can go for bronchoscope. So otherwise, it's easy nowadays. Easy thing is you can go for CT with CT EC, and you can go for definitely virtual bronchoscope image. You can reconstruct. You can see that bronchus is any foreign body there or not. So unnecessarily we can avoid bronchoscope if you're using that that virtual bronchoscope image of CT scan. We can reconstruct. You can see it. So next case scenario is 3-year-old boy presented with sudden onset of stridor, cough and choking, but you can see that it's unresponsive child here, and tone and posture is abnormal, and the child is having here is you can see that the child is respiratory failure, saturation 60% only, heart rate whereas 60 per minute. So another one is this is a child coming with a shock also. You can see the central foreign body. So complete is you can see that complete obstruction of airway due to foreign body. You can first of all you have to see that how is the air movement. For no movement of air, no sound of cough, and progressive cyanosis, you have to attempt ventilation. For no chest rise, you have to use a Heimlich's maneuver. For less than 1 year, you can use 5 back blows, then 5 chest thrust, and more than 1 year you can look for the 5 abdominal thrust. If unsuccessful, you can perform that direct laryngoscope, immediate surgical consultation, and attempt a vigorous bag and mask until then, and intubation, and you can go for cricothyroidectomy. So this how to broadly we can go for diagnostic approach to upper airway obstruction in children. Any future of upper airway obstruction, so coming to ER with signs of respiratory distress, the child is having respiratory obstruction severe, definitely you have to go for approach with ABC, that means use pediatric assessment triangle followed by pentagon. You have to go for emergency treatment. So don't wait for the investigation, don't wait for the diagnosis. If no respiratory distress, that means no respiratory obstruction, but child is having without fever, you have to think of foreign body, angioedema, and as well as caustic injection. Child is having fever with high grade and toxic appearance also, and with severe dysphagia with odinophagia also with drooling, and with the neck stiffness you have to think of retropharyngeal abscess, and without neck stiffness or pain you have to think of epiglottitis. Whereas a child is not having severe dysphagia, but child is having barking cough with a tracheal tenderness, you have to think of bacterial tracheitis. Whereas no barking cough, you have to think of the peritonsillar abscess also. And actually child is having not having fever, high grade fever, not toxic appearance. Child is having barking cough with hoarseness, and you have to think of group. Whereas no barking cough or no hoarseness, you have to think of bilateral tonsillar enlargement. You have to think of other conditions like infectious mononucleosis and diphtheria. So the take-home message is very clear. Any babies coming to ER, we have to initial assessment, use that pediatric assessment triangle, even staff nurse or even duty pediatrician, they can easily do it. Followed by initial assessment using pediatric pentagon, that means ABCD approach, and subsequent physical examination. You have to concentrate physical examination, and for the final diagnosis, most of these acute stridor, you can clinically you can make out 90%. If you have any doubt, we can go for imaging and other studies. So don't wait for the child to go for investigation. If a child is sick enough, don't send the child to X-ray or imaging. So first priorities you have to go for that's airway, breathing, circulation. You have to stabilize that one. Thank you very much.
Thank you, sir. We are pleased to welcome the next speaker, Dr. G.V. Basavaraja, sir, Professor of Pediatrics and in charge of PICU at IGICH Bengaluru. Sir is the former president of the IAP and convener of the Scientific Committee for Pedicon 2718 and has over 100 publications in national and international journals to his credit. We are honored to have you here, sir.
So thank you very much. At the outset, let me congratulate organizing committee led by Dr. Rajendran, Dr. Ismail, Dr. Sasikumar, Mulai Balaji for organizing a wonderful conference, and also giving me an opportunity. I bring in a greetings from the prestigious Indira Gandhi Institute of Child Health, Bengaluru. That is where I am working. So next 20 minutes we'll be discussing about one of the commonest thing as a pediatrician and pediatric emergency medicine or an intensivist, we all come across, how do we recognize a sick child? Just an overview of a recognition of a sick child. Once you recognize it, whether it is in an OPD or emergency or critical care unit, we need to stabilize the child. We need to think about a few diagnoses. We'll talk about that. And quick investigation, what really required, and of course, briefly touch upon the specific management. The moment we recognize a sick child, what is the first thing as a pediatrician we need to recognize? Is it a life-threatening? The moment we talk about a life-threatening, it could be in a respiratory failure, slipping into the cardiorespiratory failure and cardiac arrest. We don't have a time. We need to act quickly wherever you are. That's the beauty of recognizing a life-threatening. Potentially life-threatening, if you don't act now, it becomes a life-threatening. We need to act quickly. And if it is not life-threatening, you can afford to have a time to stabilize and shift it to the wherever it is required. So how do we assess this? How do we recognize the sick child? What is more important, most of the time as a practicing pediatrician, we will be more worried about what is the cause, which is the organ is involved. That's not the important thing. Recognizing a sick child is, you need to look at what the physiological deterioration which is taking place. That's what we need to look at it. And how do we achieve quickly? It is a CBC method. Basically, what CBC method is? Look at the level of consciousness, look at the breathing, look at the circulation. These are the three important things as a clinician we need to quickly learn within 15 to 30 seconds. The moment you see a child, how do we quickly pick up the sick child? So just when you talk about the consciousness, it is then a behavior of the child which is very important. Is it agitated? Is it lethargic? Drowsy? Is it what is the interaction? All these things we need to look at in a behavior. And respiration is concerned, it is the rate and retraction and the type of a breathing which helps you to quickly assess that. And of course circulation, basically you are looking at, is it in a normotensive shock or is it in a hypotensive shock? That's how we need to look at that. So to achieve that, there are 6 steps where we need to look at that. How do we do that in an emergency department or in an OPD practice? After that, we will discuss about 6 cases which we have come across in our OPD and emergency. I will be sharing those cases. So let's go by step. So we need to use our special sensors effectively to recognize our sick child. That's how we can. What are the few questions you can ask when the child comes to you? Just look at the behavior of the child. Is it a child? Is it interactive with the parents and surrounding? How is the interaction, eye-to-eye contact? And what is the behavior of the child? Is it agitated? These things we need to look at. That gives a fair idea about what's the cortical function of the thing. Next thing is feeding. Most of the time when you start your practice, so my baby is not eating at all, my baby is not taking the feed. These are some of the things we get it in the emergency department. So basically, best thing is put the patient in an observation, ask them to feed and observe the thing. Is it baby is taking or is it just only the mother concern? Before ruling out the mother concern, make sure that and observe whether the baby is taking the feed and all. The moment if the baby is taking the feed and all, it is unlikely to be a sick child. So that's how we can assess that. And of course, urine output, that gives a fair idea about what the perfusion of the body. That is why we need to ask a question. Generally, whenever the baby generally passes 4 to 6 times of a urine, it all depends upon the environmental factor and oral intake, all those things is, but you need to look for the circulation in terms of a urine. What is the second step you need to look at? So you need to look for the appearance. The moment you said appearance, so behavior of the child, look at the gaze. Is the child is intently looking at the parents, or looking in the surroundings, or is it a gaze palsy? Just look that, is it a playful or lethargic or a drowsy? So that gives you a fair idea about is it a sick child or non-sick child. If the child is an hypoxic, so that means child will be irritable, and child will be hesitated. So that gives an idea of about this child is an hypoxic. Interactability is another thing where if there is less interaction with the parents and surrounding, that says that it is in a sick child. And of course, cry. Look at the cry. Is it a consolable cry or unconsolable cry? Unconsolable cry indicate towards you're most probably you are talking about a pathological thing. The other things which is very important is look at the tone. Tone is a very important thing. If in a sick child, most of the time it is a limp or stiff, depending upon the pathology. So neck retraction, that indicates that it is an pyogenic meningitis or in a cortical dysfunction. Feeding is another important thing. And of course, the infant which is having a pain which is a moderate to severe pain, that indicates that this is the child which is likely to be a sick child. And the next thing which is important is look at the respiratory thing, which is already been discussed. Basically, what you are going to look at the rate depending upon the age of the child, where you can say more than 16, less than 2 months, it is a tachypnea. 2 months to that up in 1 year, it is 50. 1 year to 5 years, it is a 40. Behind that, it is a 24 to 30, it is a thing. And along with the retraction is the thing we need to look for. And in the circulation is concerned, is a mottling, typical mottling that indicate that this child may be in a deranged in a circulation, along with an excessive sweating that indicate the adrenergic activity. And of course, the color of the skin is very important. If it is a pale or cyanosis, that indicate that this child is more likely to be physiological derangement of a circulation. The next thing is listen. So cry, if there is a shrill cry, that indicates that fever with shrill cry, think about oh, this is a sick child, most probably you may be dealing with a pyogenic meningitis. Respiratory sound, Dr. Rajendran sir has already brought it out very nicely. If there is a snoring, a stridor, that indicates that more probably you're dealing with an upper airway. If the patient is having a grunting, that indicates towards your parenchymal pathology. So that abnormal wheezing, it indicates that up in your smaller airway. So these are the things which gives you the fair picture. Where is exactly the pathology? Is it a sick or non-sick? Speech is another thing, and mother concern. Never ever rule out the mother concern unless and until you have been evaluated properly. Suppose if it is a patient which is having a respiratory, initially had a tachypnea, now it has become a silent chest, especially in the case of an asthma, that indicates that this is the child which is going towards a respiratory failure and cardiac arrest will be imminent. We need to act quickly. It is a life-threatening. So step 4, basically what you are going to look at the feel. Basically you are looking at the central and peripheral pulses. That gives you a fair picture about the circulation. If there are poor peripheral pulses, if there is a difference between the central and peripheral pulses, that indicate that this is the patient, there is an hemodynamic derangement. And the skin turgor, especially in the case of diarrhea and vomiting, if the skin turgor going slowly, this is the child which is having a dehydration, sick child, I need to quickly act on. That also indicate you about the poor perfusion. About capillary refilling time, so anything more than 2.5 seconds, that's the time where, oh, this is the child which is having a prolonged capillary refilling time, there is a circulation derangement, I need to quickly act. In a case of a trauma, especially when there is a polytrauma comes to in your office or an emergency, that's the time where you need to look at the injuries, fracture and hematoma. That indicates, oh, there is a significant volume loss, I need to act quickly. This is the sick child, I need to be looked in. The 5th step is basically you are looking at a smell where you are using look at the DKA. Suppose if the acidotic child with a fruity odor, oh, most probably this is the case of a DKA, acidotic breathing and all. Some of the inborn error metabolism can also be, and poisoning can be diagnosed by just an abnormal smell. And measurement is the 6th step where you need to look at the basic vital parameter like respiratory rate, heart rate and blood pressure. Depending upon the age group, you need to have one chart in your table so that quickly you can look at that. Depending upon that, is it a bradycardia, tachycardia, or is it a tachypnea or bradypnea? Blood pressure, is it a normal or abnormal? So these measurement is a very important to recognition of a sick child. When it comes to the measurement, apart from the vital parameter, so temperature and pulse oximetry. Following a COVID-19, what really which has been changed over a period of time. So looking at the saturation. saturation of anything less than 92% with respiratory complaint, with respiratory distress. This is the patient which is most probably it is a respiratory failure. I need to act very quickly. And measurement, other measurement like a blood glucose level in an emergency department, make it a habit to look in a case of a sick child. Hypoglycemia and hyperglycemia, both the things are very relevant. As a clinician, there are a few important things we need to be aware. Any child which is a sick infant of less than 3 months, that requires a hospitalization. You cannot manage the sick child less than 3 months on a OPD basis. You need to be more cautious. If the child which is having an hyperthermia, temperature is anything more than 40 or hypothermia, that's another thing which give you the alert, oh, this is a sick child. I need to quickly look into any serious life-threatening condition is there so that I can quickly refer the patient. Any suspected ingestion of unknown substance or unknown quantity, that's the time you need to be more cautious. For example, camphor is one of the common things, we all get it in OPD. Just even a little bit of a camphor poisoning, that can throw a convulsion, that will have an altered sensorium and all. If you don't act quickly, it can go into the very serious thing. Like amitriptyline, this is another thing, antipsychotic drug in the private practice where most of the time child consumes. That's having likely to have an arrhythmias where the sudden death can take place. That's why when there is an unknown substance or unknown quantity, if you come across, don't take any chance. This is a more potentially it can become a life-threatening. I need to act quickly. I need to take the patient inside. Any severe pain, unless you are ruled out the thing, be aware and try to admit the child. What are the other situations where you need to be? In a case of a severe malnutrition, the clinical manifestation may not be that evident. You need to be very, very cautious in a sick child. Severe malnutrition where the immunodeficiency is the main thing, where the severe infection is more likely to occur. We should not send these patients. You need to admit those things. And of course, burns, any burns of a more than 10%, and also involving especially inhalation of an airway where it can compromise the airway. Suddenly they can go into the respiratory failure. We need to be very. If there is a target lesions, what does it indicate? Target lesions following a drugs. This is the patient which is more likely to progress like your Steven-Johnson syndrome. If you send that patient to the home, so finally it may come up with a lot of complication. So that's the time even if there is mild cases, you admit and take care of those things. Any discordant physical finding and mother consent, don't ignore. You need to give a lot of importance to that. With this background, let's go to the few cases what we have come across in our practice, just highlighting how we can pick it up. This is an 11-month-old child, came to our OPD with a poor feeding and excessive cry. Look at the heart rate is more than 230. The unirritable child with there is no murmur and cardiac things and all. That what does it indicate? It indicates that any heart rate of more than 220 in a more than less than 1 year, anything more than 180 in a more than 1 year, that indicates that tachyarrhythmia. The moment you take a ECG, look at that, there is no R to R variation and the absence of a P wave, that indicates tachyarrhythmia. Most probably it is a SVT. Simple measures like just putting the patient if you are practicing in the OPD, just to take care of this type of a thing with putting the ice packs onto the face or in a Valsalva maneuver, that helps you to bring it down the tachyarrhythmias. If that is not responding, give adenosine. Only thing, if you are giving an adenosine, you need to give it quickly because the adenosine half-life is 10 seconds. You need to use two syringe technique and you need to deliver. Most of the time you teach it in pulse. If the patient is not responding to that, you can consider a procainamide or an amiodarone, or if there is unstable things, that's the time where you can use a synchronized cardioversion with a different also. Another child which came into our OPD with a 2-year-old child with an irritability, and the moment we examined this child, there was a cold extremities and excessive sweating. The irritability, cold extremities with sweating, that made us to think something else in this patient. After observing for 2 hours, we re-examined the child. Look at that, there is a priapism. So this is a child, when you go back and take a history, So you'll get a history of some bite or something. This is a basically case of a scorpion sting. Basically, you need to look at in this type of a child, is there any cholinergic storm? Initially, cholinergic storm will be there, where the bradycardia, excessive salivation, vomiting, priapism, all these things you'll get it in the cholinergic storm. In a case of an adrenergic storm, where you'll get an hypertension and arrhythmias, that is a late, and somatic motor activity, that is basically you need to look at the neurological complication in the later stage. So this type of a patient, quickly you need to take care of pain, basically non-steroid anti-inflammatory drug, and of course taking care of airway breathing. So the drug which is created a magic things in a case of a scorpion management, so bite management, is your prazosin. Use a prazosin 30 microgram per kg with an intense monitoring. Majority of the time they do extremely well. Even though scorpion antivenom is there, practical utility is very less and it is not freely available, even though we talk about, so all it boils down to the prazosin 30 microgram per kg. You can repeat after 6 hours, 3 to 6 hours. The third case is an 11-month-old child presented with a fever, with a disturbed sleep, and behavior and all the things is right. What one tachypnea is there, along with the saturation is 92%. So whenever there is a respiratory things, healthy child, less than 2 years, most of the time your diagnosis is certain, it is a case of a bronchiolitis. So your investigation may not be that useful except biopsy respiratory panel, where you can look at the etiological things. Is it an RSV? Is it influenza, parainfluenza, Boca, or metapneumovirus? You need to look at quickly, because so that you can unnecessary antibiotic can be prevented. What requires is a good hydration and heated humidified high flow nasal cannula. That revolutionized the need for the mechanical ventilation. You need to use it in a mild to moderate cases, not in a severe cases, so that your outcome will be much better. Let's move on to the fourth case, which is a 9-month-old child with a fever for 2 days. Interfebrile period is irritable child. That's the catchy thing in your practice. If the child, which is interfebrile period, is irritable with a fever, and just look for the signs of meningeal irritation in this child. There was a bulging anterior fontanelle. As far as the diagnosis is concerned, it is a pyogenic meningitis. Lumbar puncture, whether to do it depending upon the hemodynamic status, and also you need to look at it, is there a raised ICP. In this patient you can do it. And drugs is concerned, it is a vancomycin and ceftriaxone. Previously we used to talk about only ceftriaxone for last 1 decade, where the vancomycin has become a first drug because of a pneumococcal drug resistance to the ceftriaxone. That is why, and of course steroid, since it is a less than 2 years, we need to give a steroid in this child. Just before starting an antibiotic, we need to give for 48 hours so that your deafness can be taken care. The fifth case, which is a 3-year-old child with an high-grade fever, with a maculopapular rashes that is involving the palms and soles, and this child which has developed an irritability, convulsion, and delirious child, and on the examination there was an hepatosplenomegaly. This is the child, you can see the maculopapular rashes involving the palms and soles, and with hepatomegaly, with altered sensorium, your diagnosis is certain. It is most probably you are dealing with a rickettsial encephalitis. So this is the child which has been looked in other situation where you need to think apart from rashes which is involving the palms and soles. Basically, if you have an investigation, please look into the hyponatremia. That's a very common. Rise in the CRP is another thing. Neutrophilic leukocytosis and thrombocytopenia. This is how clinically we can. And the features of raised ICP that indicate that involvement of an encephalon, it is a case of a rickettsial encephalitis. Serological test as a limited utility, even though we talk about indirect immunofluorescence test, but it is a gold standard, but you don't get it in a routine practice. What is possible in our clinical practice is do a wheel pelix by ELISA method. Relatively it is okay, even though we say it is a useless test, but that is what practical it is. The drug which really is revolutionized the management of a rickettsial infection, your doxycycline, 3 to 6 milligram per kg, you can give it. Even you can give it in the less than 8 years. That's a common concern as a pediatrician. Most of the time we say, can we give it to the less than 8 years? Answer is yes. Even you can give it to the newborn. The whatever the we talk about tea staining and all within a less than 8 years, you may not be able to get it. So another case, which is this is the last case, 10-year-old child with fever and rash and pain abdomen, and along with the vomiting and decreased urine output. When you examine the child, you can see there is a narrow pulse pressure with a cold periphery, with a tender hepatomegaly, with rashes. And when you examine the child, it's a leukopenia with thrombocytopenia. Platelet is 1,28,000, 25,000, with mild elevation of SGOT. NS1 antigen is positive. Basically, it's a case of a dengue. So basically, what you need to the priorities in the management, you need to take care of a perfusion by using either crystallized like normal saline, ringer lactate, or plasmolide. Organ injuries, we need to avoid it. Strict monitoring and supportive care is the thing. So this comes to summarize this. So basically, every sick or potentially sick child, we need to look at the few things, asking a few questions, looking for the behavior and feeding and urine output. Look for the appearance of a breathing, circulation, and cortical function, and listening to the abnormal sounds like cry, abnormal cry, or breathing and abnormal sounds. And pulses is another important thing, especially extremities you need to look at that. And looking at the smell of the things like inborn error metabolism, poisoning, diabetic ketoacidosis, all these things can be diagnosed. And measuring the vital parameter along with the blood sugar and saturation. These are the 6 steps which really helps you to recognize the sick child. What is the carry-home message? Regardless of the etiology, information which is required to assessment and management of all the fundamental principles remains the same. Simple clinical tools which help you to recognize a sick child or potentially sick children. And of course, kids can deteriorate quickly if you don't act. When the patient is in a cardiorespiratory failure, it can slip into the cardiorespiratory arrest. So you need to act quickly in a life-threatening situation. With this, once again, I thank the Kongu Organizing Committee for giving me an opportunity. Thank you very much.
I thank Dr. Rajendran and Dr. Basavaraj for the useful and clinically applicable discussion. Really, it's very interesting and more useful. And this will be useful to all the pediatricians. Thank you once again.
Thank you, sir. There is a question for the first speaker. The question by Dr. Mahalingam is heated high flow oxygen delivery in bronchiolitis. They're requesting more details about that, sir.
Yeah, heated humidified high flow nasal cannula is one of the most important thing. It is not going to deliver any PEEP or PEEP. It is basically the way of delivering an oxygen. Basically, you are taking care of a good humidification that gives a good comfort to the child. If you use the heated humidified high flow nasal cannula in the early stages of a bronchiolitis, in mild and moderate distress, your need for invasive ventilation will go down drastically. We have done a study. The patient who has been without any heated humidified oxygen, with humidified oxygen. So if you use the heated humidified oxygen, your need for ventilation is around 17%. If you don't use it, your things is almost 50 to 60%. That's why we need to use the heated humidified high flow nasal cannula early, especially mild and moderate cases.
Thank you, sir. And the next question is how to recognize stable from unstable airway clinically.
Thank you. And this is you have to use a pediatric assessment triangle, as already discussed. If appearance the baby is having, if a child is having older children talking full sentence, or a younger infant it's crying that's a well cry, that means the airway is stable. This is an easy clinical tool, we can use it. And coming to the breathing, if a stridor not at rest, that means okay. And another one is saturation. That means important fifth vital sign. This is saturation also according to WHO. And 2016 fifth vital sign. The saturation is more than 92-94%. I think it is definitely baby's stable airway. And third one is we have to coming to the circulation. In unstable airway, child will have impending respiratory failure or collapse. So easy thing is babies, older children crying very well, and also the child is having speaking full sentence, that baby's definitely will be airway will be stable.
Thank you, sir. We are grateful to our moderator, Dr. Uttaraj sir, and as well as our speakers, Dr. Rajendran and Dr. Basavaraja sir, for their thoughtful contributions to Kongu Pedicon 2025. Kindly accept a token of gratitude from our behalf, sir. We request our chairperson, Dr. Uttaraj sir, to present the token of gratitude to our speakers. I request Dr. Basavaraja sir to present our chairperson with a token of gratitude. Thank you all. With that, we proceed to the next session. It is my honor to introduce the chairperson of the next session, Dr. Joginder Singh Dhankar. We are delighted to welcome Sir, who has served on the CIAP Executive Board in 2011, 2014 and 2016. He was co-chairperson of Pedicon 2012, organizing secretary of HARCON, and the annual IAP conferences in 2001 and 2006, as well as the president of IAP Haryana in 2009. We are honored to have you on stage, sir. I would also like to introduce the first speaker, Dr. Yogesh N. Parikh. We are honored to welcome Sir, who is a professor of pediatrics at Government Medical College, Surat, with over 25 years of teaching experience. He is the Honorable Secretary General of the Indian Academy of Pediatrics, former National Vice President and President of the Gujarat State IAP. He has held multiple national coordinator roles, contributed extensively to child health programs, and has over 30 publications in journals. We are honored to have you, sir.
Thank you. First of all, I congratulate Team Kongu Pedicon to have such a wonderful conference, and I am thankful to them to give me the opportunity to chair this session. The first session is by Professor Dr. Yogesh Parikh, our beloved Honorary Secretary, the real life versus red herring unmasking pediatric pain. The pediatric pain, as we know, the child can't communicate. He has there are certain signs, subtle signs through which we observe, the parents perceive the pain of the child. So here Dr. Yogesh Parikh will take us through both the things, whether it is a real life or a false pain. Over to Dr. Yogesh Parikh.
Thank you, dear Dr. Joginder ji, Chairperson. And I thanks organizing committee of the Kongu Pedicon, Dr. Rajendran, Dr. Sasindran and all. Let us start this. What is the real life versus red herrings and why it matters? Because the pain drives over 55% of the pediatric emergency department visits and equaling to nearly 20 million visits annually in the US alone. The Indian context data is not available, but here this 70% of the children receive the inadequate assessment or the analgesia. So it is matter. Second, diagnostic delay consequences, because we miss the appendicitis, we miss the septic arthritis, osteomyelitis, may lead to the perforation, joint destruction or the chronic pain. It is more extended hospital stay and the cost more to the healthcare. Third is the resource impact, because it delays increase in repeat imaging, CT scan, USG and invasive procedures, and it inflicts the cost and the morbidity. So we have to record the pediatric pain expression by 2 means development consideration. In the less than 2 years infants, it is usually non-verbal cues like crying, facial grimace or the tachycardia. And in the preschool, 2 to 7 years, combine the faces pain scale, revise FPSR with the FLSCC for the reality. More than 8 years, self-report with the NRS or VAS, and the contextual modifier, cultural or familiar influence, and the neurodivergent non-verbal. We have to use the toolbox according to the age, validated pain scales. Less than 2 years, cries is there and score is 0 to 10. More than or equal to 6 indicate the need for the analgesia. 2 to 7 months to the 7 years, FPSR, so FLSE, the toolbox, and same the score is 0 to 10, validated for the pre-verbal and the cognitively impaired. More than 8 years, as mentioned, NRS or VAS with the pair with the vitals and the monitor trends. So let us see for the less than 2 years. Primarily behavior cues, the facial expression, brow bulge, eye squeeze, then the nasolabial furrows, body movements like the limb withdrawal, arching or the thrashing, and then vocalization, high pitch cry or inconsolable crying. Physiological indicators, as the Dr. Basavaraj already mentioned, change in the heart rate and the respiratory rate, then the blood pressure fluctuation, oxygen saturation or increased respiratory rate. We have to assess by the tool crying, non or vigorous, respiration, require the oxygen, yes or no, increased vital, then the expression, grimace scale, and the S for the sleeplessness, sleep or awake. Total score is 0 to 10. Threshold more than 6 requires the analgesia. Preschool and early school age 2 to 7 years, it combined with the report, self-report with the observational methods. So FPSR is 6 phases ranging from no pain to the this 0, and the FLS phase, legs, activity, cry and consolability. Its 5 domains is scored 0 to 2, total 0 to 10, useful when the cognitive or the language delay impair the valid self-report. And we have to consider the language skills, simple, description hurt or O, and prompting where does it hurt most. Then it will guide the localization. In the older children or adolescent, we have to use the numeric rating scale and the VS, and we have to encourage the narrative. Ask how does it feel? It's sharp, dull, cracking, to elicit the quality and the guide differential. So this is the something like the von Becker's phases, 0, the how and when to use. See, the 0, 2 and 4 is no hurt, 6, 8 and 10 is a worst hurt. So how to use? We have to explain the scale. The 6 phases numbering 0 to 10, explain. Phase 0 means no pain. Phase 10 means worst pain. We have to clarify phase show how much something hurts, not how the person looks, because we have to see the how much the hurts is there. So ask the patient, point to face that show how much you hurt right now, record the number below the face they choose. So these emojis are very much useful when how to this use. So use constantly, use the same scale over the time to track the changes in the pain. It helps to guide treatment decision, and we have to evaluate in the if the intervention works. So red flags, objective predictor of the serious pathology. Example is non-wearing weight bearing, or the fever is more than 38.5 degrees centigrade, or CRP more than 20. In the red herrings, it is plausible but misleading history or the sign that distract from the underlying disease, like the trivial fall masking the osteomyelitis. Some cognitive bias check-in is there. So what are the key biases we have to encourage at the bedside? Anchoring bias, like clinging to the initial diagnosis. Sometimes it's viral gastroenteritis despite the rising the CRP and the focal tenderness. Second is availability bias. It over-diagnoses the last dramatic case you saw. Sometimes we in our mind, last OPD we have seen the run of the appendicitis leading to the CT, it led to overuse of the CT scan. Then the confirmative bias, selective gathering data that support the favorite hypothesis. Some professors are very used to see this is their favorite diagnosis. They usually they see that cases only. Then the premature closure, stopping the differential once the plausible answer appears, missing the MICS or the malignancy. The priming effect, sometimes nurse tries not it is a non-case of the constipation, then it makes the clinician under the test for the Hirschsprung enterocolitis. So what are the analgesia required in the first line and what are the escalate we needs? In the mild case, then where less than 3 score is there, we have to use the acetaminophen 10 to 50 milligram per kg orally. We can escalate ibuprofen 5 to 10 milligram per kg. In moderate cases, we have to combine the acetaminophen plus the NSAID, and in severe cases, we can consider the IV morphine and the intranasal fentanyl. So we have to take care of the total maximum dose of the 75 milligram of the acetaminophen, and we have to avoid the codeine in the case of the less than 12 years, and we have to monitor SpO2 to have a naloxone 0.01 milligram ready. Combined red herring in the pediatric practice, just a virus, sometimes mesenteric adenitis versus early appendicitis. Sometimes the growing pains, nocturnal bone pain is signifying the leukemia. In the minor playground fall, while the underlying osteomyelitis of septic hips evolves, functional abdomen pain, early MICS or the IBD when the laboratory abnormal, sometimes catalog anomalies, it is incidental benign cyst on the ultrasound that distract from the primary pathology. So, this background, let us see the case. One 5-year-old playing in the playground and falling 24 hours ago, now weight bearing, FLS is a 3/10, heart rate is 130 and subtle grimace. So we have taken the decision in the apply the modified Koch's criteria, fever, weight bearing, WC more than 12,000, ESR more than 40 and CRP more than 20. So this reports CRP 95 milligram, ESR 70, WC 15, Koch's score is 3. So we have managed urgently by the joint aspiration plus wash out IV antibiotics within 6 hours, and it saves the joint integrity. So what lesson we have learned? Minor trauma was a red herring, objective markers guide the life-saving care. So framework of this case, we have to stepwise algorithm is there. We have to take history, onset, trauma, systemic symptoms, then identify the red flags. It is a non-weight bearing, fever and the elevated lab report. Then the focus examination, range of the motion, what is the change in the gait or the palpation, bedside imaging, ultrasonography for the effusion or the X-ray for the fracture. In the laboratory, we have to see for the CRP, ESR and the CBC, and we have to consult the orthopedic if it is more than 2 red flag signs is present. Case 2, presented 7-year-old girl child presented with the intermittent right-sided abdomen pain. It is afebrile and the normal ultrasonography. Initially, patient was discharged, labeling the gastroenteritis, and the readmission after the 24 hours with the mild fever, CT reveals the omental infection. Pulse of this pain precedes vomiting in the surgical causes. Repeat imaging if the CRP rises or the pain migrates. So in sequence, while the pain follows the vomiting, it suggests the surgical cause. While the vomiting follows the pain, it suggests a medical cause. So localized, not only 5% of localized appendicitis in the RIF on the day 1, imaging threshold, low threshold for the repeat ultrasound or CT scan when label escalate or the examine resolves. So missed appendicitis data sometimes in the 50% in the gastroenteritis, constipation 20%, urinary tract infection 10%, and others is 19%. Case 3, the headache, that is not just a viral. 10-year-old boy, 3 days frontal headache, photophobia, low-grade fever, ibuprofen at home with the partial relief, normal urological examination except neck discomfort or flexion, and this score is 6/10. So red herring, recent screen time increase and the mild dehydration history. What are the red flags? progressive headache intensity, and the nocturnal awakening. Then the meningeal signs is present, neck pain with the flexion, and persistent moderate pain despite the first line NSAID. So here the diagnosis will be, we have to look deeper, bedside approach, assessment by the VRS, FACES or the NRS baseline. We have to document the trigger and associated symptoms. Initial relief by the Brufen 10 milligram per kg orally, or the acetaminophen 15 milligram per kg orally. Escalation if the pain is more than 6 or 10 by persist, and consider IV or intranasal option in the ED. Monitor vitals and the reassess within 30 to 60 minutes using the same scale. Teaching Paul in adolescent, NRS and FACES correlate well. Use the same scale for the trend monitoring after each intervention. So when the pain speaks for hidden symptoms, in the case of the leukemia, Lyme or bone pain in the 45% of the cases, and the night pain at the red flags. In case of MICs, abdomen pain, predominant, watch for the shock signs. Thorax tumors, Pancoast type lesions mimic the shoulder pain. What are the future direction? Now we have heard the robots delivering the human baby. In this case, now the AI supported decision tools. So real-time integration of the vitals, laboratories and the imaging pattern should be there in the future. Wearable non-inception monitors, neonatal trials tracking physiological pain signatures, etc. is there. Then we have to see the multidisciplinary pain teams of the pediatric, anesthesia, psychology and the rehabilitative collaboration. Key messages are: validate the pain first, label later, always honor the child's pain report or the behavior, beware red herrings, minor history elements can mask life-threatening illness, use structural tools, age matched scale and the algorithm reduce the missed serious pathology. Remember, recognize, choose age appropriate tools, CRIES, FLCs, FPSR or NRS, rate, document baseline score, relieve the start analgesic later within 10 minutes of the triage, reassess same scale, aim more than 2 or the less than 4 point drop, then reflect, check for the cognitive bias, anchoring bias or the premature closure. So thank you very much. Thank you organizing team for the giving the opportunity.
Thank you, Dr. QS, explaining such a relevant day-to-day problem in such a nice way and including such real-life cases. Thank you, sir, please. Our next topic is intracranial tension. It will be taken by Dr. Arun Bansal. And it is also a problem where if we miss some subtle signs and catastrophe is very nearby. So Dr. Bansal will explain us to intracranial tension.
Good morning, Team Tamil Nadu. Thank you so much, Kongu Pedicon, for the opportunity to be here and speak on raised intracranial pressure, clinical science monitoring and management. So I bring the greetings and welcome from PGI Chandigarh. So the topic would be how do we monitor and manage a child with raised ICP. So we'll start a small baby, 6-year-old, who had presented with fever and headache for acute onset with altered sensorium and abnormal movements. So the fever was intermittent, low to moderate grade with throbbing headache, generalized and altered sensorium in the form of increased somnolence, followed by abnormal posturing, 3 to 4 episodes in the last few minutes, with other history being negative. So he had a past birth, development, immunization and family history was normal. So in the triage on primary assessment, the airway was open, had a respiratory rate of 25 with normal breathing pattern, saturating normally. Heart rate was 78, blood pressure was 112 by 80, pulses were palpable, ECG was normal, GCS was low with 9 on 15, pupils were equal and reacting, sugars were normal and was febrile. So it was classified as primary brain dysfunction and level 2 emergent. On neurological examination, he had no cranial nerve palsy, power was 2/5 and tone was increased, DTRs brisk, plantars extended. So this was a classical case as a run of the mill which we see with altered sensorium and these abnormal features. So when he presented in ER, he was intubated. First tier neuroprotective measures was started, was given sedative of midazolam and fentanyl, and was loaded with phenytoin and levetiracetam, and 3% hypertonic bolus followed by infusion was given for as an osmotherapy, and was labeled as acute encephalitis with status epilepticus and raised ICP. So the aim of this management was to maintain the optimal hemodynamic and respiratory support, and to provide adequate oxygen and perfusion of the brain, to break the vicious cycle of cerebral edema and compromise cerebral blood flow and maintain adequate cerebral perfusion pressure. So with this background, I will focus on these few things in the next 15 minutes, starting with the physiology. So brain is a closed structure, we know. It consists of the brain matter, CSF, and the blood. So any change in one component will compensate the other, and this will keep the ICP in control. But when this compensation is lost, the ICP rises. The other important thing to note is that the open fontanelle in infants are not protective for raised ICP, and even an infant with open fontanelle can have cerebral edema. So we need to understand what is cerebral blood flow and cerebral perfusion pressure. The blood flow is basically what is the equivalent to the map of in the other organs to the body. So the blood flow remains constant between a map of 50 to 150. The body tries to compensate it. So this is called as autoregulation. When this autoregulation is lost, it becomes direct component to the mean arterial pressure. So as the pressure increases, the blood flow also increases, and if the pressure falls, the cerebral blood flow also decreases significantly. So this is the condition which we don't want our child to land in. So what are the common signs and symptoms? So there could be various causes, because each cause may have different causes of the etiology of the symptoms. So we need to know what are the various causes of it. So I will not go into that. But the most difficult part is that this may not distinguish, because these are very non-specific signs: headache, vomiting, seizure, posturing, pupillary changes, papilledema. So they may not give you the etiology, but they are very good to pick up the raised ICP in these children. So what are the normal values? So they vary between 5 to 15 at different age groups. So anything between 5 to 15 is considered as normal. So what do we label it as abnormal? So anything above 20 is labeled as intracranial hypertension. But if we don't have the ICP monitoring, then any child with signs and symptoms of raised ICP, which we had discussed before, are considered as having a child with more than 20 of ICP. And if ICP is more than 40, it is considered as life-threatening. And what is cerebral perfusion pressure? Cerebral perfusion pressure is the difference between the MAP and the ICP, the mean arterial pressure and the ICP. It's basically required to perfuse the brain, and it's an indirect measure to the cerebral blood flow. We don't have the exact values of what are the values in normal children, but anything above 40 to 50 in infants and more than 50 in children is considered as normal. If it goes below 40, it is highly indicative of mortality. So then if the ICP goes significantly high, we can have, the child can land up in herniation, and there can be various kinds of herniation which are there. And these herniation can lead to the complication of the problems. So coming back to our child, our index kid continued to have seizures. He was started on midazolam infusion at 30 mics per kg per minute, was started on phenobarb and lacosamide, and was shifted to PICU. So now how do we monitor a raised ICP if this child comes in? The gold standard is the ICP catheter. It can be intraparenchymal or intraventricular, but that may not always be the case. So we need to have the non-invasive ICP monitoring, which is there. You can use the CT scan of the optic nerve sheath diameter, NIRS, then you can use the pupillometry, you can use the tympanic membrane, then EEG, continuous EEG, and transcranial Doppler. So various things are available with us which can do it. In our index case, the CT scan was showing diffuse cerebral edema. You see all the sulci gyri pattern are lost. There is loss of sylvian fissure, we don't see that. The ventricles are chinked and just blunted, so we don't see that. So this is a classical case of a child with raised ICP. So the goals of managing, what are the goals? So we need to make the ICP less than 20, keep the CPP above 45, maintain normocarbia, EtCO2 or PaCO2, maintain good oxygenation level, keep euthermia, maintain normoglycemia, sodium should be in the normal range and keep a good hemoglobin levels. And if you have to manage, we need to have certain targets. So we need to control the cerebral blood flow, reduce the brain activity, optimize the osmotic gradient, promote CSF drainage, and allow a safe swelling. So these 5 things are important. So how we can control each of these? How we can control the blood flow? So blood flow can be controlled by the body positioning. So we need to keep the head in midline at 30 degree. Avoid hyperperfusion, so keep maintain the euvolemic balance. Keep the CO2 in the normal range, euvolemia, and keep normothermia. So all these factors are important to control the cerebral blood flow. Then comes the how do we reduce the brain activity, because increase in brain activity can also lead to raised ICP. So give a good sedation and analgesia. Control the seizures by giving a good doses of antiepileptics, and again control the temperature, because any febrile episode will also increase the metabolism and increase the raised ICP. And the spikes in ICP, how they are correlated with the sedation, analgesia or fever. Any cough, gag or hiccups can increase your intrathoracic pressure and reduce your jugular flow and increase in the spikes. Pain and agitation, like in the previous lecture we have heard, is an important part, can also lead to arterial hypertension. Then seizures can increase your metabolic demand and increase the blood flow, can also lead to raised in ICP. Third important part is to optimize your osmotic gradient. So that comes with the control of the serum sodium, blood glucose and osmotherapy. So the osmotherapy is the mannitol and hypertonic saline. Sometimes we need to do the CSF drainage if there is ventriculomegaly, so you need to put an EVD or the body positioning are the 2 things which can control your CSF drainage. So external ventricular drain may need to be placed if the ventriculomegaly is significant. And if there is a mass and it's compressing the brain significantly, then you need to give some release to the brain. So then decompressive craniectomy becomes very important in this case to allow the swelling to have some decrease in the pressures. So this is a summary of the background that how we can manage a child with raised ICP by controlling the various physiological mechanisms. So coming to the tier management of raised ICP, what is the tier 0 management? So give a good airway, control the airway, that's which can cause hypoxia and coughing. Prevent hypercarbia by giving ventilation, and prevent hypotension by controlling the blood pressure. So neuroprotective intubation becomes very important, like we had already discussed why pain and sedation are important, so I'll not go into it, but you can take care of pre-oxygenation, positioning, pre-treatment, induction, paralysis, and then post-intubation. Raised ICP is very common in CNS infections, which you have seen. So what do you target? Whether we have discussed CPP, we have discussed ICP. So we did this study on the comparison of CPP targeted therapy versus ICP targeted therapy in children with acute CNS infections. We included around 110 children of various infections, non-traumatic coma. So what we observed, that the survival was better in the CPP group. When we targeted the cerebral perfusion pressure above 50 millimeters, the survival was better. The children had improved coma scores early, and then their hospital stay was also, PICU stay was significantly less in the CPP group arm. Various sedation and analgesias are there. You can use propofol, midazolam, Keeta, barbiturate, Dex. All these drugs are available with us, which can be used in combination. Temperature, like I have discussed, is very important. Any increase in the temperature by a degree Celsius can increase your metabolism by 10 to 13%. And fever is a potent vasodilator. So it can increase the cerebral blood flow and raise the ICP. Then what's a tier 1 of the specific therapy? It's basically the osmolar therapy which is important. You can use mannitol or the hypertonic saline in various concentration. So each can have a different sodium concentration and the osmolality is different, and their bolus doses are also different in these groups. Which one is better, mannitol or hypertonic saline? Again, we did a randomized trial of 20% mannitol versus 3% saline in children with raised ICP. We divided them into, randomized them into two groups, and there were various infection group patients were there in this study. And we found that children with hypertonic saline had a better control in ICP. This was the hypertonic saline arm. And an early rise in CPP, this is the upper line is the cerebral perfusion arm. So it was significantly different. Similarly, the delta change was important in both significantly different in both the groups. So these the same, the trends and the changes were important. And the composite poor outcome was significantly better in the cerebral perfusion targeted arm than the ICP targeted arm. What are the various steps in the tier 2 management? So you can do the resection of mass lesion, drain the CSF, and do the decompressive craniectomy. So what are the importance of this? There are various adult studies on decompressive craniectomy, which is the decimal trial, Destiny study, Head First, or Destiny 2 trial. They have got various results. Some have shown there is a significant reduction in mortality, but no different in the sequelae. Mortality decreased significantly from 88 to 47%, significant decrease in fertility, mortality. This one has not shown any mortality benefit, but the disability part was not shown any improvement. This is a DECRA study. The largest two studies on decompressive craniectomy are the DECRA trial and the rescue ICP. And the first one has shown no beneficial outcome in the long run. The rescue has shown that the mortality decreases, but they also end up in the vegetative state subsequently, and no significant improvement was there. In our ICU, we looked at the non-traumatic bleeds which had occurred, spontaneous hemorrhage children, and what was the outcome in that cases. So most common was the vitamin K deficiency leading to hemorrhage, and then the difference in the bleed. And we also found that it decreases the mortality, decompression decreases the mortality, but sequelae were there. Any role of hyperventilation? Yes, if the child is herniating. Otherwise, there is no role. And it can provide an immediate effect which can last for few hours, because it causes cerebral arterioles dilatation, and the PaCO2 falls down, and then when this PaCO2 falls down, the cerebral's arterioles blood supply shrink to the brain and can decrease the ICP. But prolonged hyperventilation is not recommended. So we don't recommend it after few hours, few minutes. So hyperventilation, if has to be given, is not to be given for more than 5 to 10 minutes. Any role of prophylactic and anti-seizure activity? So prophylactic anti-epileptics are not recommended to prevent late post-traumatic seizures. But yes, if seizures are there presenting early, or you can start and then stop it after within 7 to 10 days. So it can prevent the post-traumatic seizures, but it may not be a good wise decision to continue it. And then the tier 3 management consists of barbiturate coma and therapeutic hypothermia. So these hypothermia trial has not shown much of the benefit in the outcome. Barbiturate coma, the thiopental coma, we routinely do in our ICPs if it becomes refractory raised ICP. So in the end, I would summarize that acutely a rise in ICP can be a life-threatening complication. So early recognition becomes very important. You need to have a multimodal neuromonitoring, because no single tool is a diagnostic of all the parameters. And early treatment and stabilization is very crucial. And the tier-based approach to control the hemodynamic and prevention of secondary brain injury is crucial. Do a neuroprotective intubation, give a good hyperosmolar therapy, and that too in the 3% hypertonic saline is safe and better. And hyperventilation is reserved only for impending herniation, and then tier 2 and tier 3 can be stepped up. So thank you so much from PGI Chandigarh.
Thank you, Dr. Bansal, for excellent and comprehensive presentation. You have highlighted so well that raised intracranial pressure is a true pediatric emergency where only timely intervention can mean the difference between life and death. Thank you. Any questions?
Thank you, sir. There are no questions at the moment. That was quite a comprehensive and insightful lecture from both our speakers with thoughtful contributions from our chairperson. Thank you, sir. Kindly accept a token of gratitude from our side.
Thank you. Thank you, Team Kongu Pedicon.
We request the chairperson, Dr. Joginder sir, to present the speakers with tokens of appreciation. I request Dr. Yogesh sir to present our chairperson with the token of appreciation. Thank you all. I now invite Dr. Rajendran sir, State President of the IAP, to introduce the next session. The next session is the Dr. Jayarajaya Nadar oration, which will begin shortly.
A very good morning to you all. I request everybody who are outside also and who are standing at the back to come and please sit down, because we are going to have the prestigious Jayaraj Ayanadar oration. I request the organizers to kindly communicate to the other hall in order to stop their activities, and everybody should come here for the oration. Request everyone to please come and occupy the front seats for the oration. We'll be starting the oration soon. Dakshu. We'll be starting.
May I now request the delegates to kindly be seated for the most important session of Kongu Pedicon 2025. On behalf of IAP Tamil Nadu State Chapter, IAP Coimbatore Branch, and the organizing committee of Kongu Pedicon 2025, we take immense pleasure and pride to welcome you all for this most prestigious event of Kongu Pedicon, the Dr. Jayaraj Ayyanadar oration. To deliver this session, this year, we have our teacher, the most respected, the most beloved, Professor Dr. Indumati Santanam. I request Professor Dr. K. Rajendran, President IAP Tamil Nadu State Chapter, Dr. Narmada, Honorary Secretary, IAP Tamil Nadu State Chapter, to award the Jayaraj Ayyanadar Medal to Professor Dr. Indumati Santanam and do the honors. I request Professor Dr. K. Rajendran I request Dr. Narmada, Honorary Secretary, IAP Tamil Nadu State Chapter, to introduce the oration. I request Honorary Secretary to introduce the Dr. Jayaraj Ayyanadar oration.
Yes, ma'am. Professor C. Jayaraj Ayyanadar was one of the senior-most pediatricians of yesteryears who hailed from the southern Tamil Nadu. He chose to become a pediatrician under the guidance of Professor S.T. Achar. He started the pediatric department in Kirpak Medical College and was instrumental in starting the DCH course. He retired as professor and HOD of pediatrics at KMC Chennai. He was a very humble person, a shrewd clinician, a very good teacher, and a very soft examiner. After his sad demise, his family members contributed a sum to start an oration in his name. It was unanimously accepted by IAP Tamil Nadu State Branch. To perpetuate the memory of Professor Jayaraj Ayyanadar, our state branch of IAP has instituted this prestigious oration award in his name. And this year, Professor Dr. Indumati Santanam ma'am will deliver the oration. Over to you, sir.
Thank you, ma'am. I request President IAP Tamil Nadu State Chapter, Professor Dr. Rajendran, to introduce the orator.
Good morning to everybody. And I'm really happy that I introduce our today's orator, Dr. Indumati Santanam. She was my teacher, and I can say it's a mentor for me in emergency. And Dr. Indumati Santanam actually currently is a project director, Regional Collaborative Center, National Health Mission, and is a state trainer for prayer module, Tamil Nadu, as well as he's having all over Tamil Nadu. He has organized almost thousands of Prema module also, and currently he is an editor-in-chief praying for low and middle income countries and pediatric emergency of medicine in India, and is currently chair pediatric emergency medicine. Special interest is Society of Emergency Medicine India's group director also, and Best Doctor Award for 2011 for her in MGR University, and in 2019 Government of Tamil Nadu also they awarded, and it's a great pleasure and privilege I think it is a honor also. I can introduce Dr. Indamadi Sandana Madam. And thank you very much, and a big applause for her. Thank you. Madam, now you can proceed, madam. Yeah.
I request everybody standing in the back to kindly come and sit in the front, and also the postgraduates at the outside to close the display in the poster, and please come and sit.
Good morning, everybody. Before I start, I wish to thank Dr. Rajendran, Dr. Sashikumar, the scientific committee and the organizing committee of Kongu Pedicon for this tremendous honor. I feel blessed and humbled. Thank you so much. I also wish to congratulate Team Kongu Pedicon for the amazing scientific academic feast, delicious food, extremely enjoyable cultural program. Yesterday, it was a most amazing inauguration with lots of camaraderie and love and affection. People staying here more than beyond 10 o'clock. It shows, it's a testimonial to the success of the state conference here at Tamil Nadu, conducted by the Tamil Nadu State Chapter. My best wishes for the National Pedicon here at Coimbatore in 2027. Congratulations and best wishes. So before we start again, the prem which we are, prem means love in all Indian languages. And this was used as an acronym, Pediatric Resuscitation and Emergency Medicine, started way back in 1997. It's a legacy, and many people wonder what is different between PREM and PALS or APLS or BLS or all the other courses given by Western guidelines. But what we did seemed a little different, and many of you all have participated, those in the audience have participated in creating this legacy, and many of you all are still in this journey of establishing PREM in Tamil Nadu. Let's go down memory lane. So in the early 90s, when we were students, hospital ICH mortality was high. OP census was, if you look at our MRD, old MRD records, it will say 6 lakh to 9 lakh children were hitting the outpatient department every year. More than 20,000 would be seriously ill on arrival. At that point in 1997, Dr. J.M. Subramaniam, who was the then director, said she allocated space in the outpatient department. She put some glass partitions. She posted me. I was the junior most assistant professor. That's my reason why I entered emergency medicine. I was the only one who could not protest. Exclusively. She said, you have to be there between 7 and 1. You cannot go anywhere. You cannot attend audit. You cannot attend any program. You have to be seated. You have to be available there in that room. She posted nurses exclusively, and she posted postgraduates. Her only instruction was secure IV and shift, because that was what was considered resuscitation in those years. A lot of challenges. There was no infrastructure, just an empty room. I was completely untrained, clueless. My nurses were untrained. Postgraduates knew nothing. And post-resuscitation, or if at all there was any resuscitation, no facilities. The PICU also was having very minimal infrastructure. It was like being thrown into the deep sea without a life jacket. We collected data in 1999. This was published in the Journal of Pediatric Critical Care Medicine. And we found that children presenting, this is no brainer, children presenting with respiratory failure and shock had high risk of mortality. In 98, a very senior pediatric surgeon, she was a cardiothoracic surgeon, Dr. Srimati, she overhears in Delhi, JICA wanting to discontinue aid to India. So she diverts them to ICH, she brings them here, and she organizes the first equipment donation to the Institute of Child Health. And based on this donation, the entire hospital, for the first time, we see warmers. The first time we are seeing resuscitation trolley, monitors, pulse oximeter. We have not, our generation had not seen pulse oximeters. We had not seen multi-channel monitors. This is for the first time the hospital received such an aid in 1998. But however, amongst all the challenges, the worst was standard guidelines. See, we were not having any indigenous guidelines. We had only to see the Western guidelines. And when we used those guidelines, children died. There was lethal deterioration. For example, here, When we were students, the first drug of choice in asthma management, status asthmaticus, was aminophylline. Loading dose of aminophylline used to be given, and they'll vomit, they'll have tachycardia, but then they'll resolve. In the 90s, late 90s, in the emergency, somebody donates nebulizer. Then first nebulizer, first time we are seeing a nebulizer, the entire hospital seeing the nebulizer unit, and it makes the sound of a generator. You can't hear people speak. It was so loud, you can't see the fumes, but children with asthma, with these, were getting better. So, the nebulizer, salbutamol, replaced aminophylline, IV aminophylline. It sounded like a better drug. But a huge problem. One day, this was in the early years, a Monday morning, busy outpatient department. My colleague, a very knowledgeable colleague from the OPD, refers, they used to send a small drug slip, nebulized salbutamol. And this child has had fever for 5 days, breathlessness for 5 days, is looking, today I can say unresponsive, but his child is floppy. So because she says respiratory distress with wheeze, and she has clearly given instructions, so we nebulize. And believe it or not, this child crashes. That is our first thing. And later we documented this. You can see this child referred from the asthma clinic. You can see the 100% saturation behind. This is a well worked up case for asthma. As we give the nebulization, you can see the saturations are dropping, and eventually this child crashes. Of course, we revived this child, but why was this happening? In the era, for the youngsters here, there was no internet, no Google search, no AI companion, and we had to search for this. Why is this happening? There was no published evidence why salbutamol, which is a drug of choice in asthma, is causing cardiac arrest. So we had to make changes in the protocol. So we discovered the bad way, the wrong way with crashing children. The children with respiratory distress are not easy. They can be hypoxic, they have to be handled very appropriately, and we modified how we approach a case with respiratory distress and how we recognize asthma. The only place where we are going to give salbutamol is asthma, how we recognize, and we actually gave a guideline saying, like, cigarette smoking is injurious to health. This protocol says salbutamol can kill, so that you will be aware that you have to take precautions. And anything asthma mimics should be avoided. Give your salbutamol with care. And we also found that simple NRM was not going to be useful in life-threatening or near-fatal asthma. You give CPAP, you have to use an NIV or Jackson-Ray circuit. And we also found that asthma has various levels of severity, and one of the severity features, which is not mentioned in other guidelines, is that they have non-convulsive status. When you look at their eyes, they are having seizure-like activity, and they have vasodilatory shock due to severe hypoxia. The physiology of all this is given in journals like New England Journal of Medicine, the journals of physiology, etc., but it's not available in clinical textbooks. And we have to address these before you have a successful resuscitation. So this is as far as asthma is concerned. So the modifications were made. Recognize non-convulsive, recognize vasodilatory shock, use CPAP in these situations, treat the shock. So we modified the asthma protocol. Today we have, for the last 15, 20 years, it's a zero mortality when we have these asthma protocols. Another thing, child comes with, somebody says it's a febrile fit from outside, we give a diazepam, child has become apneic. By the time the child is given phenytoin, child's heart is crashing. In fact, we used to have something called mid-phenytoin assessment, just to pick up that sign of worsening or progression to cardiac arrest. So why were routine anticonvulsant drugs causing potential lethal complications? So then we found to avoid this, we have to recognize the physiological status, where this child is, and then concurrently look at the focused history, whether it's a hypoxic event or a shock event or a primary neurological emergency, seizure activity. So check the focused history. Check whether they are having, these children are also having vasodilatory shock triggered by hypoxia or sepsis. So check. So this is the only protocol where shock is addressed. And you can see, is it large volume, small volume, do you need ionotropes, etc. So the status epilepticus protocol has a very important component, the cardiovascular dysfunction. And then 70% of children who present to the Institute of Child Health have unrecognized non-convulsive status epilepticus. This can be primary, it can be secondary, as I said, in a near-fatal attack of asthma or severe dengue or severe bronchiolitis. So For one, we'll give the drugs, for the other, we'll correct the hypoxia and shock. So this protocol also addresses the difference, the presence of non-convulsive status epilepticus, sometimes how to manage this if recognized. So we looked at our data, and this was published. You can see it's a modified status epilepticus protocol, and we look at cardiovascular, CD is cardiovascular dysfunction, ARF is acute respiratory failure. So the protocol is, and subtle status epilepticus. So we look at all this, we manage, and you can see our mortality. From 2006, it's 5%. By 2010, it's less than 1%. So the mortality has fallen. In fact, status epilepticus protocol using these guidelines became a zero mortality protocol. Now we come to another important, often, there's a lot of controversies, shock protocol, because the guidelines were swinging like a pendulum. In the early 2000s, the American College of Critical Care Medicine recommends 60 ml in 15 minutes. And then came the 2020s, no fluid bolus. So which is right? Which is correct? This is given by the ACCM, this is given by a South African trial. So where do we stand in shock protocol? So what we did a trial. If you can see this earlier, this trial by the American College of Critical Care Medicine is designed by somebody called Joe Carcillo. So he connects with us, and then we design a study. And this is a landmark study as far as we are concerned, because it answered a lot of questions in how we manage seriously ill patients. This is actually a shock protocol where we compare two fluid regimens. But what we did was, because of our high incidence of pulmonary edema and hepatomegaly in our population, they're having severe cardiovascular dysfunction when they come in shock. This protocol was designed to address these issues in addition to the fluid resuscitation. So if you see features of pulmonary edema and cardiovascular dysfunction, we inotrope using dopamine, we intubate. So these are the modifications we made in the shock protocol, published as a randomized controlled trial with level 1 evidence. And what tool did we use to recognize pulmonary edema and hepatomegaly? We used the rapid cardiopulmonary cerebral assessment, which was modified to look for this. And conventionally, pulmonary edema is basal rolls or hepatomegaly. That's what everybody would say. But we found additional new findings, many, many more. This is not a teaching session. Just to tell you, fighting the mask, asking for water, combativeness, or gallop, muffling, so many other signs were identified in this, using this tool. If any one of these findings were observed, we changed our management. And using this, this protocol for this study, our mortality dropped significantly compared to published data at that time from other institutions. We found our mortality had fallen significantly. So our protocol this again is being instituted across the state. First, you recognize whether it's small volume or large volume, use CPAP, don't use non-breathing masks, don't break the bolus, recognize pulmonary edema and hepatomegaly, inotrope, intubate, and continue fluids based on what is happening to your cardiovascular dysfunction. And one more innovation was, we also found that late shock, as discussed in, let's say, IMNCA guidelines, prolonged CRT, cyanosis, unresponsive. No, recognition should be early in the queue outside the OPD, and this was also, we formed a group, South America, PEM physicians from South Africa, South America, Australia, Singapore. We all got together and they reviewed our data, and then we published this in the BMJ in 2022. Now we go on to something like CPR. CPR is, you can say it's BLS, chest compressions, but there's lots more than chest compressions to CPR. What is the etiology? How much volume are you going to give? How are you going to give the epinephrine? What is the response? So this is the PRAME process used for CPR, documentation, interpretation. How are you going to progress with this case? And this particular case sheet, which you're seeing, is a very important case sheet. This happened in 2016, when a group, 2 postgraduates in a busy dengue epidemic are managing CPR for a child who presented with CPR cardiac arrest from a different hospital, from a referral hospital. So on arrival, this is their resuscitation. 7 years later, this case comes up from the court of law, and they are accusing ICH, claiming damages for 50 lakhs. So this case sheet is traced, and it's shown to the judge, and he waivers the case. He says, Children's Hospital Emergency Department has managed it appropriately, and they are blameless. So this is the value of what you can achieve if you document even CPR and follow the process as recommended by the PRAME guidelines. Another common error is, people try, postgraduates immediately intubate when a child is presenting in cardiorespiratory failure. To be avoided, we have a proper procedural protocol for physiologically difficult airway where we ensure zero bradycardia during intubation. It's a 10-step, it's multiple steps, but you can't intubate on arrival. This again is a PRAME modification. So over the next 10, 15 years, massive crowds, hemodynamically unstable children, every month, only for a month, a PG is posted only for 1 month in his 3-year process. And even if he does what is right, there's a risk of lethal deterioration. So this was a virtual Kurukshetra. We're fighting death, and you're also fighting your internal battle with your hunger, your lack of sleep, your exhaustion, but you have to do what is right every single time. In this battlefield, we developed the rigorous 4-step process, the PRAME process. And much of it is every protocol, you can follow any protocol, but as you're giving the intervention, is this child progressing to cardiac arrest? And this is an assess, document, interpret vital signs, derive physiological status using the PRAME triangle. So this process is a practiced muscle memory, which has to kick in even if it is 2 a.m. and your loss of sleep. And this process made our PGs warriors. So, and this over 10 years, you can see the statistics are in the department. You can see the mortality has dropped significantly. This is a decade-long, it's not a 1-year thing, it's a decade-long drop in mortality. And every day, postgraduates are independently managing, and many were intubated. And you can see this tremendous work by the postgraduates of the Institute of Child Health. This came and became the first edition of the Pediatric Emergency Medicine course, was published so that more people can learn about it. This team took it forward with the Child's Trust. Many people from across India, we took it over to Sydney and presented I think it was very well received. And when a proposal was submitted, the unit became a department. So in 2010, we have the first pediatric emergency department, and in 2011, the GO was passed for having a postdoctoral fellowship under the MGR Medical University. Now, along this period, remember the 1998 donation by the government of Japan. Japan always has this thing. Every now and then they'll send a team of parliamentarians, women, they'll have committees from Citizens Committee, and they were monitoring our, the emergency data from the Institute of Child Health, and they donated 100 crore JICA OPD and emergency. So this is to the credit of the entire hospital and admins at the time. And the equipment was also donated in this, in this process. And because this was being donated, they also invited, I went to Japan to learn how to develop. They had a kind of management training class for 2 months, how you can get solutions for problems in your hospital. So they taught us that process. At the end of it, you have to generate. About 8 countries were selected, and we went and projected. We had to learn, and we had to identify solutions using their methods. And I projected innovative strategies to reduce mortality in the outpatient department for children presenting with fever, because mortality in our hospital is sepsis. So how to identify early, and that is why the paper which we later published in the BMJ came to being. Meanwhile, this JICA plan is recommended by the JICA to the then secretary, special secretary, Dr. Sendil Kumar. Today he's a health secretary. At that time, they recommended and said this has to be implemented. So Dr. Sendil Kumar advised me to submit it to the TANI, and the TANI for Tamil Nadu Innovative Initiative Fund. The State Planning Commission sanctioned 5 crores for establishing the skill lab to train undergraduates in these strategies. Today, thanks to the Director of Medical Education, who was, fortuitously was the Dean, Madras Medical College 2 years back or till recently, he sanctioned undergraduates today, 750 undergraduates, introductory batch, the pre-final and final batch, come for training at the skill lab. Even if I go tomorrow, there'll be a batch waiting. So thanks, sir, for making this possible. So in 2016, we have 2013, this book, the second edition of the PMC was published when I was at Dharmapuri. And at that time, there was an opportunity. The International College of Emergency Medicine in South Africa, they invited for a pediatric emergency medicine course. And when we advertised, apparently the organizers advertised the course, instead of 30, 40 delegates, 90 delegates turned up. So for such a huge group of participants, we had to train additional trainers. And we were only 3 of us going from India to South Africa. So I had to conduct a TOT for the department in Cape Town, Singapore, United Kingdom, and Australia. So and it was like going for an exam, because we are presenting our course, our workshop, and our PREM process, and they have to accept it. In 2017, they conduct their own PMC workshop, and you can see they're using exactly our slides. You can see the MMC logo there, and they are talking about it, and they're all senior professors. They are demonstrating with mannequins how it should be done. You can see how, like a postgraduate, one professor is standing, the other one is holding the child and showing them how the Jackson race is held and how the assessment and process is being followed. Now, some of them came over to the emergency in Children's Hospital, and then our trauma data was taken, and they formed a collaboration. This was published in the BMJ very recently. So now comes the National Health Mission. We had an amazing mission director at the time, Dr. Darius Ahmed. He was starting the Tamil Nadu Accidents and Emergency Initiative across the state. But they were focusing more on trauma. Now, how can we enter into the trauma module? So we have to present our trauma data. So I compiled the trauma data and showed this video. This subsequently earned, PREM became the 6th pillar of TAI, Tamil Nadu Accidents and Emergency Initiative. We also got our emergency department upgraded. They sanctioned funds, and the upgraded old emergency became upgraded due to TAI funds. Today, even to this day, they give us 1 lakh operational cost to run the course. So thank you. Thanks so much. So just see this. Thank you. This is teamwork. It's not one person's work, but we captured it and captured the attention of the government. And so this was sanctioned. We had to strengthen infrastructure equipment for PREM, implement protocols, train doctors, engage the administration, report daily performance, a lot of work. PRAME has to become government policy. But then before we implement a policy, we have to evaluate the gaps: infrastructure, central oxygen, availability of equipment, drugs, consumables, in doctors, nurses' knowledge in secondary care hospitals, whether they are maintaining uniform protocols, because in GH levels, the scoop and run mindset was so well entrenched for decades. So what do we do? So in a CRM visit to Thiruvannamalai, this is a Thiruvannamalai visit, you can see this is a crowd in the outpatient department. There's not even doctors, nurses are managing. I'm talking about way back in 2017. And children can get lost here. Where are they going to find space for resuscitation? The entrance is dark, casualty entrance is dark, there's no central oxygen lines, etc. And you can see unattractive and poor equipment available for resuscitation. You can see this. Much of it is broken, it can't be used, it's dirty, it's dusty, and how can we resuscitate children here? And there is no infrastructure inside the wards either. There was simply piling of patients. I'm talking about pre-COVID, long before. Now, and when we looked, we found the crash carts, there's no organization, and aseptic precautions not followed. The humidifier water here has not been changed in many days. And here is a child with trauma. We saw the picture in, in some earlier Thai group. You can see there's a lot of well-meaning doctors and nurses standing there, and they're giving IV. But actually this child, when it comes to the Institute of Child Health, has C-spine stabilization, has intubation, has shock correction, etc. There's a lot of protocol. There's a big difference between a GH level and the medical college level. It's not to say that we should do it, but we have to take this care to the periphery, because these doctors are interested in managing the patient. How are we going to train them? And we find a lot of junior doctors. See, the big trained people are not at the entrance at 2 a.m. or 3 a.m. It's the junior most doctor, and they were untrained. And nurses, very well-meaning, but again, they are not trained. So what solutions? So in 2017, the first GO for PRAME was passed. 28 district headquarters hospitals, PRAME units need to be established, and 4 nurses were recruited for each PRAME unit. And 7 crores was allocated for these 28 hospitals, and we are just evaluating what equipment reached. I'm talking about, again, pre-COVID. And we told them how to set up the PRAME unit in the ground floor near the entrance of the hospital. And by 2019, 2 years later, the PRAME GO 539 is passed. In this, we standardize the logo, the mission statement: low-cost, innovative strategies for saving young lives in the critical hours with zero delay. So this becomes the logo where patients know here resuscitation will happen, whether it is a medical college hospital like Thiruvannamalai as shown here, or Pennagaram, a GH, which is 2.5 hours from Dharmapuri Medical College. The logo has to attract patients. They have to be aware that something like this is available. They should not be rushing helter-skelter in the case of an emergency. How to organize their consumables, how to organize their equipment, their crash carts, how to standardize. All the 30-odd protocols are standardized and endorsed by the government National Health Mission and passed by this GO. How to use a K-sheet. So this K-sheet became the standard tool with which will help them manage patients. Between 2017 and 2019, courses, the pediatric PMC courses were conducted in all these district hospitals. We went and did it everywhere, engaged with the admins in their hospitals, and telling them that it's a good thing if you can do some things for these children. Many were convinced. I mean, the hospital admins were very much for resuscitation and setting up PRAME units. And this training continued on into the Institute of Child Health. Nurses were trained, and logbooks, etc. This is a formal training program. The PRAME app was launched. It was created by an IIT professor, and we started collecting data for the first time in pediatric resuscitation and emergency medicine. You can see the number of cases which are being reported: dengue shock. You can see the zero mortality, status epileptic. So across the state, all those children who are being managed over 2017 and 2018 and 19, you can see the number of cases and the single-digit and very low mortality rates. Between 2015 to 2019, we collected data pre and post PRAME, and we from these 28 district headquarters hospitals, and find a trend wherein the the hospital admissions are increasing, but interfacility transfers were falling, which is a good thing. Except for 5 hospitals, the others are doing very well. But all this crashed, and COVID came, so we had to now regroup, think how to rewrite the PMC, and it got converted to the PRAME because we had as per GO, I had to create a PREM manual, and we had now collaborators from the PREDICT team in Australia, the South African team from Cape Town. So a lot of them came together in the, during COVID, and we rewrote the book, which is a PREM for low and middle income countries. Now, these Westerners integrated the PREM process into the ATLS. They already have the ATLS, but how the PREM can be used, how the PREM triangle can be used for critical thinking, how speed and process should be implemented, and how to avoid any judgment errors. Also, this book has about 30 odd videos which shows you real-time resuscitation with explanation enough that undergraduates can understand. And this, as I mentioned, is based on GO 539. Now, all this was fantastic, but post-COVID, we had a meeting in the NHM with all the ED HODs, and they were given an app where a question is asked and they have to answer. It will come up as their responses on the screen. So the questions we asked for the ED HODs, as far as PREM was concerned: do you have a separate PREM unit with a resus trolley, airway stool, adult bag well mask? This is a setup which we gave, a very basic setup, but a very successful setup which is still in use in Dharmapuri Medical College. You can see the date there, 2012, and this was used as a standard for how you're going to organize your PREM, and this was asked to all the ED HODs at the time in 2022. Their answers were, here were their responses. So they have this is what they call the PREM unit. It is not as per guidelines. It's a mattress, a pillow that will kink the airway. There's a ventilator, no bag valve mask. And you can see with the head railings, you cannot truly resuscitate these children. So PREM guidelines were not present in setting up the PREM units. And which floor were these children shifted for resuscitation? So more than 50% are saying first floor, second floor. Some actually said fifth floor. And the lift is poorly functioning. But this was the truth. This is what had happened post-COVID. So at the inauguration of the MD Emergency Medicine, we were the first state, Tamil Nadu was the first state to inaugurate MD Emergency Medicine. Every hospital, 30 hospitals were given 5 seats. I think the DME would have been part of this. We had 150 seats, and this was inaugurated at Omandurar Medical College. And I gave to the government a process. That is, training should be given, mentoring of the PREM unit should be done, and death audit for PREM should be conducted for us to start this initiative again. So you can see all the members, the health minister, the health secretary, and many others who are part of this meeting. And so PREM training came into being. So what exactly do we train? We help them try to make decisions. We train non-pediatricians. You don't have to be a pediatrician to do resuscitation. You can be an orthopedician on duty, you can be a physiologist or microbiologist, but you should be able to do the basics for this child. How to implement the PREM process, how to ensure that you don't have mortality. The lean management is a management principle. 5S Kaizen in organizing the PREM unit, how to avoid hospital-acquired infection, how to focus on documentation, which is very lacking, and how to maintain a registry and daily reporting. So this is what we focused in the training. And this you can see is the proceedings have been sent by the NHM. If you actually read that order, you can see PREM resuscitation trolley. You can actually see hand sanitizer on either side of the trolley. They have actually given the guideline. As you move towards the patient, you should be using the hand sanitizer, which is placed on either side. The PREM case sheet should be at the foot end of the trolley. You should have a bag valve mask, adult bag valve mask, but you should have an infant round mask. So everything is, this is an order, and see the support given by the NHM in establishing PREM and how to do it in the individual units. And the daily reporting was organized, and how this is the physiological status. Not a child comes with scorpion bite, is not scorpion bite, is not an emergency, but is this child stable, is this child in cardiogenic shock, is this child in autonomic storm? So the Google platform was organized in such a way they could give this kind of reporting. And with Telegram groups and WhatsApp groups, we monitored the units because we had to encourage them to ensure compliance. So you can see that every day we had to supervise whether they were submitting reports or not. And we also checked out how they were reporting. You can see some units like Dharmapuri is submitting 129 cases, but in a month some other institution is barely reporting any PREM cases. So, so we had to highlight and tell them, you guys better improve your reporting of your PREM cases. And we also had, as I mentioned, the death audit, and we started scanning the case sheets and giving them inputs as to how to improve their management using their death, the mortality case sheets. Based on this, we changed we found that 25% of deaths was happening at home and in transit. So they were missing children who presented with fever or diarrhea to the OPD. So we integrated the PRAME triangle into the OP ticket. So this again has become standardized, and all units, secondary care and medical college hospitals are now starting to use this modified OP ticket. In 2023, mentoring visits started. You can see again in a GH, the same pediatric cot. It is nowhere near the oxygen, and you can see the oxygen suction lines are actually covered by some storage. So all this had to be ordinary. We had to teach the doctors, and this is happening since 2023 till date. These mentoring visits are happening across the state, funded by the National Health Mission. So we looked at our data. Every year we monitor the data, and we find that in 2022, you can see about 24,000 children are being seen, and the mortality is steadily decreasing monthly. In 2023, more cases have been entered, about 49,000 children plus. The mortality is 0.4%. And you can see the number of cases they are bringing under the PRAME for all emergencies is increasing, and again, the amazing low mortality for these cases in all these as based on mortality data. In 2024, you can see more cases, about 65,000 plus cases are being seen, and the mortality has dropped to 0.3% on an average. And thank you. So this was awarded the best governance award by an organization called SCOSH. The PRAME received its recommendation from an outside external source. Now this you can see on the website about pediatric resuscitation and emergency medicine. You can see that 97 PRAME centers across the state under the Thai department, 0.4% mortality at ICH Apex Training Center. We are training doctors and nurses. The initiative is awarded SCOSH Award, and this year 17 more new hospitals have been identified in accident-prone areas to strengthen Thai PRAME centers, bringing the total number of PRAME units to 113. So this is an ongoing initiative. We have a lot to achieve, and we are still on the journey. And in this journey, we expect all those who are part of building this legacy, all those who are part of the journey, who remain in this journey as associate professors, heads of departments, and in corporate hospitals, for all to join us and help us achieve greater, to sustain this legacy in the future. Pediatric resuscitation, an emergency medicine triangle, a clinical tool to facilitate critical thinking by the first. Pediatric resuscitation, an emergency medicine triangle, a clinical tool to facilitate critical thinking by the first responders during the golden hour. Large volumes, late presentations, and advanced critical illness are common in middle-income countries. This video shows how frontline doctors can successfully resuscitate incredibly sick children without advice from pediatric intensive care physicians, without advanced investigations, invasive lines, or access to mechanical ventilators. On the eve of the 79th Independence Day, we succeeded, we won the war in Operation Sindoor. We destroyed made in USA, made in China, made everywhere else by weapons developed, innovated in DRDO, ISRO, etc. It was a war we won by Make in India. I do believe that we can save lives by using those concepts, those content, science that we developed in our country, which we should be teaching the world, and we should be saving lives, reducing our underfire mortality. Thank you and Jai Hind.
Dear friends, let us rise and give a standing ovation for our excellent work in pediatric emergency, as well as poor, needy children. And I can say she never joined in a private institution. She is doing lot of work in pediatric emergency. Thank you.
Dear ma'am, your involvement and dedication in treating critically ill children over decades has been literally a tapas, and that is an understatement. Your passion in training young doctors and nurses for treating sick children has bred thousands and thousands of equipped and excellent pediatricians, and this stands testimony to the same. IAP Tamil Nadu State Chapter takes immense pleasure and pride in conferring the Dr. Jayaraj Ayanadar Oration Award to Professor Dr. Indumati Santanam.
Thank you, ma'am. Thank you sharing for your experience with us. Now we are moving on to the next session. We are inviting Dr. Aruchami Lakshmanasamy to chair the next session.
Good afternoon, all of you. So today we are going to discuss about obesity to anemia, and first session will be by Dr. Preeti Galagali. We used to talk about obesity to anemia, which are the common things we are seeing in the children nowadays. One side is obesity and other side is anemia. So I like to invite the madam who is from Bangalore and a gold medalist to have a speak. Thank you, madam.
Good afternoon, everybody. It was indeed a mind-blowing session by Dr. Indumati, and like most of you in this hall, I was totally floored. Adolescent nutrition. What I'm going to do in the next few minutes is to give you a bird's eye view, because totally understandable that talking about obesity to anemia is no joke in the next few minutes. Coming back to our traditions, which we have been re-emphasizing again and again during these conferences, eating right from the kitchen is almost extinct now, and very soon the joint family system is going to become extinct too. What is in there is feeding from the apps and also family time, which is defined by digital media with less of physical activity and more sedentary activities. And yes, India is in a state of nutrition transition. We often talk about suggested reading at the end of the talk, but here I am talking to you to read these IAP guidelines, fantastic guidelines on junks, nutritional anemia, obesity, digital wellness, and adolescent-friendly health services to get a real overview of obesity and anemia in adolescents. So in the next few minutes, we will go through importance of adolescent nutrition, the current status, a few practical tips regarding anticipatory guidance and clinical management, and innovations which are there present right now and in the pipeline. The Comprehensive National Nutrition Survey revealed that adolescents, 28.4% are still anemic, overweight around 6%, shocking pre-diabetes in 10%, and 5% with hypertension. So lots of work for all of us to do. Adolescence is a nutritionally vulnerable period. The demands are high, and if these demands are not met, the consequences can be grave. We all know that there's a gain of 15% of adult height and 50% of adult weight. There's the growth spurt, the gain of 45% of adult skeletal mass, puberty, menarche, and increase in muscle mass sets in. And in addition, adolescents love the dopamine kick. They love tasty food. They love the high-fat, salt, sugar food, which we don't want them to have. And of course, they give a lot of importance to what their friends think about what they eat, because they are concrete thinkers. They do not think about the future consequences of lifestyle diseases. The vulnerability to adolescent nutritional disorders increases with those with infection, chronic physical and mental disorders like diabetes and depression, and also those who play sports, who are pregnant. 23% of our adolescent girls are pregnant, those who are lactating, and those who follow fad diets. There are multiple socio-ecological determinants of nutrition which actually track from childhood into adolescence. And you can see that when we talk about adolescent nutrition, we should also re-emphasize on childhood nutrition. Inadequate nutrition because of poverty, illiteracy, early childbearing, worm infestation, poor growth in childhood, gender discrimination, and adverse childhood experiences, in addition to the nutrition transition and the excessive digital media. If we can't control them in childhood, we are going to have a tough time in adolescence. And to add to that, there's the specific adolescent behavior because of their reward-centric behavior, also their body image concerns in 25 to 85%, leading to disordered eating. And this is Indian data from 10 to 30% of adolescents who miss breakfast, binge on junk food, soft drinks, caffeinated beverages and alcohol, fad diets, and also emotional eating when they're under high stress. And we saw COVID obesity occurring with corona anxiety and coronasomnia during the COVID epidemic. Inadequate physical activity in Indian adolescents as high as 70% due to increased sedentary activities. I was talking to you about the multiple socio-ecological determinants. So it's not only about the children, the family, the school, but it's also about the community. Are there playgrounds? How many junk food, how easy is junk food available? And what about the policy? Are there adolescent-friendly health services? What does the legislation say about front-of-pack labeling? Is the media regulated? Is advertisement regulated? And the national nutrition programs like RKSK, RBSK, Anemia Mukt Bharat, Poshan Abhiyan, great programs showing great results, but what is the implementation? And now coming from tracking from adolescence into adulthood, so nutrition plays a role in not only diabetes mellitus, cancer, metabolic syndrome, osteoporosis, caries, eating disorders, and unhealthy gut microbiome in the adolescent age group, but it also tracks into adulthood. We are all familiar with the development of origin of adult disease hypothesis. Adolescent undernutrition leads, who later becomes an undernourished mother, gives birth to a IUGR baby who is compromised, has compromised physical, mental, and social health throughout the lifespan, but also a neuroendocrinal fetal programming taking place, leading to metabolic syndrome, and also mental disorders leading to premature cardiovascular disease. So it's time to put more attention to the adolescent pregnant mother and also to the father. So anticipatory guidance should be the rule of thumb in adolescent medicine and in pediatric care. We must emphasize on annual wellness visits, annual hemoglobin, because of the high prevalence of anemia in the adolescent age group. And we often know that anemia may have an irreversible effect on the cognition, which matters such a lot in the adolescent age group. And of course, do a metabolic profile for all obese adolescents. The National Institute of Nutrition actually spelled out the dietary recommendations for Indian adolescents, and I think we all need to have this on our table in the clinic. 50 to 60% calories from carbohydrates, 10 to 25% from proteins, 20 to 30% fats, a lot of emphasis on drinking water and not juices, dietary fiber, antioxidants, phytochemicals, iron, zinc, calcium, vitamin B12, folate, iodine, vitamin D, all need special attention. Of course, encourage dietary diversity, nutrient-rich diet, focus on the local, the millets, and also encourage outdoor physical activity. Adolescents love infographics, and these infographics are easily available on Dietary Guidelines for Indians, which is free to download, and I would recommend sharing my plate for the day, which should be so very colorful that following the total diet approach for all adolescents in clinical practice. We all know about the weekly iron folic acid supplementation plan and the IAP Bye-Bye Anemia Presidential Action Plan. I think it's time once again to reinforce weekly iron and folic acid for all adolescents and biannual deworming in addition to dietary counseling. It's not only about nutrition, but it's also about healthy lifestyle. I told you the link between the body and the mind and the mental disorders and stress leading to emotional eating disorders. Hence, our anticipatory guidance should emphasize on good sleep, practicing meditation, connecting socially, connect with the nature, and being kind and helpful. Adolescents love apps. Yes, they could be fitness apps, they could be healthy eating apps, and Calm and Headspace are excellent apps for meditation. Now focus on body image as well. We have this concept of body neutrality. Appreciate the body as it is. Focus on the body ability and practice body acceptance. Body is not the only measure of self-worth. Take care of your body because that's where you live, is the concept which we want to tell the adolescents. Keep it healthy, but also develop your other qualities like kindness, gratitude, and also sports, music, and dance. And that is actually what determines your self-worth. Talking to adolescents on how to read food labels is also very, very important. We want to meaningfully engage with youth and nurture adolescent health ambassadors who will spread the word. You all know about the sugar board and the oil board, which were recently told by the CBSE to be put up in all CBSE schools, and I hope it goes on to all schools in India. This would also reinforce healthy nutrition. Now coming to a case, Sanjana, 14-year-old, presents with a history of falling grades and mood swings. Is it depression? Is it learning disability? Can this be anemia? Let me tell you, anemia can present as any mental disorder, any internalizing, externalizing, or even psychosis. So if nothing else we can do as pediatricians, I think we just need to deal with anemia first and insist on adequate physical activity of 60 minutes per day for each and every adolescent. We are familiar with the definition of anemia. We are aiming for a 13-gram hemoglobin in both boys and girls. In addition to your routine history taking in the adolescent age group, it was very important to take a head psychosocial history in privacy, offering confidentiality, where you talk about all domains of the adolescent's life, including home, education, eating, activities, drugs and medications, chronic medical disorders, any evidence of suicide, depression, sexuality, and safety. And I have written the points which are important in case of a nutritional history. We often are stuck with the nutritional history, but remember, each part of this psychosocial history is important. Coming back to Sanjana, on a head psychosocial history, she tells us, my parents are busy professionals and they regularly order food on apps. Nobody cooks at home. She has poor concentration while studying. She gets fatigued out. Her ambition is to become a model. She feels very guilty after angry outbursts. She's very worried about her dull, pale complexion, desires to be very healthy. As you know, she wants to become a model. She is an animal lover. She turned vegan since 6 months. Her favorite meal is tea with noodles with pears. She has irregular menses with occasional heavy bleeding in some cycles. The examination and investigations reveal that she has a normal BMI, a dimorphic anemia with iron and vitamin B12 deficiency. So now you can see, not surprising with the history which we have received. How do we manage this case? We are going to use the technique of motivational counseling. That is so very important for all adolescents for change in behavior. Though I have taken a case of anemia as prototype, the same holds good for obesity. The risks for the adolescent, the rewards for the adolescent, when we talk to them about adopting healthy nutritional behavior and adherence to hematemics. So we talk about you'll be healthy with a great complexion because you after all want to become a model. We are not going to talk to her that if you have a very good hemoglobin, you would be able to run fast. She's not interested in physical activity as of now, but later you do need to tell her about physical activity as self. But also talk about healthy nutrition contributing to regular periods, better mood and concentration. And then she tells you about the roadblocks, how her peers influence her to have noodles and how much she's concerned for the animal life. Then you tell her that fad diets are not recommended in the adolescent age group. You can be a healthy vegetarian and you can be an animal activist in many other ways by probably starting a blog. So these are some of the suggestions you may give her. The adherence to hematenics has to be linked with routine activity. For example, have your hematenics after brushing your teeth. Adolescents often forget, and they don't like to be told and nagged again and again. Partnering with the family is extremely important, and so is follow-up. So to summarize, the clinical assessment includes all the routine stuff which we already do, but all pediatricians, please do add head psychosocial history, focus on drugs, stressors, body image, dieting, fat diet, binging, purging, excessive exercise, and fat dieting, binging, purging may actually indicate the setting of an eating disorder. How do you talk about body image? How do you feel when you look at yourself in the mirror? And if the adolescent says, I feel terrible, I only wish that I was thinner, then you know what next question to ask. Now, coming to obesity, we often talk about BMI. We also talk about waist circumference, but the new latest is we talk about height and weight ratio, and anything above 0.5 is considered as obese. And this is cross-cutting for all cultures, for all ethnicities, and for all age groups. And I'm sure we'll have more of research, even coming from India. There's already some research coming from India on this. So our nutritional counseling in case of adolescent has to be very, very case-based, one-on-one, sensitive and empathetic. You have a small stool there and the adolescent weighs 80 kgs and the adolescent is falling off the stool. This is weight stigma and weight bias. We have to think beyond, we have to change what is happening in our own clinics, be very mindful of how we talk. We can't keep on blaming the adolescent. We have to look for the roots of malnutrition, which is actually a triple burden. As you can see, there is obesity, there's undernutrition, there's hidden hunger due to micronutrient deficiency. We do need to talk about media, building a healthy relationship with food. We know about goddess Annapurna, and that was how we built a healthy relationship with food. And now there are some adolescents who just don't feel like looking at their plate. And there's a lot of picky eating. Family involvement is extremely important. Family meals, shopping, cooking, gardening, and physical activity. And of course, daily supplements if deficiency is detected. Coming to a little bit about sports nutrition. Lot of our adolescents are now into sports, and we are often not taught about sports nutrition. We must ensure that pre-exercise, the adolescent is fueled up, has high carbohydrate, moderate protein, low fat and fiber, and 2 to 3 hours prior to the sport has a meal, and a snack 1 hour prior. During exercise, if the exercise is more than 60 minutes, healthy snacks are recommended every 1 to 2 hours. And post-exercise, within 30 minutes to have a healthy snack. Water is the best drink to hydrate if the exercise is less than 1 hour, and if it's more than 1 hour, they do need a sports drink, and avoid energy drink. We are all familiar with the female athlete triad, but it has been renamed as the relative energy deficiency in sports, and it occurs also in boys. Those who are gymnasts, those who are ballerinas, and those who do weightlifting, they are recommended by their coaches to lose weight, and we should be aware of this because this is a neuroendocrinal problem. Coming to microbiome, we know microbiome, the gut-brain axis, is actually regulating our whole life. And it is not only what we eat in the adolescent period, but what is there right from the womb. And microbiota influences our lifestyle and our health immensely. What is next? Next is targeted nutrition. What is going to happen in future? People are going to be analyzing our individual microbiome, and they are going to be giving a prescription on what suits us the best for longevity. Sustainable nutrition is what Prime Minister Modi has been talking about, the International Year of Millets, and it's time to change to a more plant-based life for the environment, and a food which is culturally acceptable and has a low environmental impact. Very much here in India, we are just stunned by the anemia just not going. And it is time to go back to pre-processing techniques to think about how we can make plant-based food which is with high iron availability. So we are going back to our traditional methods, enzymatic methods, and vitamin-restricted methods with dietary advice regarding increasing enhancers and decreasing inhibitors. Lots of research and pipeline, and as Indumati Madam said, yes, India is going to lead. Teen nutrition has to be personalized, fun, digitable, and sustainable. Yes, AI is here to guide the nutrition intake of adolescents. There are apps, wearables, mindful smart eating tools. There is gamification. All this is there in the pipeline. These have to be understood by us. They have to be studied by us. One of the apps which is most widely used is MyFitnessPal. We continue to write papers on nutrition, Society for Adolescent Health and Medicine, and I was lucky to be a part of all the 3 papers. As we go along in nutritional disorders, talk about body image, food insecurity, I think even the IAP needs to keep publishing papers. We are all familiar with these famous lines when we come to nutrition. You are what you eat. Very soon this is going to be turned into you are when you eat, because the research shows it's so important to have regular meals and the correct timing of your meals. Hippocrates said, let your food be your medicine, and I think we all agree. Personalized medicine says, personalized medicine will guide what you eat. So, it's time to be different, it's time to be innovative, open-minded, updated. Stick to your roots, but think beyond too. Understand science and partner with youth and digital media. We all know adolescence is a nutritionally vulnerable period. Multiple determinants. Adequate nutrition and physical activity are essential for current, future, and intergenerational health. There's a triple burden. Lifestyle disorders, including body image issues, are increasing. We need to adapt motivational counseling for adherence to dietary guidelines, healthy lifestyle, and adherence to therapy. Thank you very much for giving me an opportunity to share my thoughts on adolescent nutrition.
Next, I call upon Dr. Narmada to give the next topic.
A very good afternoon to you all. After the mind-boggling session by my teacher, Dr. Indumati, and the mentor, Dr. Preeti Galigili, I'm here to talk on a very interesting topic. So the changing landscapes of prevention of RSV with nirsevimab for all infants. So this is something which is very interesting. I first disclose that it's a sponsored talk for the conference. However, the most of the data for me is researched and verified by me. The topic itself is interesting. RSV prevention for all infants, something we are not used to. We do not know. It is very common in the preterm, but in our routine pediatric practice, do we have to do the RSV prevention, and why do they need it? The vaccination, usually we recommend vaccination, but here the topic suggests about nirsevimab, a potentially monoclonal antibody type. Why the antibody and why not vaccination? Now let us look at the spectrum of viral infections in our OPD. A 1-year-old presented with complaints of cold and cough for just a day duration. It was a full-term normal delivery, no neonatal admissions. He was given vaccinations at the local primary health center. Why I said that is flu vaccination and pneumococcal vaccination. Flu vaccination was not given. In the midnight, she came with a severe respiratory difficulty, needed 4 liters of oxygen, which then increased as the night progressed. By morning, we had to start her on HFNC and ICU care. The blood workup was not significant. So this is the child, and you can see the severe respiratory distress. And the continuous hacking cough. Case 2 was a 45-year-old baby brought by the mother for constant crying and refusal of feeds. Baby again was a full-term normal vaginal delivery. Birth weight was about 3.5 kg, immunization given at birth. Elder sibling had a mild cold and cough, and on the previous day, the baby, when they arrived in ER, thanks to the protocol we followed because of Indumati ma'am, the saturations we saw, it was 85% in the nasal prong. The stabilized, it was done, and the child improved, but it required hospitalization for more than 10 days. And we could not taper the oxygen. The viral swabs were not done, the parents were not affordable, but blood test essentially normal. This is another case, again with the same respiratory distress under the nasal prong. Now look at this child. You can hear the mild grunting, stridor-like grunting, and the child being not very active. And we all know when they have a respiratory distress, the sensorium is a very key part that determines our management. So all these videos were taken from my OPD, from my emergency room from June to July of this year. They all came as respiratory tract infection. They can present with stridor, and they can go in for respiratory difficulty requiring hospitalization, and some may require ICU admission with non-invasive ventilation, and all of them were normal babies. So an acute respiratory infection in the children can present with multiple causes, and we know even in India the most common cause is the viral infection, of which RSV forms 63%, and the World Health Organization estimate that RSV accounts for more than 60% of acute respiratory infection, and more than 80% of the infants in children less than 1 year of age have been infected by that. And we also know, and it's the most common cause in early years of life, with almost all children at about 2 years of life, 90% of them are affected. And 40% of the initial RSV episodes go on to develop lower respiratory tract infection. So what is a respiratory syncytial virus? Nothing for a common pediatrician. It's a common and contagious seasonal virus. But what we have to tell it, it's transmitted by the people around, by their own siblings and their own parents, and it is also quite seasonal. The community exposure contributes to about 54.8% of the cases, most of them contributed by the siblings who goes to the school, the mother and father 2.4%. Having said that, RSV has caused a substantial disease burden for infants globally, with 12.9 million episodes of LRTI and about 1 lakh deaths occurring annually. So it is a leading cause in the whole world, and it is also the leading cause of hospitalization in the whole world. Top 5 primary diagnosis in hospitalized infants in less than 1 year of age.
Having said that, we can look at the hospitalization occurring in other parts of the world, United States, Canada, and Europe. And but the mortality is higher even compared to influenza. So any patient who has been hospitalized in the first season, 1 in 5 children get the outpatient visit is due to RSV, and about 1 in 50 infants were hospitalized in the first year of life. Now this is, one another point is RSV is highly infective, and the infective profile ranges from 1.7 to 8.2, which is considered as a very infective range. But is this true for India? Do we really have such a disease burden, and we really, as we keep telling that we do not have any studies on the same, is it so? No, there are studies for that. The cause and incidence of community-acquired serious infection among young children in Southeast Asia has shown that RSV is the predominant cause of infection in a population-based surveillance at 5 states, which included Pakistan and India, and especially Odisha and Vellore. That is my place where I come from. 63,000 babies has been evaluated. The cause identified was 28% of these episodes had viral infection. The mean rate of infection was 13.2 per 1,000 live births, and RSV turned out to be the important cause. 35 research articles, 22,000 cases, reports from all over India. The Indian RSV burden is comparable to the rest of the world. And you can also see ICMR study, which is a very big study, which said that they compared in different areas of North India, East, West, and South India, and you can see clearly RSV being contributing, especially in South India, to 50% of the cases of recurrent respiratory tract infection. So it is there across 4 regions of the country. Now this was again the ICMR data which looked at over the decades across the geography and found out that RSV was a predominant cause across all seasons. And this is a single center study done in a very close area in Bangalore, where they looked at about 145 children with acute lower respiratory tract infection, and they also confirmed that the majority of the cases, it was an independent study, not sponsored also. RSV is seasonal with peak incidence varying by region, and we actually belong neither to the northern nor to the southern, and we are having a season all across. China has a predominant southern hemisphere, but when we look at Indian data, we see that it's very ill-defined and it is present at all times here. Now, RSV circulation for India, in summary, it's a very common infection in less than 2 years of age, and it has at least one child in our OPD has an episode of RSV infection, and 1 in 5 gets the infection. We have a high disease burden comparable to the West, and we have a data that is supporting from 1970 to 2020. The spectrum is varied. They may present as an OPD practice, but soon progress on to a hospital-acquired infection. It's highly contagious, higher morbidity compared to influenza, and prevention can lead to reduction of morbidity among all children. Having said that, yes, we know prevention is a priority. We know we have the active prevention and the passive prevention. So this is the RSV virus that has, this is a single-strand RNA virus that has the fusion protein, which is something which we have to see, and the other proteins for which we developed a vaccination. A formalin inactivated vaccination was first introduced in 1966, and children were delivered that, and they were seronegative, and in the same season, they had an exacerbated respiratory disease, something we are now seeing with the dengue vaccine, antibody-dependent enhancement, that seriously happened in the presence of a weak neutralizing antibody. We had an exacerbation. This led on to a peribronchial inflammation and infiltration of neutrophils, and this led on to 2 children who died after giving the RSV vaccine just because of the antibody-dependent enhancement. Why is it so? Because that vaccine acted on the post-F1 RSV post-fusion. So it was not coming out, and it was only after the infection that the antibody could not neutralize the pre-fusion epitopes. The pathology is little important for us to understand why the further we had to depend on the passive immunization. So this epitopes is a highly neutralizing antibody. It is conserved, and once it enters into the body, it closes on, and no amount of an antibody will be able to prevent our infection. And the vaccination was actually targeting at the antigen sites after the infection. So this led on to us relying whole on the passive immunization. Passive immunization can be acquired by 2 methods. One is a maternal vaccination, and the other is the antibody we give to the child. So the maternal vaccination has been very much in the West, the transplacental transfer of Abiriso, but we do not yet have it so much in the India, and the cost is one factor. How many of the maternal mothers we have to reach, and how many vaccination, this has to be taken up by the government. As we talk about it, as I told you, the pre-F is where we have to target and not on the F protein.
The previous, if you see, palivizumab is working on a different side, whereas nirsevimab is working on a different side. Palivizumab is indicated for RSV prophylaxis, but because of where it is targeting on the site, you know, we have to give the monoclonal antibody every month for the first season of the RSV infection. Now, this will cost very heavily, and which parent will be going month on month, and so we are not able to give at the preterm. We know with the kind of the newborn units which is coming up, the preterm rates have really increased. So immunization with the traditional monoclonal antibody, the palivizumab, now having a 5 injections and the cost of it prevented many of us from taking up. Now, we needed a monoclonal antibody which can work only on one epitope, and it should be entirely neutralizing, because if it is not going to be neutralizing, it's going to be a weak antibody which is going to trigger the antibody dependent enhancement. So the palivizumab is now restricted only to the high risk conditions, and it is an immunocompromised, congenital, or having a pulmonary abnormality. And the major unmet need of preventing RSV infection is, you know, the age of the onset, the high risk status, as well as the immunity of the infant. If the mother had already received it, and if it has got an antibody, we will not be able to give the palivizumab here. Now, here comes the nirsevimab, which is designed to provide protection for all infants. We clearly understand that we need for all infants because most of the RSV infections are occurring in normal newborns. Now, it is on the monoclonal antibody technique, and as I already said, it's the site is very typical, a highly conserved site, and also there is a threonine mutation that is occurring, and this the prefusion RSV F protein, which the nirsevimab is targeting, has got a high neutralizing potency also. So there is a more than 50-fold higher activity than palivizumab. So this is what it is, where palivizumab works is on the lower most part, and where nirsevimab is on the higher conceived side. So the mechanism of long acting is why, because nirsevimab binds very strongly. It can block the viral entry, and also there is a YTE substitution in the FC region, which gives them a rate of recycling by endothelial cells that leads on to an increased half-life. So where we have a palivizumab which we have to give monthly, nirsevimab we can act for more than 6 months duration. So this is the way that the monoclonal antibodies are acting. It has got there was a phase 2 trial that is before introduction into the market. We had a significant reduction in the medically attended RSV. There was a phase 3 MELODY trial which also showed there was a significant reduction, and the HARMONY trial which came in the real world settings, which showed an efficacy of close to about 83.2%. So we have the phase 2 trial, we have the MELODY trial, we have the HARMONY trial, and we know that medically acquired, preventable LRTIs can be prevented by giving this monoclonal antibody. And again, what happens during the second episode? So we have to give a second dose of nirsevimab during the second season after going through the first season, and we can see compared to palivizumab, nirsevimab have got a greater potential here. Safety is already well examined, and it is regardless of the gestational birth, regardless of the immunization status of the baby, you can give nirsevimab. And this is where 56 countries have already approved, 24 countries have society recommendations made on it, and national government in 25 countries have recommended, and it has brought down the mortality rate significantly in these countries, where you can see the odds ratio is favoring the nirsevimab injections. It is 83% effective. It brings down the hospitalization rates. So this was a summary of the real world impact. You can see it's about close to about 87.2. In Europe, almost all countries has an efficacy close to about 87.6%. In summary, 6 million infants have been immunized with nirsevimab worldwide. A large body of evidence is there for nirsevimab, which demonstrate effectiveness against RSV-related hospitalization, ICU admission, and LRTI admission. Now, looking at the kind of protocols we have for passive immunization, what is there for palivizumab, only the recommended population is a very less population. Achievable immunization is also less than 2%, and efficacy is only about 55%. Maternal immunization, we have still not started a part. Nirsevimab has about 83% effective, can be given for all normal newborns, and it's a single injection covering full season. So, in summary, why did I really say the changing landscape? Yes, We were thinking that RSV was there only for the normal newborn, high-risk newborns, and it was creating problem. Now we know RSV is the predominant cause even in the normal newborns, and significant respiratory infection. 1 in 5 OPD children and 1 in 50 get hospitalized. So prevention is better than cure for the disease with such a significant morbidity. Passive immunization is a role we have because active immunization will lead on to antibody-dependent enhancement, and monoclonal antibodies have in fact changed the landscape of prevention of an RSV. The cost is very much applicable, and when they send lakhs in a newborn unit and when they want to come back, single vaccination which is cost affordable is really very good. Nirsevimab with its advantages offers the protection required. Thank you for your patient listening, and these are the facts regarding the RSV. Thank you.
Thank you, Namada. Any doubt, any questions?
There are no questions currently, sir.
So cost is, they are costing about 10 to 12,000 in the market, sir, for a single injection, but on the second dose also. But when compared to the hospitalization rates and all this is much more affordable, sir. 40,000, yes.
Actually, the dose recommended is 50 milligram
It depends
for
on
less than 5 kilos. And for more than 5, it is double the dose. And each contains costs 40,000 seems. And when the dose is more than 200, it seems 80,000.
But that is for the more than 2 years of age group.
That's
and
that
that is 100 milligram dosage,
yeah.
yes. But compared to that, cost effectiveness is definitely there.
Okay, thank you, Ramadan, Madam, Preeti Madam. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you.
We are thankful to Dr. Aruchami, sir, for chairing this enlightening session. With over 3 decades of teaching and clinical experience, he is also the author of widely used textbooks in pediatrics and has trained generations of pediatricians and contributed extensively to medical education. Thank you, sir. We kindly request you to accept a token of gratitude from our side. We request Aruchami sir to present our speakers with a token of gratitude. We request Narmada ma'am to present a token of gratitude to Aruchami sir. Thank you all. Moving on to the next session. It is with great honor that I introduce the chairperson for the next session, Dr. P. Ilamurugan sir, who is a child health consultant from Namakkal. Sir is a practicing pediatrician for over 27 years and is also served as the vice president of the IAP Tamil Nadu state chapter as well as the Salem and Namakkal chapter. May I invite you onto the stage, sir? Welcome, sir. For the first speech, I invite Dr. Surendranath, sir. For this first speech, I invite Dr. Surendranath sir, who will be speaking on HPV. Not just her problem, he matters too.
Good afternoon. Thank you, chairpersons. At the outset, my hearty congratulations to the Coimbatore for getting the Pedicon 27. And I thank Dr. Rajendran, Ismail sir, Jalil, and Secretary Narmada for giving this opportunity. And after 3 emphatic talks by eminent lady pediatricians who are going to be our leaders for future, now we'll come back to one of the most important topic, whether the HPV vaccine is required for the boys or not. So now the HPV vaccine is recommended for the boys also. Previously we were only giving to the girls, now it has become a gender neutral vaccine. What is the importance of HPV vaccine for giving it to the boys? Why should we give? We'll just see the requirement of HPV vaccine as far as the boys are concerned. Is it a concern for boys also? So now the HPV is not just her problem, and he also matters. So the boys also has to be vaccinated. So as an introductory, we know that HPV is one of the virus which can cause lot of cancers apart from cervical cancer. And basically it is transmitted through the sexual route mostly. Very rarely by contact also it can come from skin to skin contact. There are about 100 serotypes are there, out of which almost about 9 to 10 serotypes are known to cause skin diseases as well as the cervical cancer and other cancers. And apart from the cervical cancer, they can cause vaginal cancers, vulvar cancer, anal cancer, oropharyngeal cancers. And another most important aspect is perineal warts also can cause by the HPV virus, which are known as benign viruses, which can cause skin diseases like warts. So why the HPV virus stays in our body to cause the cancer? In fact, HPV virus, when it enters, it will not result in the inflammation, and our body will not produce the immunity against the HPV virus to control the infection of the HPV. So it continues to grow in the body over a period of time. Slowly it becomes malignant, whatever cells are there, slowly they turn into the malignancy and they cause the cancer. And most of the times it is a local inflammation. That is the reason that you don't mount antibody response to the HPV virus when it enters into the body. And most of the times initially it is asymptomatic. They don't cause any symptoms as far as when they enter into the body. Only over a period of time after 10 to 12 years or 20 to 30 years, the cancer may manifest because of presence of HPV virus. So let us see what is the prevalence of HPV in the woman with a normal cytology. So when does the HPV enter into your body? It is not at the time of getting the cancer. In fact, it enters as early as when you have the first sexual debut. And these are the statistics which have been shown in India, that HPV virus in a normal cervical cytology, almost you can see less than 25, it is about around 15 to 20% of the women have the HPV without any symptoms in their body. And as the age advances, it will come down, and around the 50th year of the age, it may increase, and in the 65, it is the maximum prevalence of the HPV is seen, even with a normal cytology. So as far as the men are concerned, there are statistics which have shown that 1 in 3 men in the worldwide has at least one type of HPV virus in their body. And 1 in 5 are infected with one or more of the high risk HPV. So when you see the HPV incidence in the men whose women got the cervical cancer, almost the woman who had cervical cancer, almost 66% of the men had HPV infection in their genitals. So this is the incidence of HPV as far as men are concerned. And there are statistics which have shown that HPV prevalence in India, and what this show is almost about HPV prevalence among the men is about 26.7%, and those women had cervical cancer, it is almost 66% of incidence is seen in prevalence of the HPV in the men as far as the men are concerned. So why should we bother? If a man gets HPV infection, do they mount adequate immune response to control the infection? No. Only the 7% of the people who got the infection are seroconverted. What is seroconversion? Seroconversion is the protection level of the antibodies where your infection can be prevented. even after getting the infection, only 7% are seroconverted. That means almost 93% can get the recurrent infections in spite of getting the first infection. So there is no definite control measures to control the HPV other than giving the vaccination, because you don't mount the antibody response for a natural infection. So this is what they have shown, that the papers show that a low rate of seroconversion following HPV infection in men, coupled with lack of demonstrated protection against the infection among those do seroconvert, may leave the men susceptible for the recurrent infections, especially the HPV 16. You know that high risk HPV 16 and 18 are high risk HPV who cause the cancer in the women and the men. So 16 is one of the high risk HPV strain which can lead to the recurrent infection and can lead to the penile cancers and the anal cancers in the men. So what is the percentage of the people who get the recurrence of HPV infection? You got the infection, can you get the reinfection? Almost about recurrent infection is seen in 31% and 20% of incidents of infection recur over a time. So absolutely there is no chance of controlling the infection, because you tend to get the recurrent infection in spite of getting the previous infection, because your body doesn't have the antibodies to protect against the HPV for the reinfection. So as far as the cancers are concerned, cervical cancer, almost 99.7% of the cervical cancers are caused by the HPV viruses. Most common is 16 and 18, and there are 5 more are there which can cause the cervical cancer. In the anal cancers, almost 90% of the anal cancers are caused by the HPV. Penile cancer 63%, vaginal is 75%, and vulvar is 69%. So one of the definite cause of the cancer is the HPV virus in the girls and the boys also. So this is the percentage of the cancers which can cause cervical, vaginal, vulval, oropharynx, penile, anal cancer also can be caused. So coming to the viruses, 6 and 11 are benign viruses which will lead to the only warts. The perianal warts or warts on other skin surfaces are caused by 6 and 11. And whereas 16 and 18 are the 82% of the cancers of the cervix, and the anal cancers are caused by the 16 and 18. There are other 31, 33, 35, 39, 45, 51, 52, 56, all these are about, it is about 10 to 15% of the cancers are caused by this. So almost 82% of the cancers are covered with the 16 and 18 HPV strains. So this is what cancer causing strains are 16 and 18, and non-cancer causing benign strains are 6 and 11. So these 4 strains are very important for the vaccination. So the quadrivalent vaccine contains 6 and 11 of the benign HPV viruses, 16 and 18 are the cancer causing viruses. The vaccine is made of these 4 strains, almost covering about 82% of the cervical cancer cause of the HPV. So coming to the incidence, almost 51 crores are reported all over the world, whereas in India 1.23 new cases come every year. Almost about 77,000 deaths have been reported because of the cervical cancer in India. So can we prevent it? How to prevent? Educate and awareness. Next is the screening procedure, and another is the vaccination. Now we see what are the screening procedures for the cervical cancer vaccine, for that matter penile cancer or anal cancer. Cervical cancer vaccine, cervical cancer prevention, there are methods to detect the cancer before it overtly manifests. Whereas cancers caused for the penis and the anal cancers cannot be detected because we don't have any screening procedure as such. So even in cervical screening, NFHS 5 study shows that in India, urban only 2.2% of the people get screening. In the rural India, it is much less, it is only 1.7. So total only 2% of the women undergo the screening test for the cervical cancer. This is absolutely low. That means in spite of having the measures to control the cancer by doing the screening test, we don't implement it properly. So this is one of the reasons that vaccination is strongly can be recommended. So why should we give this vaccine between 9 to 14 years? Always better to give the vaccine before the first debut of the sexual activity, and not only that, The seroconversion rates and immunogenicity is very well reported that between 9 to 14 years, our seroconversions and antibody levels are much higher compared to at a later age. And the protection has been shown to be almost, since last 15 years, the vaccine is there. They have shown that absolute reduction of the cervical cancer after 15 years. No cases of cervical cancer have been reported, those who are vaccinated. Probably it may act for longer period, but we have to see for the results. Presently we have a data about the 15 years. And if you see the adolescents, this is the statistics of the NFHS 3, the sexual debut before the age of 15 years. Males about 2.7 and 8% of the females are already had a sexual activity before the around 15 years. So for that reason, the vaccination between 9 to 14 years is the ideal age where they are not yet exposed to their sexual activity. HPV entering into the body can be prevented by giving the vaccination. And even the studies, some of the studies have shown that the sexual activity almost about 8% of the most of the urban, and in fact it is more common in the rural areas. 18% of the children are already exposed to the sex at the age of 15 years. So ideally the vaccine should be given before the sexual exposure. That is the reason that 9 to 14 years age is the ideal age to give this vaccine. And HPV vaccine is extremely effective. The enough studies are there. No cervical cancer cases detected in vaccinated women following HPV immunization. This is the study of the Scotland. In the Australia, the one country which has implemented the HPV vaccination in the national immunization program from the 2007. Initially they gave only to the girls. After giving to the girls, they started giving it to the boys in the national immunization program in 2013. And now it is a gender neutral vaccine. They are giving to all the children that HPV vaccine in the national immunization program. What they have shown is the incidence of the perineal warts have come down once they started in the national immunization program. In fact, if you see the less than 21 years, there is drastic reduction of the perineal warts which are transmitted by the HPV after giving this vaccine. Almost about, it came to 1% in women under age 21 years. Previously it was 10.5%. So significant reduction of the perineal warts has been shown after giving the vaccination in the national immunization program of the Australia. So why the male should be given this vaccine? Basically it is known as a cervical cancer vaccine. Now it is a HPV virus vaccine, not the cervical cancer vaccine, because it also helps to reduce the cancer of the penis as well as the anal canal and the oropharyngeal cancer. So males are susceptible for the HPV infection throughout their life because reinfections are common. High prevalence rates of infection across the age groups, and the risk of penile cancer is common with the HPV virus, and they don't seroconvert after getting the natural infection, and we don't have routine screening tests to detect the cancer of the penis or anal canal or a oropharyngeal cancer for that matter, and they are susceptible for the new and recurrent infections. If you give the vaccine to the boys, you can reduce the HPV transmission, facilitate eradication of the HPV, and it also imparts the herd immunity and protects from the infection. So ACVAP recommendation is to give for all the boys and the girls this vaccine between the ages of from 9 years to 26 years it is recommended now. A gender neutral vaccine, that is for the boys and the girls, currently 81 countries are implementing as far as the HPV vaccination program is concerned. And now we have the best vaccine available in India, made by the Serum Institute, which is affordable in fact. And there are enough studies showing that seroconversion levels of the boys and girls are found to be very good. And the studies have been done in the boys and the girls also. They have done the studies before the vaccine is permitted to be used in the Indian continent. So cohort 1 is 9 to 14 years, and they have studied with a 2-dose schedule, and the another cohort is 15 to 26 years as a 3-dose schedule. And there are 3 arms. There are males are there, females are there, and the vaccine is compared to the Gardasil 4. So they have compared the immunogenicity of the Cervavac along with the Gardasil 4 for boys and the girls. In fact, for the girls they gave the Gardasil because Gardasil 4 is not permitted to be used for the boys in India. So you cannot give Gardasil 4 to the boys. So the boys are given only Servavac quadrivalent vaccine. For the girls, Gardasil 4 is given, and they have compared the immunogenicity, and it is a multi-center study. In fact, they have done in many centers all over India, and what they have found is the seroconversion rates after giving the second dose, that is after 7 months, after giving 2 doses in the age group of 19 and 14 years, and after 3 doses from 15 to 26 years, they have found that the bridging studies, immunogenicity studies have shown that they are comparable to the existing Gardasil 4. So all 4 serotypes has similar seroconversion compared to the Gardasil 4. So efficacy, immunogenicity study has been found to be non-inferior to the existing vaccine, and they have found the antibody levels very high, which can be maintained for a longer period for protection against the HPV virus. In fact, almost 10 times, 2 to 4 fold of the antibody titers are correlated up to 10 years. So what it says is that the initial antibody level is very high. The antibody levels can be prolonged and at a protective level for a longer period. So almost 1,000-fold rise of observed with the Servavac for 6, 11 and 16 and 18 serotypes which are in the vaccine. So overall summary is Servavac has demonstrated robust antibody response. 100% seroconversion was reported in all 4 serotypes, 6, 11, 16 and 18. And geometric mean fold rise for all 4 serotypes is more than 1,000-fold across all the age groups of the cohort. Adverse events reported predominantly mild to moderate. No vaccine-related severe adverse events solicited. Reactogenicity with severity of grade 3 or more has been reported. Overall incidence of the adverse events with Servavac is acceptable compared to the existing vaccine. So at present, the Servavac is the only vaccine which is approved for the boys and the girls from 9 to 26 years. Whereas Gardasil 4 is not permitted to be used in the boys, and Gardasil 9 is only permitted to the up to the age of 9 to 14 years. And we have a vaccine which is immunogenicity wise, which is almost, non-inferior to the Gardasil 4, and it can be given as a gender neutral vaccine for the boys and girls from 9 years to 26 years. And the cost of the vaccine is almost half compared to the Gardasil 4 and 5 times less than the Gardasil 9. So it can be easily incorporated into the routine schedule at the 10 years of age along with the Tdap, and acceptability of the parents is much high because of the low cost and a very good vaccine produced by the Serum Institute. Thank you very much. Thank you for your patient hearing. Thank you.
Thank you, sir. For the next speech, I invite Dr. Atanu Bandra, sir.
Slide changer. Yeah. Thank you, Dr. Surendranath, the organizing secretary of the Hyderabad Pedicon. So, I am the organizing secretary of the next Pedicon, Calcutta Pedicon, and Rajendran sir is about the next organizing secretary of the next Pedicon. I don't need this. I don't need this. Pointer, hai na? I don't need it. Yeah, this is okay. So, we are hungry, right? So we'll talk about something which will not be related to medical science apparently, but finally we'll have a conclusion that everything, what you feel, what you do, what we all, because in the morning we come out with a mood. If we are in the hospital, we are in a different mood. When you come, at the end of the day, when you complete all our work, we'll have a separate type of mood. And we think this mood is coming naturally to us. No, sir, madams. All these things are controlled by something which we have in our power to control them also. Like, yes, Dr. Tirumurugan, whenever I see him, my mood is elevated. So much activity, so much power, and so much energy. Again, when I see Dr. Lakshmi working silently and behind the back, the future treasurer of the next Pedicon, so I feel is, well, I am in safe hands. The whole Coimbatore and whole Tamil Nadu is in safe hands. So these are all the mood changes that we say. Even if when we refer to someone, we say that his or her mood changes very fast. What is the reason? And someone we know they are very stable. They don't show their mood changes. Why? Because finally I'll show you a result. Sorry. Because what we are targeting now, initially when we were in our childhood days, the target was money, buildings, flats, property, and a successful career somewhere. So that's what we thought, that our life would be well taken care of by all these things. But now, no, what we are referring to is now positive psychology. Let us not think about negatives, because by the time when we have crossed a part of our lives, we know that not everything that we wanted has come to us, or not everything is okay till now. But we will have to look the things that we have achieved and we have attained. And that's the new theory of well-being, refers to positive emotions, engagement, meaning. What is the meaning of life? In fact, Indian Academy of Pediatrics just a few weeks ago had a session on spiritual attachment in pediatrics. So accomplishment, positive relationships. Yes, I may not like all my class friends or all my batchmates or all pediatricians. I may not like, but I like many of them. So those are positive relationships. And today's focus is on positive psychology and well-being. It significantly impacts mental health. Physical health, we all know that we have certain limitations, and after that medical science is going ahead and they are taking care of our physical health. It's time that we take care of our mental health and happiness, which are linked. So let us find the main players of why our mood is stable and why our mood can be made happier. The four major hormones: serotonin, dopamine, oxytocin, and endorphins. These are not just simple hormones. They have a complex relationships in our body, and they do have an interplay with the other hormones also. But they contribute to the feelings of happiness, joy, and pleasure. These are the primary happy hormones. Is it a misnomer? Is it an oversimplification? Yes, it's a bit of a simplification, because as I said that it has complex interactions. These hormones also have broader functions rather than other than having a role to play in our happiness and mood changes. Like serotonin, you all know, have a role to play in digestion and sleep. Oxytocin, it affects social bonding and reproductive behaviors. So when we hug a friend, when we meet a friend after a long time and we hug him, we are actually trying to get serotonin into our body, and there is involved in things. Oxytocin, social bonding, reproductive behaviors, and most of them primarily serve as neurotransmitters when they act on mood, but most of them can act as hormones as well. So we'll just focus on serotonin, all these hormones, and take out the basic principles behind it. Serotonin mainly produced in the brain and the intestine, and approximately 90% of the body's serotonin is found in the gut. The gut-brain axis, this is a very common term now, and we talk about gut-brain axis. Maybe what you feel now probably is because what you ate in the breakfast in the morning. In fact, it is the second brain. The gut is known as now the second brain of the body. There is a happy holiday syndrome. We go to a holiday, spend some days by the sea or in the mountains, and come back and and our mood is elevated for a few weeks probably. The reason all of us thought that it was because of the time we spent there. Finally, we now know that actually when we had gone to a different place, we had acquired some probiotics from the soil and from the area, and those probiotics had been into our gut, and they are actually elevating our mood. So do not overestimate or underestimate the two brains. Both of them are equal, and probably they are acting through serotonin. So low levels, depression and anxiety. Increasing serotonin level can in fact lead to a better mood stabilization and reduced feelings of sadness. Dopamine, again, is the motivator hormones. Dietary sources are rich in amino acid tyrosine, which support dopamine production. Chicken, beef, eggs, milk products, dairy products, and nuts. You are feeling down, you are not feeling motivated to attend the session, have a few nuts probably, though it is an oversimplification, but still you can definitely motivate yourself. And it's a reinforcement of behaviors involved in motivation and pleasure. This is the reward hormone for all of us. Dopamine is the reward hormone. A healthy dopamine level, you will have great feelings of enjoyment, focus, and drive. Remember all these things, even institutions like the army, institutions like the Institute of Science, they know, and they in fact motivate their people in the institutions with many of these principles. Oxytocin, this is the love hormone. When you hug, physical touch, this is the hormone that comes out, and it is produced in the hypothalamus and released by the pituitary glands. Higher levels, but then it has to be optimal level. Higher levels are associated with a reduced stress and anxiety, and it enhances interpersonal relationships, fosters connections, and promotes feeling of safety and trust. So oxytocin level is very important in all those things. If we are not feeling like going about doing fellowship, meeting our friends, probably oxytocin levels is something that we should be looking at. Endorphins, this is the runner's high. A runner running a marathon, he needs to have high levels of endorphin for completing his run. They're often linked to feeling of euphoria and associated with exercise. You have a workout and you feel today, okay, I am ready to take on the world. So these are produced in response to stress and pain, and endorphins are primarily released in the brain and nervous system. So increased levels can lead to improved mood, reduced perception of pain, and enhanced feeling of satiety and comfort. So what are the factors that we can control to have these happy hormones and optimal mix cocktail of them? Diet, nutrition, exercise, sleep quality, stress management techniques, social connections, and relationships. Without this, life, the positive life concepts do not work. So all these are there because these will act through our happy hormones. Nutrition, dopamine boosting foods, fish, avocados, oxytocin and endorphin rich sources, dark chocolate and spicy foods. As spicier as it can get, provided you do not have to consult a gastro. So foods that enhance serotonin, bananas and nuts. In Karnataka, when I went, every time I have a food with them, they give bananas at the end of it. So I'd asked them, what is the reason? Well, it's going on for many, many years. So then I found a reason, because that will increase my serotonin. So bananas and nuts. There is a saying in whenever we say that he has gone nuts or she has gone nuts. No, actually he is on a high because of high serotonin level. So the benefits of regular physical activity, types of exercise that increase dopamine and endorphin levels, we should work for that. Meditation, stress reduction, and different techniques. The role of social connections. In fact, the pedicons, the scientific programs, they are not only scientific, they are not only conveying scientific information or updating you, but they are also the social connections that we depend on to get our things on stability. So the importance of community and support systems. IAP is looking to bring all of us closer to the community. In a splendid audition that Dr. Indumoti gave today, okay, so we are giving back to the community by the emergence, by saving lives across the country, and Tamil Nadu is leading the cause. So gut-brain axis, gut bacteria is very important. Gastro, all of you will be happy to know that, yes, we depend on you. 90% of the serotonin produced by gut bacteria. So dietary components, we all have an idea of what foods is responsible for producing these hormones. So they are the dietary patterns and mental health. So the prescription of a mental health specialist should include the dietary components which could control all of this. So some don'ts: poor diet, lack of exercise, inadequate sleep, stress, and negative relationships. If you don't like someone, do not go near him or her, but do not take the stress from that negative relationships. So that's what we should avoid. There are tech tools and techniques for tracking progress, apps for tracking habits, nutrition and well-being, importance of self-assessment and reflection. At least at the end of the day, let us devote at least 5 minutes in our mind of how we went through the day, what could have been better, or what could have been improved, probably. So those are self-assessments. So acknowledgements and special thanks to Dr. Anirban. He's a child psychologist, and all the other these ladies and gentlemen, Professor Shukanto Chatterjee, Dr. Shushma Desai, Dr. Geeta Patil, and Dr. Piyali Bhattacharya. They are all parts of our things. And well, welcome to Calcutta in January 2026. Any help you need, I am there. This is the tiger and football, which symbolizes Calcutta. So Tigru is waiting to welcome you, and at National Pedicon, Calcutta. Thank you.
Thank you very much, sir.
Thank you, sir.
That was a very thought-provoking and enlightening session, sir. I kindly request the dignitaries on the stage, the speakers as well as the chairperson, to kindly accept mementos from our side. I request the chairperson, Dr. Ilamurugan sir, to present the speakers, Dr. Surendranath sir and Dr. Atanu sir, with a token of gratitude. I request Dr. Surendranath sir to present our chairperson, Dr. Ilamurugan sir, with the token of gratitude. Thank you all. With this, we conclude what has been a very engaging and thought-provoking morning session. We shall now break for lunch and request all delegates to reassemble in the hall by 2 p.m. as we continue with the afternoon's program.
Good afternoon, one and all. Hope you all had a delicious lunch today. Now we move on to the next session. For the same, we invite Dr. R. Krishnasamy sir, senior pediatrician and great teacher from Masonic Medical Center for Children, Coimbatore. With nearly 4 decades of experience, he is a distinguished expert in immunization, newborn screening, pediatric examinations, and child growth and development. It's my privilege to invite Dr. Dijan Shastri sir to deliver the next talk about therapeutic approaches in varicella.
We are meeting of the lunch. After a good lunch, we have two good speakers, great professors of different places, one from North India, one from South India. So I call upon Dr. Dijan Shashti for his lecture. Over to you, sir.
Hello. Hello. Is it audible? Okay. So good afternoon, friends. It's always pleasure coming to the state of Tamil Nadu for the academic events, and this is my third visit to the city of Coimbatore, and it gives you opportunity to meet friends and again get connected with the friends. The topic which is assigned to me is a very straightforward topic, and there is nothing much new in this, but what I have tried to do, that I have tried to compile the recent guidelines on this subject, the recent recommendations, and also have tried to take few cases. And by that way, I will try to make this talk informative and interesting. So we all know that varicella or chicken pox is a primarily disease in a young children, and almost 90% of the cases occurs between the age of 1 year to 14 years of age. And most of the time this illness is minor illness, benign illness, and it does not require much intervention. The complications also not common in a healthy individual, but immunocompromised children, newborns, adults, chicken pox can have many complications. So when we talk about the immunocompromised individual, the disease may have an atypical or a fulminant course. It can be a disseminated varicella with involvement of lungs, liver, heart, brain, and unfortunately these cases are associated with high mortality. So naturally we need to be vigilant about chicken pox in immunocompromised individual or those who are at a high risk. We all know about the acyclovir is the drug of choice for the treatment of varicella infection, and early treatment with acyclovir will prevent the dissemination and progression of the disease. I am not going into the details of the pharmacology of acyclovir because we all know it. Different formulations are available right from the syrup to tablets, injectables, ophthalmic ointments, ocular drops. It is available in different formulations. Now in a varicella, when it happens in an immunocompromised individual, they have a limited T cell response, and in this situation, acyclovir alone will not be sufficient in preventing the dissemination of the disease, and for that, along with the acyclovir, you have to use varicella zoster immunoglobulin. Now this simultaneous use of varicella zoster immunoglobulin will neutralize the virus invasion, it will suppress the viremia, and it will also lead to the rapid prevention of dissemination of varicella. So this synergistic action between the acyclovir and varicella zoster immunoglobulin will be needed for a immunocompromised individual. About VZIG, again it is available in the form of 10 to 18% solution. The solution has got glycine as a stabilizer and thiamerosal as a preservative, and it is prepared by such a technique that the infectious agents like hepatitis B, hepatitis C, HIV, all such infectious agents are eliminated from the product, because we are it is our aim that we should not cause any harm to the recipient. So VZIG is a blood product. It is derived from the plasmapheresis from the donors. So this should not transfer the infection to the recipient. The bottom line of the success of this varicella zoster immunoglobulin is that it should be administered as early as possible and preferably within 48 hours. But in 2011, the FDA revised the guideline and they have in fact recommended or they have allowed the use of varicella zoster immunoglobulin up to 10 days post exposure for the prevention of varicella zoster. Again, I am not going into the details of the product. The product which is available in the Western market, this is only approved for the use by intramuscular route. There are some, when I studied the literature in Germany as well as in UK, the product is available for intravenous administration also. But the intramuscular preparation, dosage based on the different weight band, you have to titrate, and no renal or hepatic impairment, no dose adjustment is required. So these are the different weight band, and depending on that, you have to use the concentration of the varicella zoster immunoglobulin. Certain practical aspects related to the varicella zoster immunoglobulin use, because this immunoglobulin will prolong the incubation period of the varicella, so by 1 week or so. So whenever you treat the patient with varicella zoster immunoglobulin, you have to keep this patient under observation for 1 more week, that is 28 weeks. And by chance, if this patient develops any evidence of varicella, in that case you have to start with the acyclovir therapy. One more thing we should not forget, that those who are eligible to receive the vaccine, the vaccination should be offered at least more than 5 months after the use of varicella zoster immunoglobulin. Because when you use any immunoglobulins, it will interfere with the uptake of the vaccine. So vaccination should be deferred for at least 5 months. The contraindications, again, the patients who are having history of IgA deficiency as well as history of anaphylaxis, we will not give this vaccine. So I think with this, the last part is about the recommendations. So the CDC has a very clear cut. These are the 5, you can say that, eligible candidates for the varicella zoster immunoglobulin. Anybody who is a immunocompromised, maybe primary immunocompromised, secondary immunocompromised, immunosuppressed because of the steroid therapy, because of the chemotherapy, all individuals, they are the candidates. Then newborn whose mother develops the varicella 5 days before or 2 days after the delivery of the baby. In that period, if the baby mother develops varicella like rash, then this newborn is a candidate for the zoster immunoglobulin. Any premature newborn who is above 28 weeks gestation and the mother is not having any history of varicella during her childhood or in adulthood, the baby is at risk, so this baby should be offered the varicella zoster immunoglobulin. Any newborn baby who is less than 28 weeks gestation or the baby who is less than 1000 gram weight, irrespective of maternal varicella zoster status, you will offer the immunoglobulin to this baby. And last is the pregnant woman. As we know that pregnancy is a immunocompromised situation, as well as during pregnancy you cannot use acyclovir. So with this, let us start with some cases. Pankaj, 3-year-old, 10.8 kg, fever, rash, itchy, 5 days, no past history of any major illness, and treated by general practitioner with paracetamol for the fever. The rash persisted, so he has approached the pediatrician, and if you can see the picture, this is a classic case of pleomorphic rash, extensive on the back as well as trunk and face, so it's a case of primary varicella infection. And Pankaj, since he is a 3-year-old, by this age he has no major illnesses, so he is a apparently healthy child, not a malnourished child, 10.8 kg. So again, malnutrition is also not there as a risk factor, and the child has presented after 24 hours. The child has came on the 5th day. So in this case, what treatment we will offer? Naturally, no treatment is to be offered, as we know that in a healthy individual, the primary varicella infection is a benign illness, and usually it requires symptomatic therapy. So no antiviral drugs are to be used. Only those who are at risk of disseminated varicella infection, in such cases only you will use acyclovir in the dose of 10 milligram per kilogram. And again, the beneficial effect of the acyclovir will be highest when it is started in less than 24 hours of the appearance of the rash. Second case, Meena, 15-year-old, apparently healthy so far, fever and rash for last 4 days, not vaccinated with varicella zoster vaccine in past, and there is a history of chicken pox to a younger sib. And here is Meena. If you see, she is an adolescent girl and she has an extensive varicella on the back, and she has not received vaccine in past. So what treatment here we will offer? Naturally, this child you will offer acyclovir, because in those who are above 12 years of age, we need to have an aggressive pharmacological management, because otherwise this patient may have several complications. And here you will start with the acyclovir in the dose of 800 milligram 5 times for 7 days. And again should be begin within 24 hours of the onset. Now when you start the acyclovir within 24 hours of the onset of the symptom, it will have 3 benefits. Like it will decrease the number of days for which the new lesions goes on appearing, decrease the duration of fever, and decrease the severity of the cutaneous and systemic signs. So definitely starting the acyclovir in older children within 24 hours is a beneficial thing. Now what is the AAP recommendation? AAP recommendation is saying that any healthy people who are older than 12 years, people with chronic cutaneous or pulmonary disorder, people who are receiving long-term salicylate therapy, or people who are on short, intermittent or aerosolized course of corticosteroid. These are the candidates for the varicella acyclovir if they are about 12 years of age. Case 3, Shahnaz. She is a 7-year-old female, known case of HIV. She is on irregular antiretroviral therapy, and she has came with fever, rash, cough for last 5 days and respiratory distress for last 2 days. You can see that she has a extensive varicella rash, and this is her picture. So the picture X-ray shows extensive pneumonic infiltration, and it's a case of immunocompromised individual, irregular antiretroviral therapy. So here you will hospitalize the patient because the child had a respiratory distress, not maintaining the saturation. So oxygen therapy was started, IV fluid was started, and along with that, injection acyclovir and injection ceftriaxone was started. Within 72 hours, the child became afebrile, respiratory distress got controlled, SpO2 started becoming normal with the room air, and child was discharged after 7 days therapy. Another similar type of case, 12-year-old female, she is a known case of psoriasis, and she is on a methotrexate 15 milligram weekly for last 18 weeks. She has presented with fever, painful bully, vesicles, which started on the neck and later on spread on the face, limbs and trunk. And again here there was a history of neighboring child having chicken pox, and she had not received the vaccine. And if you can see, she had a extensive varicella like rash on the face. She is a case of secondary immunosuppression because of the methotrexate. So patient was hospitalized, started with injection acyclovir and cefazolin. The disease continued to evolve. There was a dissemination, there was a periorbital cellulitis and febrile neutropenia. And after 6 days of hospitalization, the fever ceased and the lesion started regression. And ultimately, after 10 days of therapy, patient was discharged. This is a day 60 after the discharge, and the patient is absolutely normal. So there is a, in the literature, if you see, there are 2 modalities which are recommended for post-exposure prophylaxis. One is acyclovir and another is varicella zoster immunoglobulin. And there is a very famous one UK observation study that is called PEEP-TALK-3, where 105 immunocompromised children who were treated as a post-exposure prophylaxis either with the varicella zoster immunoglobulin or with acyclovir. And at the end of the study, it was found that the acyclovir is no less than varicella zoster immunoglobulin. And since varicella zoster immunoglobulin is not easily available and it's costly, so acyclovir is a cheap and easy option for post-exposure prophylaxis in a cases who are exposed to the varicella. So Again, as we saw in these previous two cases, in an immunocompromised individual, there will be severe disseminated disease. It can be pneumonia, it can be encephalitis, hepatitis, hemorrhagic complication, all these complications to the tune of 36%. As well as there can be a secondary complications, like there will be infection of the lesions, and infection will lead to then, super infection will lead to the pneumonia or septicemia. So these children should be treated aggressively, and you have to treat with the acyclovir intravenously in the dose of 10 milligram per kilogram, IV 8 hourly over 7 to 10 days depending on the severity of the illness. Please remember, when you are infusing when you are giving the acyclovir, it is always to be given in an infusion, never by push, otherwise it will cause renal precipitation, tubular necrosis, and it will lead to acute renal injury. Another thing is that it should be diluted by 5% D or by normal saline. And when you are treating the patient with acyclovir, you have to monitor for the renal function test, hemoglobin and neutrophilic count. So it is recommended for all severe diseases, varicella in an immunocompromised individual, and symptomatic varicella infection in newborns of a mother with active chicken pox. So any mother who has, as we said, there is a lesion between 5 days before the delivery or 2 days after the delivery, this baby is at risk. So a similar case, and Sujata, she is 26-year-old primipara, and Sujata had a history of fever and chicken pox last like rash just a day prior to her delivery. She delivered a male baby 3 kg by full-term vaginal delivery. All family members are very much worried about the baby. So what advice we will give, or what measures to be taken? So here, because it is in the immediate parental period, there are high viral load transmitted from mother to the baby, as well as there was hardly any time for mother to generate the antibodies and this antibody to get transferred through the placenta. So this baby is at risk of disseminated varicella infection. So you will provide the varicella zoster immunoglobulin and isolate the newborn, keep the baby under observation. If the baby start with the varicella zoster immunoglobulin, or if that is not available, you can use IVIG. And if the baby by chance develops any symptoms of varicella infection, treat the baby with acyclovir. Case 5, I think I will need 30 seconds more. 17-year-old male, fever, malaise, headache, burning pain in the back and axilla since last 3 days, and there is an appearance of erythematous rash which later turned to be blister. There was a history of chicken pox in the late infancy, and this is a picture of Ayush. So this is a case of herpes zoster infection. So what treatment we will offer? So we all know that antiviral drugs are the cornerstone in the therapy of herpes zoster. Now acyclovir or other antiviral you can use, like brivudin, femicyclovir or valacyclovir. But femicyclovir and valacyclovir are not approved for use in the children. So acyclovir is a safe option. It will decrease the length of the time of new vesicle formation, decrease the number of days to attend the completing the crusting, and decrease the days of acute discomfort. Ideally, again, it should be started in 72 hours, duration is 7 to 10 days, and it will definitely help in preventing the post-herpetic neuralgia. This last case, a previously healthy 3-year-old boy, fever, vesicular rash on the left forehead and left eye since last 5 days. Patient's medical history is uneventful. The patient has received 2 doses of varicella zoster vaccine, and mother has denied the varicella-like illness during the pregnancy. And if you can appreciate, the child had a vesicular lesion near the inner canthus as well as on the forehead. This child was started with acyclovir, considering as a case of herpes zoster, ophthalmic herpes zoster, started on acyclovir, topical ganciclovir, gradually the vesicles crusted, and there was a complete resolution, and if you can see, the patient has totally recovered. So for herpes zoster ophthalmicus, acyclovir is a drug of choice. In severe cases, you have to administer it intravenously, or you can use orally also. Again, treatment should be started in 72 hours of the onset of the rash, should be promptly referred to the ophthalmologist, because here you need to have a treatment in coordination with the ophthalmology also. Pain management is very, very important, and also some topical preparations like acyclovir ointment, eye drops, as well as antibiotics. So thank you so much for the patient's hearing, as well as sorry for extending by 1 minute.
Thank you, sir. It was a very good lecture, all about management of varicella, when to use acyclovir, when to use immunoglobulin and the combination. It was very clear. And any questions to the audience?
Maybe after the
or after the next session.
Now I request Dr. Lakshmi Velmurugan ma'am to take the podium for the next talk.
Next speaker is Dr. Lakshmi Velmurugan. We have all treated pneumonias as an outpatient as well as inpatient. Now, madam is going to talk to us how to approach a recurrent pneumonia. Over to you, madam.
Thank you, sir. Good morning, everybody. Good afternoon, everybody. This, after hearing a wonderful session on, a practical session on varicella, now we are going to a session on recurrent and persistent pneumonia in children. All of us are very familiar with the management of pneumonia. What should you suspect in a case of recurrent pneumonia? For the next 20 minutes, we'll be talking on that. Now, what is the definition for recurrent pneumonia? Any 2 episodes of pneumonia in 1 year, or 3 episodes of pneumonia ever, that is called as recurrent pneumonia. The main important point here is, in between the 2 episodes, there should be complete radiological and clinical resolution. That is mandatory. A case of persistent pneumonia in which clinical symptoms along with radiological abnormalities, they persist beyond 1 month or more despite adequate and appropriate treatment. That is very important. In spite of treating adequately and appropriately, if the radiological features and clinical features persist for more than 1 month, you call it as persistent pneumonia. The key differentiation in between the two is, in recurrent pneumonia, there's a symptom-free interval totally, whereas it is not there in persistent pneumonia. There is a significant overlap between recurrent and persistent pneumonia, and mostly it results from either local or systemic defense defects. For example, a child might suffer from primary ciliary dyskinesia or from primary immunodeficiency disease. That is what we call as defense defect. Or it may be due to some anatomical disorder which is there in the lung. For example, it can be a case of cystic adenomatoid malformation, or it could be a case of sequestration of lung. In such cases, you get the persistent or recurrent pneumonia. The approach to this depends upon the competency of the physician who has seen many such cases, and also the availability of resources like bronchoscopy and CT pulmonary angiogram. These 2 investigations become very important in a case of recurrent pneumonia. Now, this question has been repeatedly asked: is an X-ray needed for the diagnosis of pneumonia? Clinical symptoms like fever, cough, fast breathing, is it enough for making a diagnosis of pneumonia? Though X-rays are not mandatory to diagnose pneumonia in OP, but personally I feel there's no harm in doing it, as it definitely gives a clue to the etiology. Why X-rays are not considered important in the first episode of pneumonia is because X-ray changes will take some time to appear. The same way, the X-ray changes take some time to disappear too, even after the pneumonia improves. So for a first episode of pneumonia, whether it's needed or not, you can debate. But whereas for a second episode of pneumonia, it is definitely mandatory. And even in the first episode, if you have abnormal clinical findings like persistent localized crepitations or reduced air entry after resolution of fever and tachypnea, it becomes. So the answer is yes, it is definitely needed in the first episode as well as for the second episode. Now, I have just 10 case scenarios. Rapidly, I'll go through the case scenarios. This is a 10-year-old child. All of us are able to make out the right upper lobe pneumonia in this child. Child was treated with ceftriaxone and discharged with cefpodoxime. But since the pneumonia appears a little large and bigger, the physician wanted to take a repeat X-ray and wanted to see whether it is resolved. which he needn't have done it, but he did it. But the repeat X-ray showed the pictures remained exactly the same. It did not alter. So this child underwent 4 films over a period of 6 months, but resolution never happened. Radiological resolution never happened. But the child was totally asymptomatic. The physician and the mother both were frustrated. In such a case, you should remember that when there is complete recovery or good clinical recovery, but if the radiological persistence is there for a longer period, the etiology of pneumonia wouldn't have been pneumococcal pneumonia as is usual or H influenza pneumonia. It could have been a case of adenovirus or mycoplasma pneumonia, right? And adenoviral pneumonia, last epidemic we had it. It presents features typical of bacterial disease with high fever, lobar infiltrates, paranpneumonic infusion. In fact, sometimes you can even have empyema in a case of adenoviral pneumonia. And it's one of the second most common cause of viral pneumonia after respiratory syncytial virus. So rule 1 is, whenever there's clinical persistence but delayed radiological recovery, think in terms of adenovirus. Second case, cough for 2 months, azithro, amoxiclav, everything over. X-ray after 1 month, see, the X-ray is remaining the same. And the child also had a persistent cough. So cough was persistent and radiological persistence was also there. So in such cases, you cannot leave. What next you should do? You should definitely go ahead with the bronchoscopy. And in this case, though the CBNAT, gastric lavage CBNAT was negative, or it was negative for tuberculosis, the ball CBNAT became positive. That is bronchoalveolar lavage taken by bronchoscopy that turned out to be positive. So whenever there is radiological persistence and clinical persistence, go ahead with investigations. Case 3, you are able to make out this X-ray which shows with the mediastinal shift to the same side, left side, a child with cough for 1 month. It is a typical, what do you say, collapse consolidation. Though this terminology is not very much accepted, this X-ray is very typical of a collapse consolidation X-ray. In this child again, CBNAT was negative and MAN2 was negative. And what next? You might be wondering, what is the use of the CBNAT? In all these cases, the CBNAT is becoming negative. So what is the real positivity of CBNAT? Even in whatever specimen you take, you can take a resting gastric juke, you can take a bronchoalveolar lavage, you can take a CSF, whatever specimen you take, the chances of your CBNAT becoming positive is only 20 to 40% at the most. So you should, even if the CBNAT is negative, still child can have tuberculosis. So in this child of collapse consolidation, when we did a bronchoscopy, groundnut was removed. Again, a humble advice to all the parents which we usually give is, don't give whole groundnuts in the form of giving good protein source. Don't try to give groundnut in children less than 1 year. It should always be a finely ground powder which can be made into a ball or something. Otherwise, groundnuts are very dangerous for children. And so rule 2 is, whenever there's clinical persistence and radiological persistence, tuberculosis and foreign body has to be ruled out compulsorily. So when will you investigate a case of persistent pneumonia further with bronchoscopy or with your CT? Failure to thrive. Whenever the child has failure to thrive, it's not growing appropriately, investigate. Whenever the same lobe is involved every time, you can suspect anatomical problems like CPAM or sequestration. So again, investigate the child. Different lobes every time. Physiological problem like primary immunodeficiency or ciliary dyskinesia, you should suspect, investigate. Early age of onset, multi-system involvement, for example, pneumonia plus GI involvement. Think in terms of cystic fibrosis. Chronic URTA from first month of age, again primary ciliary dyskinesia, you should think in terms of. Family history of lung disease or death, and whenever clubbing in a child with whom probably child is having bronchiectasis and the cause of bronchiectasis, you will have to evaluate. You will have to evaluate a child of recurrent pneumonia whenever you have these following clues. And the key questions which you should ask, 5 questions you should ask is it really arising from the lung? That pneumonia which you see, is it really part of a lung or some extrapulmonary structure which is seeing, you are seeing as pneumonia? Or when it is a lung structure, whether it is pneumonic infiltrates or other extrapulmonary or extra pneumonic infiltrates. Whether there is a very slow recovery, whether it's the same lobe every time, different lobe every time. Now this case, this child has been a 2-year-old child, admitted with breathlessness, cough and fever. It was treated with IV antibiotics, nebulizers, and it was referred as a case of right lower lobe pneumonia. That arrow, can you see? Does it look like pneumonia or some extrapulmonary vessel or vein? Yes. When a CT was done, it clearly showed that it was not a case of pneumonia, it was an abnormally dilated pulmonary vein. That arrow, yeah, are you able to make out that? This one, this part is is a dilated pulmonary vein, and it turned out to be a case of scimitar syndrome. And this one, can anybody guess what? This first case was referred to us as a case of right upper lobe pneumonia. The second case was referred as a left upper lobe pneumonia. Is it looking like pneumonia, Nishanti? Can you guess what the diagnosis could be? Anybody? Yes, ma'am? AV malformation, something more physiological, very simple. Yes, excellent. Which is excellent. It's a thymo. It is a normal thymus, which was referred to us as a case of recurrent upper lobe pneumonia, and this one was referred as a left upper lobe pneumonia. Normal thymus is so easy. Only pediatric radiologists interpret it appropriately, and pediatricians rather than adult radiologists. So it was a thymus which was referred, and it was investigated as a case of recurrent pneumonia. So always find out whether it is a pulmonary or extrapulmonary. So it can be either an abnormally dilated vessels, or it could be thymus, or it could be a esophageal duplication cyst. Now, another 6-year-old child with recurrent pneumonia for the past 1.5 years, 6 times child was admitted. Each episode, one important thing which was not there, you should always detail the details. You should write what went wrong. Fever, first episode. Second episode, fever plus tachypnea. Third episode, fever, tachypnea, cough. You please detail it like that. In each episode, what we noted was there was no fever at all. And CBC showed severe anemia, hemoglobin 4.5 to 6.5 grams, and X-ray showed mild cardiomegaly. Is this recurrent pneumonia? Any guesses? Pneumonia with anemia? Yes, this is Ball showed 80% hemosiderin-laden macrophages. So it's not a case of recurrent pneumonia, but this is pulmonary hemosiderosis. So pulmonary hemosiderosis, asthma, hypersensitivity pneumonitis, vaginous and sickle cell anemia can present with recurrent lung infiltrates which resembles pneumonia. Then this case is easy. Yeah, all of us are able to make out that lung abscess in the right lower lobe. Lung abscess is an easy diagnosis to make from the X-ray. But the one history which we had was child had a similar lung abscess 5 months back. That is not common. Okay, 2 times you getting lung abscess in the same lobe is not common. So when we went, when the child was investigated, it turned out to be a case of, so same lobe, you should always think in terms of anatomical malformations like cystic pulmonary adenomatoid malformation, sequestration or tracheal bronchus, and the investigation of choice in congenital pulmonary malformations is CT or CTPA. And when CT was done, it showed that clearly the cystic malformations was made out in this X-ray. And for you, one information carry home message which I would like to tell you is, please don't take CT when you have an acute infection. All the underlying abnormality will be masked. You will just make out a pneumonia. Pneumonia you would have already made out in a X-ray chest. So don't take CT in an acute phase. And this child, CT findings were more pronounced when not infected, and a diagnosis was CPAM was made in this. Case 7, recurrent pneumonia. See, very, very sad case this one. The child had pneumonia in January 18, total resolution in January 18. In February 2019, again the same lobe child had pneumonia, again complete resolution in June 2019. And again the last time, January 2020, when it was referred from another hospital, when we did a bronchoscopy, a mucoepidermoid carcinoma was made out in this child. Same lobe. And unilobar opacities can either be due to congenital malformations and airway narrowing. Airway narrowing can be due to foreign body, which I told you earlier, or due to tuberculosis, very rarely due to neoplasm. In all these cases, the investigation of choice is bronchoscopy. So unilobar opacities, recurrent pneumonias, you'll have to go ahead with a bronchoscopy or a CT chest. Multilobar pneumonia, when this recurrent URI and infections, you should think in terms of primary immunodeficiency or ciliary dyskinesia. When it's associated with malabsorption, you think in terms of cystic fibrosis. When you have feeding difficulties, you think in terms of aspiration, congenital heart disease, or neuromuscular diseases. And this is the 8th case, 10-month-old infant choking during feeding and failure to thrive. Any guess? H-type esophageal, all of you said H-type, most of you said H-type esophageal fistula. Though it is commonly suspected, we think in terms of it is a very, very rare cause of recurrent pneumonia. But this child, it turned out to be H-type fistula only. In fact, it is an N-type fistula, we should call it. Tracheal end is because at a higher end, and you need a bronchoscopy and a barium study. See how nicely the barium depicts the H-type. But to get this picture, you don't attempt it. Hand it over to a pediatric surgeon. Let them get that picture of barium swallow. It's a very tough job to get this picture of H-type fistula. 9th case, growth failure plus 5 prior admissions, multilobar pneumonia, pus from both ears. Guess? Think in terms of immunodeficiency. 4 or more new ear infections in a year or more than 2 pneumonias in 1 year, always go ahead and think in terms of primary immunodeficiency. Which primary immunodeficiency presents with recurrent pneumonia? X-linked agammaglobulinemia presents with recurrent pneumonia, CGD, and common variable immunodeficiency. And whenever we talk about immunodeficiency, people lose what they become, okay, it's not for us, it is for medical college people. It's not at all like that. Very simple clue I will tell you to diagnose primary immunodeficiency. Anything which presents less than 6 months in the very early period, 1, 2 months, 3 months, think in terms of severe combined immunodeficiency. 6 months to 5 years, the diagnosis is usually X-linked agammaglobulinemia, and more than 5 years, it is common variable immunodeficiency. Very simple clue by which you can diagnose either SCID or X-linked agammaglobulinemia. Very, very useful clue. And again, whenever the B cell deficiency, X-linked agammaglobulinemia, when you suspect, do an immunoglobulin profile. And SCID, when you suspect a T cell deficiency, you do a CD3 immunoglobulin profile. Very simple. The last case scenario, I think you are going to give the diagnosis. Multilobar pneumonia, failure to thrive. Child had a protuberant abdomen. What we have not talked about so long in a case of recurrent pneumonia. Any clue with a protuberant abdomen? Probably a GI involvement is there with pneumonia. Always suspect cystic fibrosis. Any child who presents with oily stools, summer dehydration, and this aquagenic test, it's a very simple test. Genetic mutations, before going to genetic mutations, how do you get this? Normally when you dip your hands in water, it at least takes 10 minutes for the wrinkling to happen. Whereas in a case of cystic fibrosis, when you dip your hands in water, it just takes 3 minutes for this wrinkling to appear. You can suspect cystic fibrosis whenever you have such a aquagenic test positive or aquagenic wrinkling test is positive. In such children, hyponatremia is usual electrolyte abnormality we usually make out. Deranged LFT can be there. And whenever you have a pseudomonas infection in ball or any episode, you can always suspect cystic fibrosis. And sweat chloride done more than 60 milliequivalent twice when you get, you can always make a diagnosis of cystic fibrosis. Very simple tabular column. Whenever you suspect recurrent pneumonia, unilobar pneumonia, go ahead with a bronchoscopy and CT chest. Multilobar pneumonia, always rule out primary and secondary immunodeficiency. If that has been ruled out, always do a HIV too. Ruled out, you have only 5 or 6 causes. It can be either congenital heart disease, aspiration due to GRD, allergy and asthma. It can be a post-infective bronchiectasis, structural abnormality like CPAM, or mucociliary deficiency. This last slide, most important one. Recurrent admissions for cough is not recurrent pneumonia. Very important. It can be a simple case of asthma exacerbations. Don't forget asthma whenever you are investigating a case of recurrent pneumonia. So carry home messages. First find out whether it is arising from the lung. If it is arising from the lung, whether it is pneumonia, whether this is slow recovery, same lobe every time, think in terms of anatomical problems. Different lobe every time, multilobar pneumonia, think in terms of primary immunodeficiency or primary ciliary dyskinesia. Always rule out asthma. Do not forget foreign body or tuberculosis in a case of recurrent pneumonia. Feeding history is extremely important. Examine other systems like GIT to rule out cystic fibrosis. Avoid CT scan in a case of acute pneumonia. Thank you very much for patient listening. I think I have completed on time. Thank you.
Pneumonia and what investigations to be done. Thank you, madam. Any questions?
Hello, sir. There is one question from the audience from Dr. Gautami. The question
Yeah,
is.
I have this question. In fact, I highly appreciate the wonderful system that while I am on the dais, I get the email regarding the question from the floor. It's really most remarkable thing I have noticed in this conference only, nowhere else. So the question somebody has asked, whether prophylaxis with acyclovir is needed for a previously unimmunized asymptomatic child in a contact with the sibling with active varicella infection. So in my presentation, I made it very clear that contacts who are immunocompromised or a contact who is above 12 years of age or a pregnancy, these are the three conditions where you need to offer the post-exposure prophylaxis. Younger children, by and large, varicella is a benign, mild illness. So in such cases, chemoprophylaxis post-exposure is not recommended.
Thank you, sir. With that, we come to a conclusion of the session. On behalf of the organizing committee, we extend our sincere gratitude for the time and effort that you have spent, both the speakers as well as the chairperson, for putting this together. Kindly accept a token of gratitude on our behalf. I request the chairperson, Dr. Krishnasamy sir, to please felicitate the speakers with a token of gratitude. I request Digant sir to felicitate our chairperson, Dr. Krishnasamy sir, with a memento. Thank you all. With that, we come to an end of this session. We are proceeding with the general body meeting now, which will start shortly.
welcome to all who have gathered here. Now we'll start with the pediatrician's prayer. I request Rajkumar sir to deliver the pediatrician's.
Good afternoon, one and all. Please stand up for pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, amid all people. Thank you.
I request people who are standing in the back to kindly come and sit in the front. I request the organizers to inform to the other halls that no further proceedings should be done in any other hall, and request everybody to come for the GBM. Organizers, Dr. Murli, Bala sir, can you call everybody to close the proceedings in the other? Yeah. Obituary to the members who have departed in the past 1 year. I request all of you to stand for us 1 minute. Dr. V.S. Krishnakumari ma'am, former director of Institute of Child Health, Dr. P.S. Muralidharan from Chennai, Dr. Sajid, Dr. Salim, and unfortunately yesterday we lost Dr. T. Rajagopal sir from Madurai, father of Dr. Bhuma ma'am. 1 minute of silence for the departed souls. Thank you all. As we start our general body meeting, I request our Honorable President, Dr. Rajendran sir, to kindly give the felicitation.
Good afternoon to all, and most respected our Central IAP SSG, that's Honorary Secretary General, Dr. Yogesh Parikh sir. On behalf of IAP-TNSC, welcome Dr. Yogesh. And most respected our President 2024, Dr. Balashankar, President-elect Dr. Somasundaram, Vice President Dr. Gopal Subramaniam, and Joint Secretary Dr. Sudhagar, and Dr. Jayabadna. So, AAA Dr. Balaji, Editor Dr. Sridevi, Academic Coordinator Dr. Thirumurugan, and the Secretary Dr. Narmada, and Treasurer Dr. Rajkumar, and all central as well as state EB members, and most respected members of IAP-TNSC. And once again I welcome on behalf of IAP-TNSC, and it's a great pleasure and a privilege to be here as a President of IAP-TNSC 2025. And this from start with the 2025 January onwards as I took over. We had a 5-point agenda. One is academics, is improving academics. We planned many academic programs like start with the B2B and PG teaching program, and pediatricians, that's Pralata programs each week also, and PDNE also we are proposing, and P4 also we are proposing, and that also we are already implemented. And we had so many representation to the government also, and we IAP-TNSC, Avis Perer, as a team, we met Principal Secretary of our CM, Dr. Manath, as well as second in position, Dr. Sanmugam, and Health Secretary, Dr. Sendil Kumar, as well as Education Secretary also, regarding that social reform recommendations, like if you are going for vaccinations, one things we have to improve, ask them to include almost 9 vaccines in the government schedule. So they already rolled out varicella vaccine also, that's it's a human papillomavirus vaccine, HPV almost 38 crore. They are sanctioned the budget. They are going to implement slow paces. They agreed already. And regarding inclusion of MMR in the our Tamil Nadu state health program also, we have asked. I think they are going to represent to the central government also, and other vaccines like going for varicella and as well as hepatitis A also. So many vaccines we asked to represent to include in the health program. That's why I have done. And another one is regarding that early child development issues, like early child development disorders identification screening also we are approached. We asked the school to go for screening through IAP members. That also we approached. And another one is we requested the permission to go for school regarding drugs and social media addiction from AHA chapter. We are that also after some issues the government has stopped all the social workers, NGOs, as well as even our pediatricians also. They can't go to school and directly ask permission to conduct the classes, awareness among the students. That also we are represented to the government. I think they agreed to review our situation and give a permission also. So we asked that a thyroid screening and all other newborn screening program include in the coming year health program also we are represented. That's already we are done. And coming to the second one is regarding cultural and sports activities. We already conducted Trichy. This year we onwards we have separated cultural and sports from the Pedicon, because both clapping together, no, it's really disturbing our academic activities. That's why this year we conducted that cultural and sports meets under leadership of Dr. Ismail and Aram Sendil. They participated at that's Trichy with the help of Trichy IAP and Makaveri. So well organized and really appreciated by all of them. And we are planning for next level of subsequent years. I think we'll go for that cultural and sports separate event. And second one is we are going for leadership programs. So we are since we have so many sub-chapters all over India, but we are lacking the sub-chapters, and we almost 8 sub-chapters this year we have started, and mainly for each sub-chapters we start with pediatric emergency, and another one is environment, child health and asthma and allergy, like that, no? So eye cancer also, so many sub-chapters, 8 sub-chapters we started, and this each sub-chapter level chairperson, and you can go for chairperson elect and secretary, joint secretary, like that. So main aim is we have to groom our youngsters, so go for national level. We are lacking that leadership from our our state, and that's why we have to groom our youngsters. We have to take up the national level post. So everybody aware that last president was 1997, Dr. Barsardi. Almost 28 years no president from the Tamil Nadu. So currently we are having almost 4,500 life members at present, and apart from Maharashtra we are in second largest branch. So we are not having president almost 28 years. So that's why we have so we have to develop why that's happening. No, that means we are not having leadership, and that's why we are planning for leadership development program also. And this year, innovatively, we in Kongu Pedicon had a separate Yuva Hall also for that under 40 years. We had under 40 years that we had separate hall for the youngsters also. So a lot of innovative ideas we are taking for the grooming of our youngsters to come up that national forum. The third one is we are planning for that almost 2004 we had last Pedicon. So this year, after planning of almost 1 year, we achieved this national Pedicon at Tamil Nadu, and with the help of all the central IAP members and all our brotherly states, we have achieved this national Pedicon at Coimbatore, and so I think it's glad to inform you also, and I think already everybody knows that one. So we'll have definitely the same venue we are going to have next year 2027, we'll have national Pedicon. And more than that, next year we are having Golden Jubilee Pedicon, that's our state Pedicon at Chennai, and they are going to organize Chennai, it's a Golden Jubilee Pedicon also. And I think both we have to achieve, we have to go for national level. This is a very important milestone for us also. And if you are going for next membership drive, so from January onwards, I think we are almost 600 life members we enroll. That's a great achievement from our team led by Dr. Singarvel sir and Dr. Ramesh Babu as a vice chairperson and Singarvel as a chairperson. They have worked hard along with Dr. Tirumurugan and all Chennai. So I can say all office parents, central EB members, I can say so many persons they involved and last minute enrolled. And so I think we 250 life member, if we are crossing, definitely will get one EB member. I think already we are having 5 life member in Tamil Nadu. So I think, I hope that this we exceeded that, I think that 4,300. So I must get this one member. I think Dr. HSG, our honorary secretary general, he knows that they are going to announce shortly. So officially we didn't receive communication, but unofficially I can say that definitely we crossed that milestone. Definitely this year we are going to get one more EB member for Tamil Nadu. That's a point we achieved. And fifth one is I want to, openly I want to request you. Since we are not having central IAP present past 28 years, I request this general body and respectful IAPians to take it your own candidate standing for the national IAP. I request all of you to support Dr. Singarvel sir. He is well known, and he is all over India. He is well known and soft spoken leader, and he was the vice president of IAP also, and he is having very good chance. We have to ensure that he has to win this election for this national level. So once again I thank that the general body IAP members to give this opportunity. Thank you very much.
And now we have a very special guest, our Honorary Secretary General of Central IAP, Dr. Yogesh Parekh amongst us. I request him to kindly deliver his address.
Hello, thank you, Dr. Ramada. Good afternoon, all. After the heavy lunch, it is very difficult to stand and sit in the general body with the awake mind, but there's still large gathering of the Tamil Nadu state branch. So first of all, thank you for this opportunity to have a sitting with all of you. And congratulations to the Tamil Nadu state and Coimbatore city branch for getting Pedicon 2027 in this venue. So Dr. Rajendran, Dr. Narmada and the whole team of the Tamil Nadu state with the help of Dr. Jalil, Dr. Singarulu sir, Dr. Thiru, Dr. Ismail, all the EB members have worked hard to get and support from all across the country. And the more than 50% executive board members have kept faith and trust in the Tamil Nadu leadership and the Coimbatore city leadership. Now it is your turn to make it a more successful, memorable to the country, all the IP members. So I hope you will keep our faith, because more than 50% votes of the executive board members will get it. A very difficult task in the for the Pedicon bidding, who are the experienced person or IB members, they know it is how it is difficult. But getting it done, so congratulations, and I hope for the best successful Pedicon in 2027. Again, congratulations and best wishes for the team Tamil Nadu for the excellent academics years. I am observing since last year, Dr. Balashankar sir, my dear friend and mentor, was there, and they have delivered the best academics. This year also, Dr. Rajendran and Dr. Narmada madam doing the best academic activity, and we hope under the leadership of Dr. Samusundram and Dr. Narmada, they will also believe the best. Regarding the membership, all the 6 EB members, including Thiru, all have done excellent work with the support of the state and the city branch leadership, and the cross remarkable journey of the more than 4,500 near to, I am not declaring the exact number, but it will be the 6th seat of the Tamil Nadu will be there, and Pondicherry. So 7 seats will be for the Tamil Nadu state and the Pondicherry. So again, the congratulations for the state leadership and my all EB members of the Central IAP. Special thanks to our membership drive. Where is sir? Yeah, Ramesh Babu. Always is very supportive for the Central IAP, all the activity with along all our EB members, Dr. Thiru, Dr. Amal Raj, Dr. Ismail, Dr. V.T. Rajesh, and our senior most veteran, Dr. Annamalai Raghavan sir, Vijay Raghavan sir. So thank you very much, and congratulations again for the enrolling the 6 new sub-chapters of all the Central IAP sub-speciality chapters. So we have to learn more and more things from Tamil Nadu leadership, and we hope, I will not say openly, but my best senior friend sitting along with Dr. Jalil, so best wishes to him, because officially I can't deliver, but he is my senior brother, and we all know Tamil Nadu is having a leadership at the national level, as Dr. Rajendra sir mentioned, more than 23 years or 25 years. Yeah. So now it is your turn, and we hope for the best wishes to team state, Tamil Nadu state, and Chennai, Thanjavur, Coimbatore, Salem, Dindugul, my dear FBS person, Dr. Veluswamy, sir. So many branches also last year we have enrolled, and this year also we have enrolled 3 branches in this month only, Virudhunagar and Karur, Hosur. So this is something new, that whole Tamil Nadu state united and working hard. So this will give the best results in the coming few years and the few months. So thank you very much. Dr. Narmada and Dr. Somsundaram, best wishes for your great successful tenure next year. Thank you.
Thank you so much, sir. The support of the CIAP is always required for state branches, and we are having it, enjoying it with your secretaryship. Thank you so much. Now, addressed by immediate past president, Dr. Balashankar, sir.
Respected President Rajendran sir, Secretary, Treasurer, Vice President, President-elect, and Yogesh Parikh sir. First of all, thank you Kongu Pedicon team for this top-notch conference, getting full marks in all aspects. Thank you for everything that you have done. Then this year has been full of activities, starting from academics. Let it be a new event done, that is Sport Culticon. Let it be starting of starting of new chapters, 8 new chapters. and bidding the conduct of National Pedicon. Everything has been fantastic this year, and I would like to give some of the suggestions which in the present months and in the coming president also can take up, and that will take IAP to higher levels. Still, I feel that the charity activities and public health activities are little lagging. I think we can increase more number of public health and charity activities so that IAP will be known to the public also. Second is, we should continue the membership drive. Fantastic work has been done throughout the year by Dr. Singarvalu and Dr. Ramesh Babu sir, and we are fortunate enough to get one more EB member, and it has been announced by the Secretary General itself. So we are getting 6 EB members next year, and we have equaled Mumbai. So Mumbai la idhe alavu dhaan EB members irukanga, Maharashtra layum. So we have sustained to that level. So we have come to that level. Mumbai ki equal item, Maharashtra ki equal item. In that way we are all proud, and this should continue every year. The membership drive வந்து it all ஒரே ஒரு key இது என்ன அப்படின்னு கேட்டிங்கன்னா ரெண்டு பேர் தான் they can play key role. Number one is the HODs of all the medical colleges. பாஸ் பண்ணி போகிற ஸ்டூடெண்ட்ஸ் இந்த அலுமினி மாதிரி இருக்கும் இல்லையா, அவங்கள வந்து முடிச்சு போனதுக்கப்புறம் ஒரு மெசேஜ் மாதிரி போட்டாலே போதும். இந்த மாதிரி ஒன்ஸ் யூ ஹவ் காட் த ரெஜிஸ்ட்ரேஷன் சர்டிஃபிகேட் அண்ட் ஆல், ப்ளீஸ் அப்ளை ஃபார் லைஃப் மெம்பர்ஷிப் அப்படின்ட்டு போட்டிங்கன்னா இட் இஸ் ஈஸிலி டன். I think Ramesh Babu sir next year one of the people who will be the EB member next year will take up his work and get it done. அவர் காலையில் கொடுத்தோம்னா மதியம் வந்து நம்பர் வாங்கி லைஃப் மெம்பர் ஆகி கொடுத்துட்றாரு ரமேஷ் பாபு சார். இட் வாஸ் அ வண்டர்ஃபுல் ஒர்க் ஹி டன். ஸோ இன்னும் ஒரு ஆள் அவர் அடுத்த வருஷம் வர எக்ஸிக்யூட்டிவ் மெம்பர் கேன் டேக் அப் அண்ட் see to that we get more and more life members and make our Tamil Nadu state high in number in life memberships. That is another thing I wanted to tell. And reaching the periphery of so அதுக்குமே வந்து முக்கியமாக வந்து உதவ வேண்டியது வந்து டிஸ்ட்ரிக்ட் ஆஃபீஸ் பேரர்ஸ் தான். இப்போ புதுசாக நிறைய டிஸ்ட்ரிக்ட்ஸ் வந்து இண்டிவிஜுவலாக ஆரம்பிக்கிறது வந்து தட் இஸ் வெரி 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 குட் ஃபார் தட். ஏன்னா இப்போ வந்து மதுரையில் இருக்கோம் அப்படின்னா திண்டுக்கல்லில் இருக்கவங்க முன்னால் வந்து ரொம்பலாம் வரமாட்டாங்க. அதே மாதிரி சிவகாசி சிவகங்கை மக்கள்லாம் வந்து மதுரைக்கு வந்து வரமாட்டாங்க. ஸோ இப்போ ஒவ்வொன்றும் இப்போ வந்து திண்டுக்கல் தனி பிரான்ச் ஆச்சா, அவர் ஆட்டோமேட்டிக்காக ஹீ இஸ் கண்டக்டிங் ஹிஸ் ஓன் சிஎம்இஸ். விருதுநர் அடுத்து இந்த பிரிஞ்சு போகிறாங்க. ஸோ தே வில் பி டூயிங் தர் ஓன் ஒர்க். ஸோ தட் வில் பிரிங் இன் மோர் அண்ட் மோர் பீப்புள் ஹூ ஆர் இன் த பெரிஃபரி இன் டு த ஐஏபி ஃபோல்டு. ஸோ தட் இஸ் வெரி வெரி இம்பார்ட்டண்ட். அது ஒரு நல்ல விஷயம், இந்த மாதிரி நிறையா பிரான்ச்சஸ் ஆரம்பிக்கிறது. ஸோ somehow or other we have to reach. அது டிஸ்ட்ரிக்ட் ஆஃபீஸ் எல்லாருக்கும் ரெக்வஸ்ட் பண்ணி கேட்டுக்கிறேன், பெரிஃபரியில் இருக்கிற மற்ற பீடியாட்ரிஷன்லாம் கொஞ்சம் வந்து சிஎம்இ அதெல்லாம் அட்டன் பண்ண வைங்க. தட் இஸ் குட் ஃபார் தெம் as well as for the IAP also. With these few suggestions, thank you for the opportunity. Thank you very much, sir.
Thank you so much, sir. Now I request our address by President-elect Dr. Somasundaram.
A warm good evening to one and all. Respected President of the day, Dr. Rajendran, past President Dr. Balashankar sir, Vice President, Treasurer and Secretary Dr. Narmada, all the senior IAP members of IAP Tamil Nadu Staff Chapter, a warm good evening to one and all. So first of all, I should acknowledge that we can see a good number of IAP members attending the general body meeting. That itself, it shows that the involvement of the members in the proceedings of IAP Tamil Nadu State Chapter. And this is reflecting in the way IAP Tamil Nadu State Chapter is being looked at the national level. So all has been spoken of yesterday in the inaugural function, and my senior presidents who have spoken before. So I also would reiterate only 3 points. The first point is about IAP-TNSC. We all know that it's becoming the second largest branch in the country, and the last few years IAP has grown leaps and bounds both in academic activities and bringing in young talents and community services. This year till 8 months also under Professor Dr. Rajendran and his team is having lot of innovative things which has been brought under the Presidential Action Plan, and that is getting implemented month after month. And as I told you, for 2026, when we enter the Golden Jubilee year, we also have certain plans which will be following the predecessors, and that will be implemented on a face-to-face basis. The second one about Kongu Pedicon. I told in my inauguration, this is a next-gen conference with a lot of innovative ideas in terms of your handy things like flipbooks, WhatsApp registration. After my talk, I have got about 8 questions. I didn't have time to answer. It has come to my mailbox. So that's the way this the conference has been worked, and everything. Yesterday's the dinner after the inaugural, it went on till 11:15 or 11:30, and on a dry day, people were able to have such stamina to dance till 11:15, 11:30. So the cuisine, the Madambatti food is it's so lovely. It's mouth-watering. Everything is so lovely. So congratulations to the team Kongu Pedicon on behalf of IAP Tamil Nadu State Chapter. So the last point one agenda is still unexplored and still to be accomplished by us. We see a array of national leaders coming to us, but we still not have a national leader who can go and attend other places. So we are in the way. We have hardly 6 to 8 weeks to accomplish that. We all know that what is also is there, Professor Singaravelu election. So request all of you to reach, not you to vote for Singaravelu, that everybody will be doing. So, but to reach your people, your friends. Most of you have friends all over the country. Most of you have done your post-graduation in other places. So reach to other people who say that we didn't have a president for the past 28 years, no secretary, no treasurer from our place. So, but we have found an able person, a non-controversial person who can be there, and please give us the chance and vote for Dr. Singaravelu. With these kind words, thank you one and all for this opportunity.
All of you would have received the minutes of the previous GBM held at Tirunelveli. If there are any clarifications. So if there is no further any doubts or any clarifications, request you all to pass the confirmation of the minutes of the last GBM. Passed by Dr. Tirumurugan. I think you can't do it because you were the office bearer at that time. Ismail sir and Dr. V.T. Rajesh. So confirmed by Ismail sir and passed by V.T. Rajesh here. Thank you. So any minutes or business arising out of the minutes? There was no one. So we'll proceed with my secretary's report. I mean, most of you would have attended the inauguration yesterday, but still now I can present it a little relaxed here, but I'll complete it within 10 minutes. So we started off with a very, all this has been presented from 1st January 2025 to 10th August 2025. We started off with a winning note at our National Pedicon, where we had where we got the most of the awards at the National Pedicon here. Our presidential action plan started off with the launch of the membership month drive. As everybody has been speaking about, we could reach 600 members, and then we have also become the second largest branch and got an extra EB this year, thanks to the efforts of Dr. Ramesh Babu sir. And one another very important one which reached to the national level is One Day One Drug Digest, very beautifully carried on by Dr. Tirumurugan, Dr. Balaji, along with their team members. Every day, even yesterday, we had the digest coming up into our WhatsApp. They have almost reached, at the time of the preparation, it was section 175. I think now it's issue 176 today. So this is one of the very big event, and with the scientific advisor, Dr. Singaravelu sir, we are able
to reach the whole of India, and many people are expecting for the same. Further action with regard to this is also going to happen in the next 2 months. As was said, we launched many of the subspecialty chapter. The first chapter to be launched was IAP Medical Education chapter on February, IAP Pediatric Allergy and Applied Immunology chapter. Medical Education chapter also had its CME. We had the installation of Pediatric Infectious Disease Academy, though it was already existing. We had the installation of the new office bearers at Trichy. Tamil Nadu Environmental chapter was started. This was a really one of very close to my heart, and we had Dr. Paramesh sir also giving the inaugural invite, and we had Dr. Balachandra attending the same. IAP iCancel was also started. Then already spoken about Sports Culticon at Trichy was one of the very innovative one. We usually have sports and cultural competition along with the Pedicon. We wanted to give more importance to the sports and cultural. We had a special event for it in July 12th and 13th, and IAP Kaveri, we appreciate their sponsorship and their support for the same. And several of our leaders have especially Dr. Amalraj has participated in most of the liaison meetings along with the state government, and we also had opportunity to represent ourselves in Tamil Nadu Medical Council. The academic of pediatric specialties has been very, very active under the academic coordinator, Dr. Tirumurugan. We have four sessions. One is the perspective plunges for in pediatrics for practitioners. Every Sunday of every month is being occupied, and we have state speakers also from national level also. These are the 7, this was headed by convener as Dr. Ashwath. Very, very interesting and practical topic for pediatricians. Immunization colloquium by experts, very beautifully led by Dr. Nandini Kumran madam and Dr. Jalil sir. They had all the vaccination experts throughout the nation to come and speak, and almost 5 sessions was over. The 5th one was a curtain raiser for the Kongu Pedicon, and it was almost a 3-hour CME. Many people have attended, more than 1,700 hits in the YouTube. We all have on Saturday pediatric postgraduate masterclass. This is very beautifully coordinated by Dr. Kritika, very essential for our postgraduates, and it is one of the well attended. Dr. Tangavel sir is giving all our practitioners back to basic classes. It is like listening again from our teacher. We almost had 7 sessions. He started off from the clinical history and going every day. Even growth chart is being held. Pediatric dialogues with national expert is coordinated by Dr. Somasundaram. As we said, we have national experts giving a very important topic, a little higher topic than the routine practice. The Next Gen Foundation course is a hand-holding course for the pediatricians, our young budding pediatricians who are entering our college. So we are almost starting them off. Even when they enter, then hand-holding them till they finish their post-graduation. Then we have practices, a lot of programs for the practitioners. So this is in the PSG, which was the first course was launched. Then we had the second course at Pondicherry. Then we had the third course at Kaveri Hospital at Trichy. The postgraduates were really excited, and they have a new, they have a very good entry into the pediatric course with a very good knowledge, and this is by in Chennai we had a physical program for adolescents. Then the academy programs of district branches also was not far behind. They also started off with their installation of the new team members. IAP Chennai City branch had their installation along with the CME. You can see the stalwarts here. Coimbatore Medical College, the first academic session was started off there under Dr. Sasikumar, who was the president of Coimbatore branch. Makaveri again with his branches, and TCB we had Theni Kambam branch, though a very small branch and started only with a few members. They've become very active, and they had an online launch where we all attended here. IAP Tanjavur branch was also successfully organized the first CME and installation of the office bearers. The scientific meets and conferences individually by the district also is not far behind. The virtual Gurukulam by Dr. SBS sir is a benchmark event by IAP Chennai City branch. Every month non-stop they go ahead with doing this program, and almost 7 or 8 sessions have already been completed. Many of the important topics are being covered by them. So, and they had their dengue care continuum CME in the month of January, and then again in February, sensational module in the month of February, which it was going to be another presidential action plan. Pneumo Conclave 2025, which was taken up by other branches too. IAP Coimbatore also had its own Pneumo Conclave. And Pondicherry had its regional ID CME, which was a national CME here. There was an update on pediatric epilepsy and also an update on pediatric gastroenterology. We had a best of allergy here and grand rounds where Amdekars had visited. And there was a national level program on pulmo and dental. And we also had the IJPP CME, the national level CME in June in Chennai. The Chengalpet branch also has a scientific meet, so they call themselves Chengai Meet, and they are having almost every month one of the CME programs, and Chengalpet leads in all the other activities also. So this was the kind of academic activities done by them. We had IAP Dindigul branch. Veluchami sir is doing so much of work, and the most youngest person in the branch is ensured that every month we have one CME programs there. It's really amazing to see the kind of activities he has been doing there. All the main important topics for the practitioners has been covered, and it has been well attended by the members. The TTT branch also had Dr. Elizabeth Madam coming here, and they had their hematology CME as well as one hit module. The Sivasubramaniam oration by Coimbatore branch was a great hit. And the Coimbatore branch also had the HIT module also for history, investigation and treatment. In spite of their busy schedule, they keep doing a lot of work. And CME program on pediatric emergencies were one of the biggest thing done by Salem branch. Trichy branch continued its activities and CME program every month. They have also started to concentrate on various specialities. The pediatric emergency by IAP Salem was itself a mini national conference with 350 odd delegates attending and most of the elite faculties being there. IAP Tanjavur organized along with the subspecialty chapters. The advantage of having the subspecialty chapters also, the district branches are having a specialty meet which really helps in all the practitioners. Nachin and All Point is going to be another one, presidential action plan, which is a great hit. We had the workshops being conducted, the RTA GEM, IAP MAP ALS program for practitioners, the ventilatory workshop at Coimbatore, and the POCUS workshop. This is a massive hit in most of the places wherever it has gone, including the pre-conference workshop here where the 60 seats were filled immediately. We had 4 national conferences. The South Yuva Pedicon, the first of its kind, conducted by Dr. Gopal Subramaniam in Kanyakumari, was a very big hit. The East Coast Pedicon, conducted by Dr. Trimurugan and his team, was another major hit in Pondicherry. The Sangam Pedicon by IAP Madurai, in a very picturesque location of Thekadi, was a very big success. Autocon was conducted for the autistic children by Dr. Subramaniam and his developmental subspecialty chapter. We also have a lot of community activities, the CUTIS module being conducted, Sankalp activity, ATM module being conducted in more than 2-3 places, and it was also again conducted as a pre-conference workshop. The CUTIS module seems to be a particular hit among our practitioners, and this is the ATM module at Madurai. The parent education program, we have to mention Dr. Sambasivam's contribution to this. He has educated more than 50,000 practitioners, paramedicals, mothers. He really deserves a big round of applause. As a single man army, he ensures that he will take up the theme of IVCF and breastfeeding awareness to each and every town of Tamil Nadu. And he's also been honored by IMA Madurai. IMA Tamil Nadu. So these are some of the snapshots of his work. IAP Days and Week activities has also been very much beautifully conducted by all the branches. They had the National Immunization Day, World Kidney Day by Erode branch, World Kidney Program by IAP Pondicherry branch. Pondicherry is doing it in a really big level with more than the colleges being involved. International Child Cancer Awareness Activity at Hotel Savera, Chennai again. World Health Day by Thiruvallur branch. And World Sickle Cell Anemia Day celebrations also. One of the unique things is all this rare diseases, not rare, the incidence is rare, but the awareness program for this is also being conducted so that it creates awareness among the public. World Environment Day has been held up in a very big banner by Thiruvallur, Tiruchi and Dindigul. This is one of the very needed one because we need to hand over the environment safely to our children. As I said, National Girl Child Day was held by 4 branches.
Obesity events was conducted by more than 8 branches. World Autism Day again by more than 8 branches. Anemia awareness by more than 12 branches. World Down Syndrome Day by more than 5 branches. Thalassemia Day again by more than 8 branches. Complementary Feeding Day. You will not imagine Dr. Gunasingh sir had a very unique program also for the Complementary Feeding Day. World Breastfeeding events has been conducted by most of the branches. So all our branches have been very vibrant and they have received the awards for the same yesterday. BLS and CPR Day also. The community awareness program individually by our Dr. Rajendran sir, Dr. Ismail sir and Jayashri Ashwath and Dr. Lakshmi Shanti in Coimbatore for the school students is one kind of fun. They have created awareness on drug abuse, also educating about adolescent issues also. IAP-CCB is also not far behind. They have special programs for even for the adopted children. And Kadalur branch and Neyveli branch always leads, Kadalur always leads with the educating the school children more by Dr. Sendil Kumar and Dr. Aram Sendil sir. Medical legal protection, we would not think it's great, but now it's becoming a very major issue. And it is very nice that this time 4 of the branches had taken it on a big level, and especially Dr. Madurai branch, Trichy branch, they had done it at the public level and with sensitization of the public also, along with the Pondicherry branch too. These are the certain snippets of the same, as well as Erode and Perundurai Medical. So not only the medical college, even the public are made aware of the same. So neonatal resuscitation program, one of the kind to reduce the infant neonatal mortality rate. Advanced NRP in 3 places, Vellore, in CMC, we had it in Erode also and in Tanjavur. And we had the basic newborn resuscitation program at Erode. This is a very key activity to train our nurses for the same. And the second activity was at Vellore, and we had for the both in CMC Vellore and in my hospital. More than 50 to 60 nurses are being trained for the same. And vaccine quiz is connected by IAP Trichy and SRM Trichy. Our members are also very active in social media. Nowadays, it's the need of the hour. Rajendran sir has written numerous articles in spite of his busy schedule here. Trichy always makes sure that they will put it in all the newspaper. That's one of the very good initiative of IAP Trichy. So this is this is the social media propagation by IAP Trichy. These are the articles by our president, Dr. Rajendran sir. So all in all, our members have been very active in most of the media, and we also have our leaders being very active on the radio, Dr. Lakshmi Shanti, Dr. Srinivas, Dr. Amal Raj, and many such people. So we have a long way to go still, and one of the very beautiful dream of having the National Pedicon came up in the executive board meeting of 2025 at Goa, where we won the national bidding for the same venue, and we're going to have in 2027 where we are going to have our own president, Dr. Singaravelu sir. So let's make a promise that we will work for his candidature, and we are sure we will have both the National Pedicon at a grand level with our own president here after a span of 25 years. Thank you so much for your patient listening. Now I request Dr. Rajkumar to deliver the Treasurer's report.
Good evening, one and all. Respected dignitaries on the dais, off the dais, respected seniors, dear friends. It's my immense privilege to, as a treasurer of IAP-TNSC, to present the account statement and budget of this year. Let me start with the account statement. Okay. This is the balance sheet, which is nothing but a snapshot of the financial health of IAP-TNSC. On the left side, that is, I'm seeing here, so that is your right, okay, so my left is your right. So on the left, my left, we have the liabilities. The liabilities means what the IAP-TNSC as a non-profit organization owes to the members since the inception. So whatever we see there is the fruit of all the toil we made in the past, since last 30-40 years. So the capital account, current liabilities, And the excess of income over expenditure. The third one, that's nothing but profit. Since ours is a non-profit organization, we cannot put as a profit. So that is the excess of income over expenditure. And on my right hand side, that is your left hand side, what we have is the assets. Assets means what the thing we own, what we own. So we have two types of assets, the fixed assets, we have the electronic, and the flats, the land and flats. And the current assets means what we have in our bank as well as in hand, as well as the amount which are due to us from the TDS and other things, from the minor debtors, sundry items which are due to us. So on RHS and LHS we have both are equal, 1 crore 63,028 and 385, and this side also same. That means our financial position is very healthy. Let's move on to the next. And this is the income and expenditure for the last year, for the financial year 2024-25, and ended on 31st March 2025. On my left hand side, I have the direct expenses. So these are the expenses we have paid, and on the right we have the income. And when you look at it, it is equally tallied, 28 lakhs 77,735. So all the things are there in your hand. You have, if you have any doubt, you can ask at the end. And this is a depreciation schedule, and we know whatever assets we own, all the movable, non-movable assets, they have the depreciation annually, 1%, 2%, sometimes it's 10%. So we put it there, and it comes for 5 lakhs for last financial year. And this is a branch contribution for the last year. Today morning actually Dharmaburi paid, sorry we didn't update, but other branches paid almost this time. 40% of branches already paid, and rest of the branches I request all the members to please inform your office bearers of your district and ask them to pay in time. So that's the balance we have on 13th/8. We have 40 lakhs 89,441. So I'll move on to the budget now. So this is the budget. On my left hand side we have the assets, and on my right hand side I have the projected expenses. Okay. This is the liabilities and income we project for this year, and this is the expenses we project for this year. On this side we have the income. We are expecting around 24 lakhs 17,080 rupees. From district branch contribution and other nomination fees, bidding amount, all this, MRCCP and ICT, all this contribution, we expect this much of amount. And on the projected expenses, we have 24 lakhs 73,908, and there is a slight deficit, comes around 60,000, but actually the amount we expect is actually will be definitely more. Why? Because in the last the statement I presented just now, which shows that last year we had additional income of almost 5 lakhs since from the projected income. That means this year also definitely we'll almost will generate another 4 or 5 lakhs apart from this 24 lakhs. So definitely there won't be any deficit. Okay. Thank you very much. Thank you for the opportunity.
Thank you, Rajkumar, for presenting detailed one. First of all, I want to appreciate the Kongu Pedicon team for putting a wonderful conference. Thank you very much, Dr. Rajendran and Dr. Ismail and team. And just remind me, just how much is the FDs we have out of this 40 lakhs?
So we have bank account of currently around 54,056,628. FD, Narmada, 40.
Rest of them?
FD.
In 2 or 3 banks or in one bank?
Here I would like to tell you that Dr. Sunathan, you told in the last GB to put this FD in 3 or 4 banks. Yeah. That we did it.
Okay, that's the question I want to ask.
Okay.
Thank you. And the thing is, I know that you mentioned about Tamil Pedicon has given some 8 lakh 50, isn't it?
Yeah.
So we should appreciate that also.
Definitely.
So thank
They
you.
pa-
Thank
they
you,
paid in time.
Yeah, we
Kongu
have to
Pedicon
thank
people.
Kongu Pedicon for putting that,
Definitely
you know,
thank-
we have to just appreciate that. And second, and the other thing is, this conference expenses, 2,30,000.
Yeah.
Is that from the TNSC for the awards and everything?
Yeah, yesterday you must have seen
No, it is
all
award
these
and,
things,
mementos.
everything.
Okay.
Thank you, thank you.
Whatever we spend, it comes from IAP-TNSC. We do not take from the local branches. That is the. So Mike.
So the depreciation போட்டிருக்கீங்களா சார், the
No, I'm sorry.
income and expenditure account depreciation வந்து direct expenseலயே வரும். They put depreciation 5,20,504 as a direct expenses.
So
அது
it's
வருமா?
like, so what they say, it's actually a hidden expense. This expense actually, you know, we
But
have
you
assets.
You have put in that column as a direct expense. All other things accepted, audit fees, bank charges.
So I asked the auditors. Auditor told that it has to come under direct expenses since each year we are actually whatever assets we have, it's depreciating in value. So it has to come in direct one only. He said it
So
was.
if we are taking a building, so we are having building இல்லையா? So அந்த அதெல்லாம் வந்து it's
அது புரியுது சார்.
utensils and
அது
computers
accept பண்ணிக்கிறேன் சார். Depreciation I understand.
Yeah.
But why that has been put in the direct expenses?
Yeah. That auditor has put, sir. That he has telling us.
No, sir, he said that is the way it has to be done. He said.
Yeah.
Regarding that, Dr. Thiramun here. So regarding putting it as a depreciation means that we are going to pay less tax. So eventually, when we sell the building, which is never going to happen, that time when we have a capital gains, that time we won't be able to gain a capital, we won't be able to claim for a capital gains, so we'll end up paying tax. But by doing this, we are able to pay less tax. So either you can do it yearly or you can do it right at the end. So we are doing it yearly, which actually becomes benefit for the society.
Yeah.
These are all loopholes in the tax system. That's what he's telling, sir. The capital gains, it will be definitely less when we maybe will sell in the future.
So one more thing, actually, I would like a note to be made in the report. See, part of them, I think about the GDP-CON has contributed, the IAP-TNSC is holding about 3 lakhs, is that right? 3 or 3.5 lakhs. I don't remember the exact amount. I think because it's being shown as the FD by IAP-TNSC, it's actually not. We are basically holding that money for for GDP-CON to open their own chapter, and we have done that actually now that once their account is open, that money has to be transferred. So probably it's useful if you can just separate it and show it, because otherwise it looks like...
Until transfer the account to the GDP-CON, I think it will be IAP-TNSC account. So once that already, Sudhakar is already they're making for once starting account, now that you can change that one. Okay.
So after sending only we can put it through.
Yeah.
The amount owed to GDP-CON, CCP, everything has been put as a separate FDs.
We
as
have it.
written.
Yeah.
But we should still, because we are holding it, no, that is why it's reflecting.
Sir, please, sir, Dr. PRC.
Dr. Rajkumar, congratulations for presenting this, looking very healthy. I actually have need two clarifications. One is regarding our association. Are we exempted from IT? Are we coming under the charitable organization? That is question number one. Second is, if it is so, what actions, what charities we are actually doing? Are there anything like that? Because the central IAP, every every general body meeting, that becomes a bone of contention. Okay, because there are members who always say that we are not doing any charitable activity, we have to do like this. Second question is, the auditors, whatever we are paying the auditor, does it include the charges for every month? I think he has to, the GST also he has to calculate and upload. Everything is included in this 30,000. I just wanted to clarify.
Sir, in this,
So one is, wait, sir, we are having ATG. Already we got ATG, and we are having some, that's for the, if any donation, if you are coming from, for example, we started that purchase of Hall's Tower, no? That the time we got ATG. So we are doing a lot of any income also we can get exempted. And as central IAP rule says, I think we have to go for charity work. So if you really want, this is a fluid stage, sir. Some associations are doing really charity, and charity means you have to go for community, you have to donate this one. There's a lot of charity work you have to do it, and we are showing our auditors showing a lot of activities as charity like that, and this is a really not completely implemented regarding that charity work. And because if we are going for central IAP, they are having crores of rupees, they can do it. We are having almost only 40 lakhs only. If we are going for charity, I think it is a very, we are having nominal, minimal amount only we are having. But we are having already 80G we are having. So we can use that one for any donation or all those things we are exempted, sir.
Sir, you asked 3 questions, sir answered, President sir exactly answered 2. The last one you asked, did it include the GST? I marked it in yellow lightings there. You can see auditor fees is the first one, 30,000 we paid. The professional fees, the last one, that one contains the GST and other sundry items we pay, sir. That is the GST one, sir.
Sir, again continuation with what sir has asked. IAP, Central IAP is, National IAP is registered as a charity. We are registered as society, sir. So they are bound to do charitable activities. Whereas if we do charitable activities, we can claim that expenses under this charity. So we also have exemption, but we are not registered as charity. We are registered as society. So that's the basic difference between us, state, and the national one, sir. Whereas national Puerto Rico, every money they are actually supposed to spend 85% of their income for charity, which they are not doing. Adrala vande, I think even now something to quite a huge fine has been levied by the income tax department. They are negotiating, I think, to the crores. They have not paid it. I think about 4 or 5 crores have been levied by the income tax on national IAP. It's still in the process. But whereas we are not by law obligated to do a charity activity, but if we do it, we can always claim expenses.
President?
Yeah, please, sir. Tell us, sir, please.
Sir, again, regarding the direct depreciation, is it beneficial to our, because is it
definitely beneficial.
Sir, definitely beneficial, sir.
It's a beneficial, sir.
It is reflected into our IT returns?
Yeah.
And there is no mention about the income tax payment and GST received like that.
Sir, that's
we'll
why
the
the auditor report they given, sir.
We'll go to the first question, sir. We are a charitable organization, so IT will not come for us, sir.
No, Rajkumar, 1 minute. Sir, this is actually the complete statement given. So they need not go for complete day-to-day submission, sir. That's why they didn't give. This is a complete statement. That's all.
Okay, thank you.
Next MSP, you can make it pass now.
Same question on GST actually. So it's being filed every monthly, isn't it?
Yes, sir.
Because I got a bit confused about when Thirus mentioned that we are registered as more as a society and not as a charity. But I'm just
GST comes for all.
I know.
1 minute.
But what I'm asking is, IAP does have some sort of, exceptions for GST purposes. They were able to claim certain amounts. In fact, the previous treasurer mentioned that he was, as far as charity is concerned, they were able to, the income tax, did not charge whatever the pending amount, they waived off that, something like that. So I'm just asking, there was a circular which was sent by Central IAP to state branches. I just want to know whether we could whether you guys received it or whether you could use that, to have some sort of exceptions from IT department for all those purposes.
Actually,
first
I
of
asked.
all, Rajkumar, 1 minute. Actually, if you are going for charity and society, we can't change it now. That means you have to change the re-registration. You have to go. It's very difficult now. And regarding that exemption, already we got 80G. Okay, whatever this income, we can show it in 80G. Also, we can show it. That's all. Otherwise, we are paying the tax.
Good evening, sir. I'm Dr. Babu. So, when I was a secretary of CCB, we received a letter from the office saying that we have to do 80% of charity to claim for exemption. I think President-elect Dr. Somasundram also knows that, office staff knows that. We also received a letter from the office, registered office, saying that we have to show 80% of charity activity, and we have to give the proof for that.
So that's why we are having not registered as a trust and as a society, sir. And as Central IAP, they are registered under trust. That's why they are facing the problem. We are registered under society. Whatever that our income is very less now, that if your per year income is 7 lakhs or 80 lakhs only. So that's why we are not facing any problem until now. And our almost our income, for example, current amount is almost 54 lakhs. That's all we are having. And we are having huge amount only. We are going to face it one thing. Anyway, we are facing that GST also we are paying now.
GST also we are paying, sir. That's why professional fees 70,000 we pay.
So we are paying, sir.
We are paying.
I don't know about the huge amounts, but this is what the auditor of CCB was telling us that time. Because we have to show the proof for the activities.
So then we are actually every month they are actually directing for the GST also whatever things we are getting income.
Okay, thank you.
Charity, so நீங்க சொன்னது charity வந்து அதான் சொன்னலையா சார் இது ஃப்ளூட் மாதிரி இருக்கு ஒரு சில அது வந்து கேக்குறாங்க some year they are not asking any charity.
டாக்டர் பியர் சார் சொன்னதும் அதேதான். சார் one thing is I think that if it applies for the central IAP it should apply for the state and the city branches அப்படி இல்லைங்களா அது மாதிரி
இல்ல அது registration is different.
As per the bylaws
registration is different. சார் அதான் சொல்றாரு.
சார் நம்மளது வந்து சொசைட்டியா ரெஜிஸ்டர் ஆயிருக்குங்க சார். நம்மளது பட் சென்ட்ரல் ஐஏபி ட்ரஸ்டா ரெஜிஸ்டர் ஆயிருக்கு.
So is it mentioned on paper?
ஆமா
is it given on paper that we don't have to show any proof for that charity activity?
So already we register as a society.
Okay. Just a brief comment. Recently we received our auditors keep saying that even for membership fee we have to pay GST. I'm just saying that there are different tariff for different categories. I just want you to be aware of that.
Okay.
Because we'll be charged on that. You know that every month you have to file the GST. Because I'm secretary.
Rajkumar, you note that one. Okay, so note பண்ணிட்டு பண்ணுங்க. So I think we can finish up MSP. So if any doubt please ask.
Sir, there are a lot of young people here. I think if it is possible to share the memorandum of agreement with the society for IAP Tamil Nadu State
it is in website. We are having already in website. So we can
Tamil
go for
Nadu
website.
And IJPP also.
Which one?
IJPP also.
IJPP is a different thing. It's under control of central IAP. And IAP, this our is IAP-TNSC and CCP is a different account. Okay. IJPP is not our purview.
Okay, IJPP is an autonomous body.
Yeah, it is until central IAP, the autonomous. Yeah, I think we can, if anything is, you can, any doubt we can ask, otherwise we can go for past that treasurer report. Yeah, next we'll move.
Thank you, thank you.
So the treasurer report passed by Dr. Suresh Balan and approved by, seconded by Dr. M.S. Vishwanathan. Okay. So the other thing is the ratification of the budget was already passed, that is also done. Approval of the constitutional bylaws has been done by the previous, in the EC. So should we go ahead, sir?
Since if you are going for approval of bylaws, already we have submitted to the Register of Society. Okay, this is already submitted, they are given a receipt. So any existing bylaw, if you are making any changes, you can submit to the Register of Society. They will come and check and lot of clarification they will ask. If you are going, so once what I import from that other Register of Society or other reliable persons, what they are telling. So once they are given, stamped and given, paid and stamped and given means we can take it. That's feedback what they are telling.
Okay. So that is the update on the constitutional bylaws with regard to the approval of the financial committee guidelines are, yeah.
So about this bylaws, I just want to ask you, this bylaws has been done when we had a special GBM in Pondicherry.
Yes.
After this, no other changes.
No.
Can you clarify?
No changes.
No changes.
Yeah, no changes.
We are just waiting for the approval, that's all.
Yeah.
And building financial committee guidelines, we regularly we have a financial committee and we regularly submit to them and the reports are audited. With regard to the building renovation quotation approval, in fact, we have no issues with the main building. In fact, our state guest house is very, very beautiful and you can, we request our members to use the guest house, the rooms there, which will also be a revenue to us as well as it is very friendly for every one of us to, especially for lady members traveling alone, it's very safe. Please use that. And the lower, the ground floor building, sir, you want to add the note on that? Yesterday we discussed about the ground floor in the thing.
Yeah, ground floor already we as many times we went for renovation And one thing is, as a ground floor is already, it is previous, our seniors, we got it that ground floor, and it's because of water lagging and was leaking also. So 3 or 4 times we spent almost 10 lakhs. We are going to do that flooring with the waterproof. And second one is we are going to raise that surrounding that wall, that's all. So we are going to do some minor renovation. I think that Dr. Sudhakar has, yeah, I think Sudhakar, you can come and explain. So already 9.2 lakhs they given quotation, I think. So I think we can go for renovation. My opinion, you can go for renovation. But here, this is not used for the purpose of occupation of occupy by the any families. But you can go for rent for that any godown like that only. We can go for that's godown use பண்ண முடியும், courier something there. அது மாதிரி தான் last time they asked almost 25,000 rent கொடுக்கணும்னு சொன்னாங்க. ஃபேமிலியில் யாரும் தங்க முடியாது. I think so we can't go for family quarters. I think we can go for the renting. That's all.
I'm Gauri Shankar. Can we sell it?
It not possible,
no, not
sir.
possible, sir.
Why what I am telling, this is I want since it's a general body, I want to inform you very clearly. Our seniors, after a lot of difficulties, they got the property. One thing, it is previously it was meant for a car shed. So legal documents are lot of problems. So we can't sell the property. More than that, it is our a monument of our seniors who has got that property. I think once another 20 or 30 years later, we complete renovation or demolition of building, definitely we'll get one plot. So I think we can leave the idea of selling the property. And if we are try to sell also, a lot of legal issues are there because document is not clear, because it's mentioned as a car set.
So just leave it for rent. Whatever rent you are able to get, use it to maintain the IAP flat. I think that will be the best. And minimal what is needed, that alone we can do rather than spending too much, because IJPP had functioned from that place, so we know how it is. It's almost run down. So whatever rent we are able to, we need not spend too much on that. This is a request.
So basically we need almost 9.2 lakhs we need for renovation. I think after that we can go for renting. I think 25,000, I think we can get to almost 3 lakhs per year. I think we can try this time, no other go. Otherwise, simply we are keeping also may go for no use at all.
Sir, answering Dr. it's a very valid suggestion. The point is we are keeping a building idle is also problematic actually. We were IJP office, IAP office, even IAP CCB office also functioning in the same building. But now due to the other thing, raising the road level and everything, causing water seepage into the room. So it is spoiling the whole building. So at least maintain, we know we may not be able to get the rent, but we cannot be calculated on that. The square feet area is 512 square feet areas and the wall will be 360. So we are planning to do the waterproofing for the floor as well as the walls. And the final thing is we got 3 quotations. The lowest one is 8,83,000 plus GST tax comes.
So this one waterproofing one and
raising
the one raising. Actually already 8 feet there rise panna 7 தான் ஆகும். So I think it's very difficult to enter also. That's one thing. Another one is in front of that room இருக்குல அத வந்து we have to raise it.
Yes sir.
Okay.
That also including the cupboard and changing in the cupboard.
Yeah.
It's all waterlogged.
So if the general body approves means I think we can go for that renovation. Please.
I really appreciate the effort taken for regarding the building, sir. Because our president very clearly told, because few years back, lot of confusions, challenges came that the building should be sold and all that. It cannot be sold. It is, as everybody is told, it is with a great effort of Dr. Guna Singh and others who took effort to buy the flat. Definitely it is worth still, even if it is getting demolished, you will get the land which will go in crores. Definitely, as Gauri Shankar sir told, I really agree that minimal expenses, commercially, definitely you will get more rent than keeping it as a residential. Adds up to your efforts. Thank you, sir.
Sir, once again I appreciate the efforts taken by the team to retain the building which was brought by the past leaders. But the concern, as Dr. Gauri Shankar has raised, whether the amount of 9 lakh rupees which you are going to spend is going to be useful, that's one thing. And what will be the rent you will get if you...
25.
So around 25,000 sir. Around 25,000 sir.
சார் அதுக்கு பையரும் இருக்காங்க சார். ஆனா அது தவிர அவங்க ரெண்டுக்கும் கேட்கறதுக்கு ரெடியா இருக்காங்க.
இல்ல பையர் கூட பையர் வந்து it's not possible. Rent what they tell.
25,000 after spending 9 lakhs. That's your point.
Yeah, per month 25,000.
After spending 9 lakhs.
Yeah.
That's one thing.
At present condition not possible to give it.
You know, because if I remember the flat which we got on the first floor, that we spent nearly only 12 lakh rupees for renovation.
If
I am correct. அது வந்து ஒரு நல்ல ஒரு இதா இருக்கு. இது இவ்வளோ ஒரு ஓல்ட் பில்டிங், அது இவ்வளோ பண்ணணுமாங்கிறது
அது வாட்டர்
சார். otherwise we can't leave it also says அப்படியே போயிட்டீங்கன்னா
இல்ல நீங்க கோடவுன் தானே சொல்றீங்க. அதுக்கு
ஆமா சார், ஏதோ பண்ணி தான் ஆகணும். we have to go renovation ஏதோ பண்ணி தான் ஆகணும். அப்படியே விட முடியாது. So we have to go for
கொஞ்சம் நல்லா டிஸ்கஸ் பண்ணிட்டு பண்ணுங்க சார்.
ஆமா.
And get the general body opinion because you are spending nearly 9.4 lakhs.
சார் அது பூஞ்ச காலம் புடிச்சு அது காலே வைக்க முடியலங்க சார். அந்த ரெய்னி
சீசன்
அதுல தானே இவ்வளவு நாள் கால் வச்சிருந்தோம்
சார். இல்ல
அப்ப வேற இப்ப வந்து ரோட் லெவல் ட்ரெயின்
சார். டாக்டர் சுரேஷ் பாலன் சார், we went and saw the condition, current condition. எல்லாமே இப்போ நாட் ஈவன் உள்ளாரே போக முடியாத அளவுக்கு தான் எல்லாமே அப்படியே கிடக்குது. அங்கே லீக் ஆகி எல்லாம் இருக்கு. இந்த சினாரியோவில் எங்கேயுமே நம்ம ரெண்ட் கூட முடியாது. எனிதிங் ஹேப்பன் we are the responsible.
Please get
the because ரெண்ட் வாங்குறீங்க, ரெண்டுக்கு போகும்போது நாளைக்கு ஏதாச்சும் இருந்துச்சுன்னா நம்ம we are responsible ஆயிடுவோம் as a ஓனருங்கிற முறையில். ஸோ தட்ஸ் why even president secretary also face the consequence. So we have to renovate only, we can give it. So otherwise we have to close the building. I think it is even as I said no, இது வந்து ஒரு நம்முடைய சீனியர்ஸ் உடைய ஒரு பயங்கரமான முயற்சியில் வாங்கினது. I think we can 9 lakhsங்கிறது ஒரு worthwhile, we can pass it நினைக்கிறேன். Any objection please raise.
Sir, one point sir.
Yeah,
if
please,
we get
sir.
rent, it will be considered as income. We will be paying tax on the rent also. Please bear that in mind. When we get rent, it is considered as income.
Okay.
We have to pay tax on that also. It will add on to our existing income.
Yes, sir.
So the tax slab may also go up. Ultimately, we will be losing out of the rent.
Thank you, sir. Thank you, sir. Thank you,
keep
sir.
it in mind.
டாக்டர் துரைக்கண்ணன் கோயம்புத்தூர்.
சார் ப்ளீஸ் சார்.
ஒரு பில்டிங்கை சும்மா போட்டு அது கெட்டு போகிறத விட அதை மெயின்டைன் பண்ணால் நமக்கு செலவு மிச்சம்.
தேங்க்யூ சார். தேங்க்யூ சார்.
அப்ரிசியேஷன் ஆஃப் வேல்யூவும் வரும்.
ஓகே
நம்ம செல் பண்ண போகிறதில்ல, அதுக்காக நம்ம அது தரைமட்டமாக போடுறதும் அதில் நல்லா இருக்காது. 9 rupees செலவு பண்ணுறது, அதுலேருந்து நமக்கு வட்டியெல்லாம் கணக்கு பார்க்கக்கூடாது.
சரி சார்.
அதை மெயின்டைன் பண்ணுறோம், அதில் வர இன்கம்மை வி ஆர் யூசிங் இட்.
தேங்க்யூ சார்.
அண்ட் அப்ரிசியேஷன் வில் பி
தேர். So any objection, I think we'll stop it.
Pass it,
please
Dr.
pass
Gauri
it.
Shankar and
yeah, please pass it.
Just one comment on two comments actually. One is regarding the renovation expenditure. When I started as secretary, we took the quotation. It started around 5.5 to 6 lakhs. Same work. Now, thanks to inflation and everything, it has gone up to 9.8. இன்னும் கொஞ்ச நாள் வெயிட் பண்ணோம்னா இதை விட அதிகமாக தான் ஆகும். ஸோ அதனால better to go ahead. ஒன்று.
So I think ask 3 quotation, already they got 3 quotation. Yes, so we can lowest one is 9.2. I think please proceed.
And the second clarification about the other question about loss. See, whatever expenditure we spend on the building will be carried on as a loss to the next year. So till we recoup those expenditures, it will still be useful in the IT. So it will not be a problem.
Thank you. Thank you. So we can pass the thing.
Proposed by Dr. Gauri Shankar and seconded by Dr. Singar.
Okay, we move on next.
So again, the appreciation to the organizing team of Kongu Pedicon. If Dr. Sasi, Dr. Ismail sir is there, we really give them a real big ovation for their tremendous work for the past 1 year in spite of bidding for the National Pedicon 2027 and putting up a great show. Thanks to the team, if anybody is there, Lakshmi Shanti, Dr. Sasi was here so far, Jayavardhanan. Yeah.
So on behalf of IAP-TNSC, and really appreciate our chairperson of organizing committee, Dr. Ismail sir, who has done tremendous work, and really appreciate sir. And another one is Dr. Sasi Kumar as a chief organizing secretary, and it's, this time is a very young team they are doing. Dr. Jayavardhana is the organizing secretary, Dr. Lakshmi Shanti, and we are going for each one. I can say almost 100 people are working. I can't pinpoint. This young team, they are doing very well. I think it is definitely will be a, so I think all districts, so this I can see past few years, a lot of youngsters are coming up. It's Tamil Nadu is going right path and right direction. I think definitely will have great future. So more than that, I really appreciate all in this general body. I really appreciate all the members. This is the time we are united, and united we can achieve it. even if you are going for Pedicon bidding, or if you are going for Dr. Singarwal sir election also, we have to unify, we have to face the things, and you have a great future for us. Thank you.
So we have a short presentation from the next state Pedicon 2026, the update. I request the office bearers to come fast. You will have to get up.
So, respected members, so next year we are into the 50th year conference. We are completed the 49th. It is a prestigious occasion for IAP Tamil Nadu State. And one other thing will be, it will be the South Zone Conference also, the 40th South Zone Conference. And it will be a proud moment for me to take over as the president of 2026 and to hold it in Chennai. So for this we have a team, and we will be presenting our thing. Dr. Sudhakar, our organizing secretary, will be presenting about the conference. I request the GB to approve the same so that we can start the early bird registration from now on. Thank you.
Good evening to the office bearers of the Tamil Nadu State Branch and the esteemed members of IAP-TNSC. We thank you for giving the opportunity and expecting your approval from the GB for conducting Chennai Pedicon, the 50th Golden Jubilee year. So the conference will be the 50th Annual State Conference of IAP-TNSC and 40th South Zone, organized by IAP Chennai City Branch. The conference will be held on August 20th. It's a pre-conference workshop. 21st will be CME. 22nd and 23rd will be conference. Actually, August 23rd is a Madras day, so it's an additional thing for us. The core organizing team, organizing convener will be Dr. A. Somasundaram, Chief Organizing Chairperson Dr. T. N. Manohar, and myself, Chief Organizing Secretary and Chief Organizer Dr. Subramaniam. The venue will be the Chennai Trade Center. We already blocked the thing. And the tariff will be a special offer at the Kongu Pedicon Hall. Spot registration will be for IAP member 8,500, non-IAP member 9,000, senior citizens no free, accompanying person 8,500, postgraduates 8,500, and postgraduate non-IAP member 9,000. This is meant for 16th and 17th. We got the approval from the EB. We've been waiting for the approval from the GB. From 18th August to 31st August, it will be 9,000, and non-IAP members 1,000, accompanying person 8,500, postgraduate 8,500, and postgraduate non-IAP 9,500. We are not increased for the IAP postgraduate students actually. We are continuing the same thing. From 1st September to 31st January, it is 10,000 for IAP member, 11,000 for non-IAP member, accompanying person 8.
Actually, it was presented in EB. Actually, they quoted spot registration, the early bird registration is 9,000. We as EB members, we request to reduce 8,500 because it was last year at Tamira Pedicon where Kongu Pedicon announced that one they started 8,000 on the day of registration, 3 days I think. So now they are asking 500 rupees increment. That means increase the tariff. So I think you open to the forum, so we can take a call.
Sir, 1 minute.
Through, you can proceed through, please.
Okay, sir, one suggestion, because in the national IAP tariff, there is a category for corporate registration tariff is slightly different, is much higher than self-pay registration. So I would request the GB to consider increasing the tariff for the corporate registrations, like pharma sponsor, whatever other. Whereas for individuals, this should be I support this current tariff, but I think for a corporate, maybe additional charge of 2,000 for every slab for a corporate registration.
Dr. Thiru, this one thing is, actually it's a basic for the IAP members. So corporate, I think it's, even if you're going for central IAP, their own team they're fixing, that's all. I think it's not a general body to involve to fix the corporate tariff.
Sir, but my
actually,
request is that
that's they have to decide,
sir,
because
the reason why I'm asking you this, because corporates come and then say we want 50 registrations, and then they try to negotiate a discount on top of it. So as a GB, we approve and then say for any corporate registration.
Now one thing, is I can say, this is a corporate, we can't this word we can't need corporate word in the open tariff. I think they can go for, that's a basic thing. The team, they can negotiate, they can fix it. That's my advice. Yeah, now we can't, in tariff we can't put it corporate. I think if you are going for central IAP tariff also, a corporate that not mentioned at all. This is for understanding, that's all. We can't
Sir,
make
actually,
it openly, we can't
talking,
disclose it.
I just was speaking to Dr. Atanubhadra,
Ah.
and they were saying corporate tariff does exist and is different from
No, that not mentioned. There, if you are 10,000, suppose one pharma is asking, you can give 20,000 or 30,000, but we can't mention openly. We can't mention it. We can't general body. We can't take a decision going for corporate because already that's IMA, NMC, there is act is there, so they are not encouraging the company to sponsor the doctor also. So we can't, அதில் போய் நம்ம மாட்டிக்க வேண்டாம்னு தோணுது எனக்கு என்னை பொறுத்த வரைக்கும். ஸோ அதை வந்து நம்ம தலையிட வேண்டாம். அது அப் டு தம் டு டிசைட். ஏன்னா ஓப்பன்லி இது இப்படி போனோம்னா நினச்சி ஐஏபி சப்போர்ட்டிங் தட் ஃபார்மா கம்பெனி டு ஸ்பான்சர் டாக்டர்ஸ்னு ஆயிரும். இது வந்து நம்ம இந்த மெடிக்கல் லீகல் இஷ்யூவில் மாட்டிக்க வேண்டாம். ஸோ ஐ திங்க் வி கேன் மேக் இட் 8,500 as a thing. I think up to the organizing team to decide.
The early bird can be extended up to month end. Instead of giving only up to 17th, you can put
we
up
can
to
ask
month
the
end.
Sir, actually the last year tariff was
People who are not attended.
The last year tariff was 8,500 for the early bird. So we asked the GB, we will keep it 10% extra and keep it as 9,500. The EB told for the spot registration for today and tomorrow, have it as 8,500, which was the early bird registration of Kongu Pedicon. So we are keeping it the same. We have not at all increased even.
Sir, for years together, sir, sir, that is why it is called spot registration. It
early
is
bird at a time, 1 minute.
Early bird.
Sudhakar, wait. One minute.
டாரிஃபை பத்தி சொல்லல. இந்த பீரியட் எக்ஸ்டெண்ட் பண்ணுங்க 2 நாள்ல மக்களுக்கு தெரியறதுக்கு 2 நாளைக்கு மேல.
So I think shall we keep up to August 31st? Month end கொடுக்கலாம்பா, கொடுங்கப்பா. கொடுக்கலாம்.
Organizing convener has to send.
I think I request organizing chairperson to
சுதாகர் மந்த் எண்ட் வரை கொடுக்கணும் முடிவு பண்ணிட்டு இங்க சொல்றது 2 நாள் சொல்றீங்க. அது எங்களுக்கு தெரியும். அதனால மந்த் எண்ட் வரை.
Okay sir, sure sir. Yes, sir. So we will as a special gesture to the request of the seniors, we will extend 8,500 till this month end. Okay?
Thank you. So that's all we want because
we will share in all the groups the QR code. We have the QR code today also. The QR code, the registration form link, everything will be shared on Monday after we reach there. For the registration in the counter.
Counter number 1.
Counter number 1, it's there. So we have QR code. You can pay by cash or by check also.
Sir,
thank you. That is all we wanted.
Thank you, sir.
Anything, any point, please.
On behalf of Indian Academy of Chennai City Branch and our CCB members, I thank the whole Indian GB body for approving our things, and we assure you that we will give the best academic feast. Thank you.
கேட்டதெல்லாம் கொடுத்துட்டோம் சார். 2000 registration வரணும். We have 1,500 for Coimbatore. It should reach 2,000. Thank you all.
So the GB approved by Dr. Venkatesan sir and seconded by Ismail sir.
Babu
Okay.
sir, please. சார் மைக் நல்லா யூஸ் பண்ணுங்க சார்.
சார் இன்னைக்கு இருக்கிற என்ஜாய்மெண்ட் போய் பண்ணோம் சார், எல்லாரும் ஓடி போயிடுவாங்க, சீக்கிரம் சொல்லுங்க.
Just one point I wanted to add regarding the corporate registration. It cannot be discussed also, and we can't audit, sir. How can we audit that?
Open
that
அது
income?
இல்ல சார், அது
How
முடிஞ்சிருச்சு அந்த
will we
டாஸ்.
audit that
Sir,
income?
matter is
Better
over,
better
sir.
not to better இல்ல
Sir, we'll
but
close the
corporate
matter,
நீங்க sponsor அது இதெல்லாம் நம்ம
Sir,
discuss
we'll
பண்றது
close the
மட்டும்
matter,
இல்ல.
sir.
We
Please,
can't
sir.
audit it also.
Okay,
So
sir.
let us not go into such.
Sir, sorry, only one point about this, also being the South Pedicon, because the IAP rule book now talks about the South Pedicon as well. We need to look at that as well and then see how to be incorporated, because now they're talking about having separate
இல்ல திரு சார் அது 2030 ல இருந்து தான் வருது, அதனால ப்ராப்ளம் இல்ல.
இல்ல ரூல் புக் வந்து
ரூல்
ஆல்ரெடி
புக்ல வந்துருச்சு, பட் அதுல சவுத் பெடிகான் பத்தி பேசுறது 2030 ல தான்.
இல்ல நர்மதா, இட் இஸ் a rotation basis. அதுல what he is telling south pedicanல ரூல் இருக்குனாரு, but I request CCP to look the rule book ங்க, accordingly we will plan and we will next EB meeting we please present it. Okay.
Because it becomes very important, because it's a big headache for us.
Yeah, no, because that how many faculties you have to give, how many who are the persons in the stage, அதெல்லாம் நிறைய ரூல் புக்ல வந்திருக்கு. So அதை வந்து kindly go through it and accordingly follow that rule book. Okay, anything please. Next.
Sir, President, sir, this is regarding a different matter, not this. Can I talk now?
Yeah, please. With the permission of chair, you
chair
can talk,
you can
sir.
do.
Yeah.
With the permission of the chair.
Chair, sir.
Regarding the society registration, I attended the office once.
Yes, sir.
They said that every time there is an election and change of office bearers, we have to inform that to them. That has to be done by all the branches.
Yeah.
So sometimes we are not doing that. That's why there is a problem in continuation of that.
Sir, this time all the district
same
branches.
thing, sir. What I am telling, each branch. So they have to go for even
every time there is a
district
change.
IAP also. They have to go for each year. They have to conduct a general body. They have to same way we are doing IAP-TNSC. You have to conduct a general body. You have to pass a resolution. You have to go for registration. That's my advice.
Thank
Sir,
you.
we have already told in the district
Sir,
office bearers meet yesterday.
the meeting we already informed, sir.
So we'll.
Respected President, one kind request, sir.
Okay, sir.
The IOCF chapter, as you all know, I have already informed you that we need to register. And though it was started in 19, we could not further, because of the COVID, we couldn't get it registered in our Society Act. So you have already promised that you send the details that you will help us to register. It is my kind request as well as my plea. Please do help us to register.
Sir, I already told you, kindly send a official communication to IAP-TNSC with your office bearers as per IAP-TNSC Presidential Action Plan. We started 8th chapter. According to the format, please send it. We'll definitely will do it.
Thank you very much, sir.
Okay, sir.
Hope it will be our 9th.
Okay, sir.
Forget
please send it
registered.
that same format, sir.
Thank you, sir.
Okay,
Thank
sir.
you.
So again, that already we are having 8 chapters, sub-chapters. We are planning to register, and as per Central IAP bylaws, we shortly we do it before the end of this month.
So shall we start? Yeah. So now, vote of thanks by Dr. Rajkumar sir, Treasurer.
Respected IAP-TNSC office bearers and other dignitaries, friends, it's really very happy to see such a lot of crowd in the GB after a long time. So thank you for coming all the way, and thank you for spending your evening with us, and thank you for all your suggestions. A lot of useful solutions you have given, and all your points are well taken. Thank you very much for coming and attending this and making this function a grand success. Thank you very much.
Thank you so much, sir. Ismail sir, இன்னைக்கு banquet எங்க இருக்குன்னு எல்லாரும் கேட்டுக்கிட்டே இருக்காங்க. தயவுசெய்து
Same venue we are having a banquet. I think Dr. Ismail sir, chairperson of
somebody
Kongu
kept
Pedicon
asking
honors.
whether it is
Same
here,
venue.
sir.
Same venue.
இல்ல இங்கயா வெளியிலயா?
வெளியில மலையிலனா வெளியில.
மலையில வெளியில.
Okay.
Thank you all so much. I declare, request the President to close.
Sir, please announce. Dr. Sasi is there?
Sasi is not there, sir. Dr. Sasi is not there.
Yeah, please.
Check. The banquet is in the same venue. Only thing you're going to have the entertainment at the same venue yesterday, the same stage, the entertainment part. It will be DJ Black's DJ along with some musical and dance programs will be there. And of course, all the banquet spiritual evening will be conducted in the food court. And it is an exclusively closed atmosphere. So we request you all to enjoy your spirits inside the hall, especially the food court. Please don't take it outside. And second thing, you can enjoy the dance and the music at the outside. You can dance very well in the floor and near to the stage. And the food court will be the same outside. There is a small area where there will be steps and a downtrodden place. That will be, food will be served there, and as well the routine shamiana which has been given outside, there will be food. So if the venue is here only, you can come and join us by 7 o'clock.
Thank you. The GB is over. I think we can go ahead with the academic session. Thank you all once again for a brilliant gathering for the general body meeting. Thank you.
An announcement from the MC desk before we proceed to the next session. If anybody has misplaced a City Union Bank credit card, please collect it from the MC desk. I repeat, if anybody has misplaced a City Union Bank credit card, please collect it from the MC desk. Proceeding to the next session for the day, it is my privilege to welcome the moderator for the panel discussion on interpreting common pediatric X-rays in clinical practice. The moderator for the session is Dr. S. Venkateshwaran, an eminent pediatrician, past president of IAP Tamil Nadu, and guiding force for generations as a professor of pediatrics. He is also the founder chairperson of the IAP ID Chapter Tamil Nadu and editor-in-chief of the IAP Textbook of Radiology. We are truly honored to have him with us today. I would like to introduce the speakers for the session, Dr. K. Ilayaraja sir, Dr. V.T. Rajesh sir, and Dr. Prasanna Raju sir. Kindly take your seats on the dais, sir.
A very good evening to all. First of all, I thank the organizers for having given me and our panelists to discuss about this common practical aspect of X-rays. Auto run la irukku. Adha maati vidunga. எந்தையும் தாயும் மகிழ்ந்து குழாவி இருந்ததும் இன்னாடே, அதன் முந்தையர் 1000 ஆண்டுகள் வாழ்ந்து முடிந்ததும் இன்னாடே, அவர் சிந்தையில் 1000 எண்ணம் மலர்ந்து சிறந்ததும் இன்னாடே, இதை வந்தனை கூறி மனதில் இருந்து என் வாயுர வாழ்த்தேனே, இதை வந்தே மாதரம் என்று வணங்கேனோ என்று பாரதியின் கவிதை மூலம் சுதந்திர தின வாழ்த்துக்களை தெரிவித்துக்கொண்டு let us go to the subject of read it right. So when you read an X-ray, you have to read it in the right sense. That is the meaning. How you are going to interpret the common X-rays. So medical imaging has revolutionized the field of medicine by providing lot of valuable insights into the body and thus helping the doctors to diagnose, monitor and treat various medical conditions with accuracy. Though there are lot of improvements in the field of radiology, despite the advent of various gadgets in radiology, the common X-ray remains to be one of the most celebrated investigation throughout the globe, in nook and corner, in every areas. And out of all the investigation, 30% of the investigation is being occupied by X-rays, of which 70% are X-ray chest. So we will be most of the time concentrating on the interpretation of the X-ray chest. That is what we commonly do. Of course, one of the next most commonest area of X-ray being demanded is in orthopedics. But most of the time we may not be in that area, so we will be concentrating on X-ray chest. So to help us in the panel discussion, Dr. Ilayaraja is an associate professor from the Division of Pediatric Pulmonology of the Sri Ramchandra Medical College, and he is a specialist in allergy and asthma, and he has done a lot of work in his institute and as well as outside. And also Dr. V.T. Rajesh is one of the famous consultant at Tirunelveli, and he is the current EB member, central EB member. And Dr. Prasanna is from SRM Medical College. He is in the Division of Pulmonology. And so the first X-ray, so the question is to Ilayaraja, how many anatomical structures can you name on this X-ray? Can you think of any important structures in the chest that are difficult to see on the X-ray?
Thank you, sir, for the kind words. Good evening to one and all. So once we check the patient details and the quality of the image, then we can go ahead with the visible structures and the invisible structures in the chest X-ray. With regards to visible structure, we can follow the mnemonic A, B, C, D, E. A is for the airway. Airway number 1 is the trachea. B is for breathing. So number 2 is the hilum and the bronchi. 3 is the C is for circulation or cardiac. Number 5 is the heart. D is the diaphragm, that is number 4. And E is everything else. So that is your 7 is the rib, 8 is the scapula, 9 is the breast shadow, and 10th is the gastric air bubble. Apart from this, there are so many invisible structures, namely the esophagus, spine, sternum, and pleura, fissures, and aorta. Generally, these structures are not visible, but in disease conditions, pathological states, something like a pleural thickening or a pleural effusion, or whenever there is a spinal abnormality, malformations, that times it becomes visible.
Thank you. Dr. Rajesh, can you help us to trace the trachea and bronchi? How will you assess the airway?
Good evening, everyone. First, I would like to say something about the digital X-ray. As the digital X-ray, we have changed over to digital X-ray. It is better to view the digital X-ray in the screen with the help of the app, where you can increase the gain, contrast, everything, so that the invisible structures also sometimes we can see. Sir may appreciate if all who are seeing in the screen will appreciate what I am telling. And in the given X-ray, you can see in the central midline portion, the air within the trachea is seen as a dark shadow. And the position of the trachea has to be judged with the presence of the clavicle, medial end of the clavicle, as well as the spinous process of the spine. And the trachea starts from the pharynx larynx, and it up to the carina, it is extended, and at the level of carina, the right main bronchus and the left main bronchus are divided. And you can also appreciate the aortic knuckle, which is present here in this X-ray.
Thank you, Dr. Rajesh. Now, Dr. Prasanna can proceed with assessing the hyla.
Good evening, sir. Thank you, IAP-TNSC, for the opportunity. So, to quickly to assess the hyla, there are two sides, left and the right. Left is higher than the right. So, there are two lobes of the pulmonary vessels. The upper lobe and the lower lobe, they divide and form the hyla. Usually, the hyla is seen, and then the hyla may not be seen even in some normal patients. The points that we should look into the hyla is whether they are in the right position, whether they are in the right size, whether they are in the right density. So these 3 points are very important to note from the hyla.
Very good, excellent. So you have to keep in mind whenever you look at the hyla, the size, position and density. Whenever there is an increased density, there is some problem. Whenever there is an increase in size, there is a problem. Whenever there is a deviation of its position, it may be a pull or push depending upon the pathology, right? Dr. Ilayaraja, how can you assess the pulmonary arteries?
Sir, so we know that when the right ventricle pumps the deoxygenated blood into the main pulmonary artery, from the main pulmonary artery, the blood is directed towards the right pulmonary artery and the left pulmonary artery. Generally, the right pulmonary artery's course runs just anterior to the right main bronchus, whereas the left pulmonary artery, it goes and arches over the left main bronchus and then continues into the pulmonary circulation. This anatomy is important because the left main bronchus runs a very long course and it can be easily compressed by the vasculature, particularly in conditions like double aortic arch, whenever there is a pulmonary sling or even an enlarged left atrium. All these conditions can compress the left main bronchus, so it is vulnerable or more prone for vascular compression when compared with the right main bronchus.
Very good. Knowing the vessel, the importance is about the compressive pathology. Thank you. Next, Dr. Rajesh, what is this upper, middle and lower zone?
The lung is divided into 3 zones for anatomical reasons to describe the lesions in the lungs. And mainly the second rib medial end and the fourth rib medial end. So in between these two are the middle zone. So above the second rib is the upper zone and lower than the fourth rib is the lower zone. The zone is important because certain diseases are specific for each zone. Like in older children and adult, the upper zone is for tuberculosis, and middle zone we see the primary complex and the lymph node enlargements. The lower zone mostly the aspiration pneumonia, all those things are relevant for this.
Thank you. So in all the pictures we give 2 pictures. One is regular, another one is annotated. It is for your benefit of viewing the various things. And Dr. Prasanna, can you tell about few important aspects of pleura and pleural spaces?
So to assess the pleura, first we have to see with the lung markings, whether the lung markings is there till the end. So that is one most important point. Pleuraன்னு சொன்னோன்னா நம்ம எல்லாரும் போய் நேராக காஸ்டோஃப்ரெனிக் ஆங்கிள் தான் பார்ப்போம். So but pleura is fully around the lungs. So we have to start from the hyla and trace it around the hyla, then come to the costophonic angle, and then go to the cardiophrenic angle and go back to the hyla. So you can have thickening anywhere. So pleurana, you should look for thickening, you should look for effusion, and then you see the lung markings and see whether there is any pneumothorax. Pleura, as already said by Ilayaraja, is a non-visible structure.
Correct.
If it is visible, then it is abnormal.
Excellent. It's an invisible structure. Until it is being affected by pathology, it may not be visible. So if it starts visible, it may be either thickening, or it may be because of mass, or it may be because of fluid in the cavity, or it may be because of the air in the pleural cavity. Very good, fine. Next, Dr. Ilayaraja, how much diaphragm is important in interpretation of chest X-ray?
So diaphragm is a well demarcated structure, dome shaped structure, and the right hemidiaphragm generally is slightly above than the left hemidiaphragm.
Very good.
And that is mainly because of the presence of liver beneath the right hemidiaphragm. The structures that is present beneath the left hemidiaphragm include the gastric air bubble and the spleen. And the asterisk mark points the cardiophrenic angle. That angle is formed between the base of the heart and the diaphragm. And what we should know is the upper border of the diaphragm is not the lowermost part of the lung. The lung continues beneath and behind the upper part of the diaphragm as seen in the chest X-ray into the costophrenic recess, because we can see the air shadows even at the level of diaphragm or beneath the diaphragm. So the lung will continue beneath or beyond the diaphragm into the costophrenic recess. And with regards to the contour of the diaphragm, we can trace the contour of the diaphragms right from the from posterior to anterior, from the spine up to the ribs. So that the lateral X-ray gives a very clear picture. The right hemidiaphragm can be traced all the way from the diaphragm, from the spine up to the ribs, whereas the left hemidiaphragm can be traced only up to the lower border of the heart. And what we are seeing beneath is the gastric air bubble.
Yes, very good. Excellent. Then Dr. Rajesh, can you explain few points about costophrenic angles and the costophrenic recess?
Yeah, the diaphragm where it meets the thoracic cage on the lateral aspect is the costophrenic recess. And also on the lateral X-ray when you see, the costophrenic recess on the back side is also more prominent. And this is very important. It forms acute angle of around 30 degree. And whenever it is not seen, that means there is effusion in it. So minimal effusion if it is there, on the lateral X-ray if you see, it is possible to locate even if the amount is very less, like 50 ml. Whereas in a normal anteroposterior X-ray, AP view, if the volume is more than 100 ml, then it will be visualized. And remember that in decubitus X-ray, these angles, the fluid may not get accumulated in the angles and will be seen as a hazy shadow. Most of the time in dengue patients, when we take X-ray, we'll see similar findings.
Yes. The blending of the recess, not only maybe because of fluid, but also maybe due to consolidation or maybe because of mass also. Thank you. And Dr. Prasanna, can you tell me the easiest way of interpretation of cardiac size?
Yes, sir. There are actually many ways to interpret CT ratio, but this is one of the easiest way that we have projected here. For the left side, you can say the copula, the highest point of the diaphragm, which is usually around the mid-clavicular line. The left major, the contour should not cross this copula line. So that is for the left side. On the right side, the right hemithorax, we can divide it into one-third and one-third. And it should not, the right hemithorax, the right cardiac contour should not cross the one-third of the right hemithorax. So this is one of the easiest way. Just looking at the X-ray, we can tell. So there are so many ways, but this is the easiest way.
What is another way?
Another way, you can mark the center of the spine, sir, and then from the center of the spine, you can take the largest part to the left and the largest part to the right. It need not be a straight line.
So that takes longer time. But this is the easiest, just looking at whether this is in the maximum summit of the diaphragm. Cupola or copula, that means the maximum summit. So it should not cross that. And here it should be within the medial one-third of the right hemithorax. Very good, excellent. And then Dr. Ilayaraja, can you tell me the right way of assessing the mediastinal contours?
So the most important component of the mediastinum is the heart. But in the right mediastinal border, we can see the right paratracheal stripe that runs parallel to the azygos vein. In the left side, we are seeing important structures. Number one is the aortic knuckle. Aortic knuckle is nothing but the lateral most part of the arch of aorta that curves around and continues as the descending aorta. Next is the aortopulmonary window, which contains the left main bronchus and the left pulmonary artery. And beneath is the descending thoracic aorta. Generally, this contour will be maintained in normal patients. In conditions like aortic aneurysm or adjacent consolidation or a mediastinal mass, in these disease conditions, these contours may be altered.
Very good, very good. And then Dr. Rajesh, what is the right way of reading aortopulmonary window and its importance?
Yeah, continuing with the previous slide, we can see the aortic knuckle and the concave translucent space beneath the aortic knuckle, and above the left pulmonary artery is the aortopulmonary window, and which will be visualized only in older children, because in infants the thymic shadow will obliterate this angle window, and in the presence of lymph node enlargement like tuberculous lymphadenopathy or lymphomas or any other mass in the mediastinum, this window will be obliterated.
Okay. Next, Dr. Prasanna, can you read it in the right way, the right paratracheal stripe?
Yes, sir. Actually, the right paratracheal stripe is formed by the right border of the trachea. So it is usually visible from the clavicle to the azygos vein. The left border of the trachea will not be usually visible because it is buried under the great vessels. So it is why it is clearly seen is this is a high density, and beside that there are low density areas. So that is why it is clearly seen. And if it is enlarged, then we should think in terms of a node or some mass in the right side, right mediastinum.
Yes, very good. This is the representation of the right lateral border of the trachea. On either side, on one side the tracheal air, on the other side the lung parenchymal air. That's why it is visible. So whenever there is a thickening or widening, then you have to think in terms of mass or a node or disease in the trachea itself. So on the left side, it is not, most of the time it is not seen because it is overlapped by so many structures on that side, especially vessels and esophagus. Dr. Ilayaraja, can you explain few important right points in assessing the bones in X-ray chest interpretation?
So in the chest X-ray, the key bones that we are going to see is in the upper chest. Number one is the spinous process that is seen in the midline of the spine, and either side of the spinous process we'll be seeing the clavicles. The medial end of the clavicle should be equidistant from the spinous process. That means it is a well-rotated film. Apart from that, we should also be able to track the ribs from the posterior to the anterior aspect. That is very important to know whether it is an inspiratory film or not. Apart from the chest bones, we can also study the shoulder bones in the chest X-ray. So the key shoulder bones in the chest X-ray include the clavicle, acromioclavicular joint, and the acromion process. All these things. So number one is the clavicle, number two is the acromion clavicular joint, and number three is the acromion process. Number four is the body of the scapula. Number five is the glenoid fossa. Number six is the head of the humerus. Number seven is the glenohumeral joint. Number 8 is the coracoid process. So all these structures also we can see in the chest X-ray. So any abnormalities here can also be appreciated.
So any erosions, any destructions, any mass in the bones, any osteomyelitis, all you have to look into. So about this, Dr. Rajesh.
In pediatric, whenever we take X-ray, it's very difficult because they won't hold the breath while we take the X-ray. So it's very difficult to judge whether the film is inspiratory film or expiratory film or partial inspiratory or expiratory. It's very difficult.
Very good.
Now to guide our assessment, now if you trace the 7th rib, anterior end of the 7th rib, if it is touch at the level of diaphragm, if it is there in the mid-clavicular line, that means the full inspiratory film. So, and also you can also see the other clavicle position and the tracheal position in the same time.
Okay, fine. So this may be, so you cannot just ignore the bones. Bones help in assessing the centrality of the film, rotation of the film, or any other abnormality associated in the bones. So bones are equally important like lungs and heart. So, Prasanna, what we like to tell to the audience in this picture?
Sir, apart from this, there are many PGs here. I just want to tell them the most important basic point in reading X-ray is to check whether the patient name is correct or not. So many a times that happens. So first to check the name and then come to these 3 points in the pediatric X-rays. So because they may not be able to take the X-ray in the correct position. The child may not be cooperative. So if you follow this mnemonic rest in peace, so you will be in peace. So first one is rotation, As Eliraja said, the clavicle should be in the center of both the spine, the spinous process, both the clavicles should be in the center. Then, as Sir said, check for the inspiration. The 5th to 7th anterior rib should pass through the diaphragm. And then the penetration. Penetration is very important. Sometimes the X-ray may be underexposed. Then it may look like an apparent pneumonia, or an overexposed, then it can look like an apparent pneumothorax or air trapping. So for penetration, we have to see the spine behind the heart, and the spine should be clearly visible. Sometimes you can see the interspinous spaces clearly, then the penetration is clear.
Very good. Nowadays, as what Dr. Rajesh told, we are now using digital X-rays. So this penetration problem may not be there when digital X-rays are taken, because you can zoom, you can increase the density, decrease the density, and you can visualize your interested areas. So that penetration most of the time may not be problem in nowadays with the digital X-rays. That's what do you say, Dr.
Yes,
Rajesh?
exactly. The penetration, even if it is poor, with a little adjustment, you can able to see.
Anyhow, this is a classical traditional way of approach. Next. Dr. Ilayaraja, can you tell the important criteria for optimal inspiratory film on seeing this?
So there are 4 important criteria to
so one is an AP erect, another one is a supine film.
So the one on the left is the erect film. So to know whether it's an inspiratory film, number 1 is the first rib. The medial border of the first rib should be turned inwards, and it should be facing the trachea. That is number 1. Number two, there should be at least 6 rib lung expansion in the erect erect film.
2, 3, 4, 5, 6.
Yeah. So here the word of caution is the 6 rib is the anterior end, not the posterior end.
Yeah,
the
this is the anterior end.
We should track, and the anterior end of the 6th rib should be above the copula or at the intersection of the copula of the hemidiaphragm.
That should be in the mid-clavicular line, in the maximum superior height of the diaphragm, hemidiaphragm.
So in the supine X-ray, at least 5 anterior ribs should be seen. The anterior ends of 5 ribs should be above the copula of the hemidiaphragm.
So the supine is being, the child is being lying down. So this may be even 5th rib is more than enough.
And the third point is the entire cardiac shadow should be above the level of the diaphragm.
See, this is the maximum base of the heart, which should be above the diaphragm. So it should not be below the diaphragm. The cardiac shadow should maximally be occupying the above the diaphragm or just above the diaphragm.
And the 4th criteria should be the cost of the cardiophrenic angle. That is the angle found between the base of the heart and the diaphragm should be acute angle. So lesser than 90 degrees.
So these are all the 4 points. So the position of the first rib or the clavicle, and then the number of ribs that is being in the anterior end intersecting the diaphragm, angle, and then the position of the base of the heart. So what is your comment on these 3 X-rays, Dr. Rajesh?
First we'll see the first X-ray. When you count the ribs, only the 4th rib is meeting the mid-clavicular line at the level of diaphragm.
2, 3, 4, yes.
And when you see the cardiophrenic angle, it is not acute, it is obtuse angle. At one side it is more than 90-100 degree, and the other side it is almost 160 or 130. So, and the size of the shape of the heart is trapezoid shape, and which all shows that it is a expiratory film. It is not an inspiratory film.
Expiratory or poor inspiratory film.
Okay, poor inspiratory. And coming to the second X-ray, on seeing it appears as if it is an inspiratory film. But when you see the angle, cardiophrenic angle, again it is obtuse. And also you can notice that the heart below the level of diaphragm, under the contrast.
Audience, can you please trace the heart here?
Yeah.
Can you see the border going down?
The air inside the stomach, which is creating a contrast in which you can see trace the cardiac shadow below.
Okay.
And when you come to the third X-ray, here also you can see the cardiac heart below the diaphragm. You can very well see in the contrast created by the air in the stomach. And the angle is somewhat right side, it is almost 90 degree, and left side it is obtuse. And also notice the clavicle, the first rib position. The first rib is pointing downwards. It is not facing the midline. So again, it is a suggestive of a
So
poor.
these are all three are poor inspiratory films. Dr. Prasanna, your comment on these two X-rays, quickly, we are in short of time.
Both the X-rays are supine and both the X-rays are poor inspiratory film because of the fourth rib crossing, the anterior rib crossing. And on the left side, you can see the
heart is how much it is going down.
Four ribs it is going down.
The base is here.
So it is a poor inspiratory film. On the right side, if you see, we commonly get these X-rays. This looks like an apparent pneumonia, apparent cardiomegaly. But first, if you see the inspiration, then you can say that this is a poor inspiratory film.
This is a pseudo, you mean to say pseudo-cardiomegaly, pseudo-pneumonitis?
Pneumonitis.
Very good, fine. And then Dr. Ilayaraja, your comment on these X-rays, quickly.
Yes, sir. Again, this is one more example of a poor inspiratory film. The one on the left is a good inspiratory film because the medial border of the first rib points towards the trachea and the midline. And this film shows a five rib expansion on the supine position. And on the left side is a poor inspiratory film because the medial side of the first rib is pointing downwards, and there are only four ribs that are visible above the diaphragm, and the angle formed by the cardiophrenic angle is not acute, it is obtuse in nature. So that seems to be a poor inspiratory film. That is why we are getting a false positive cardiomegaly or pneumonitis changes in that X-ray.
So this, you mean to say this is ideal film, this is
Yes,
a poor
sir.
film?
Yes, sir.
Very good. And Dr. Rajesh, so your comment on this X-rays, quickly.
In the left X-ray, we can trace the trachea which is there in the midline in relationship with the pedicle of the spine. So in infants, you don't see the spinous process, so we have to adjust or we have to calculate from the pedicle whether it is there in the midline or not. Coming to the other X-ray, where you can trace all the spinous process. So the trachea is compared with that, also with the medial end of the clavicle, which is equal distance from the center point.
Yes, this is an infant X-ray, that's why spinous process is not ossified, this is a grown-up child. Very good. So, Dr. Prasanna, your comment on this X-ray.
Quickly, both are rotated films, sir. Left side, one is slightly rotated. The trachea is over the right pedicles, and the clavicle is malaligned. And on the right side, you can see the entire hemithorax is on the right side.
So this one is a mild shift, this is a massive shift.
Massive shift, sir.
Rotated to the right.
Yes, sir. On the,
so
and
the
on the left
hemithorax,
side,
here it is larger, here it is shorter.
Shorter. The whole ribs are crowded.
Very good. Thank you. And then Dr. Ilayaraja, what abnormality could you observe in this?
Again, both are poorly rotated films, sir. In the left side, what you are seeing, again in both these X-rays, the medial end of the clavicle is not clearly visible, so that cannot be taken as a reference point for centralization. So in these X-rays, we have to take the pedicles of the spine for reference. So here on the X-ray on the left, the trachea is grossly deviated to the right, and it is seen overlaying the close to the right spinous pedicles. So it is shifted towards the right, it's not a well rotated film. Again, the one on the left, again the trachea seems to be overlaying the left pedicles. Again, that is also a not very well rotated film.
So next, what are all the pitfalls in these X-rays, Dr. Rajesh?
Okay, the first one is grossly rotated to the right side. And the second one, we are seeing a shadow, which is the sternal shadow. And the third one is rotated on the left side. You can see the left side ribs are all crowded, and trachea seems
so
to
here,
be
because this there is a rotation, here a false hyperlucency is seen, here it's a pseudo mass is there, and there is a pseudocardiomegaly. All this because of rotations. So next, Dr. Prasanna, how to assess the major vessels and heart?
Sir, can you trace it for me, sir? That is the aortic knuckle, then the pulmonary vessels, and then the descending aorta, and that is the apex, and that is actually the gastric bubble. But in the X-ray on the right, you are not able to see all the vessels because of the thymus, that's a young child. And you can see the apex, but because it's a supine X-ray, then the gastric bubble is not clearly seen because of the gassy bubble or the gastric bubble. So we cannot say the, whether it is situs or not with this X-ray.
So, Dr. Prasanna again, what are the practical points about this normal variance in chest X-ray?
Both are thymus enlargement, which we routinely see, sir. Right is a thymus which appears like a mediastinal widening, but it is not a mediastinal widening. And left you can see appreciate the thymic notch.
So this is because of the compression of a single rib. So in this, again, Prasanna?
Sir, this is because of the compression of the ribs, you have a wavy pattern, and that's a sail sign of the thymus.
So all these are normal variant of thymus shadows. So what do you find in this, Dr. Ilayaraja?
Yes, sir. In the X-ray on the left side, it is showing a tracheal buckling. This is called the tracheal buckling sign, which is not essentially abnormal. It can be normally seen in 2.5% in children, but in certain conditions like mediastinal lesions, vascular lesions, it can be abnormal also. The X-ray on the right is showing it's showing the apex of the heart to be on the right side, and we can also see the fundic air shadow on the right side, and we can see the liver on the left side. Not only that, we can see the bronchial branching pattern like a mirror image of the normal. See the normal long course of the left main bronchus is actually seen on the right side as indicated by the green arrow, and the steep course of the right main bronchus is actually seen on the left side as indicated by the yellow arrow. So that is a mirror image of the normal. So along with these findings, we can say it is a situs inversus totalis.
Very good. So what abnormality is this, Dr. Rajesh?
This 3-month-old baby, the anterior ends of the ribs are not well visually. It looks like as if it is a rickets is there. It is widened, but we should not comment in smaller babies. Whereas the right side X-ray is showing a normal variant of a bifid rib.
So in less than 6 months, there will be bulky anterior costochondral junction. So that you must know, less than 6 months of age. And then what is this normal variation in problem, Dr. Prasanna?
Sir, these are normal lucencies which were seen in younger infants, sir, actually. That is a spinal lucency because of the non-ossification of the spinous process. And on the right side, you have some curvilinear symmetrical lucency near the shoulder joint. On a lighter note, clinical or a party la solvanga. Pudichu utta kulikkumbodhu kadak sound kekudhu. Maybe this is what the air that is trapped in the sinusoids of the shoulder joint that is pushed and causes the lucency. So these are all normal variants and should not be taken as fractures or spinal dysraphism.
Ilayaraja, what is this?
Sir, both the X-rays are showing a shadow within shadow of the heart, particularly on the right side. There's a small shadow. So this shadow is nothing but the right lateral border of the left atrium, which is not normally seen. It can be seen in a small proportion of children. So it can be mistaken as mediastinal mass or something else.
So summarizing all this, dear friends, so you have to know the all clinical details of a patient, and as what they have told, you have to label the name, date and age. That's what Dr. Prasanna told, and also concentrate on the technical factors, and then proceed with the airway, hyla, aorta, heart, thymus, lungs, costophrenic angles, diaphragm, and then also concentrate on the bones, soft tissues. Is there any fractures, anything in the abdomen? And then so the take-home message is get clear-cut clinical history, get trained to read normal radioanatomy, keep in mind the normal variants, especially thymus and various other variants. Whatever be your confidence level in radio diagnosis, each and every film should be read as though it is a new one in a systematic manner, starting at the trachea and ending in bones and soft tissues, and your error will be very, very less. Try to correlate your findings with clinical follow-up and pathological findings. When in doubt, get the opinion of the radiologist. Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, dear panelists. You got discussed very nicely.
Thank you, sirs. That was a thorough and all-encompassing discussion on X-rays that all pediatricians could benefit from. We request you to kindly accept a token of gratitude from our side. I request our moderator, Dr. Venkateshwaran sir, to present our speakers with a token of gratitude. We request the delegates to please wait for the live pediatric quiz that will be happening after this session. We request Rajesh sir to present our moderator with a token of gratitude. Thank you, sirs. We now have reached the final item on today's agenda. It has truly been a rewarding session so far, with insightful lectures and discussions from our esteemed faculty. To conclude, we have the live pediatric quiz conducted by Dr. M. Kritika, Assistant Professor at Theni Medical College, and Dr. G. Madhumati, Assistant Professor at KMCH, Coimbatore. A QR code along with a passcode and a Mentimeter link will be displayed on the screen for you to scan and participate. The same can be found on the Kongu Pedicon Delegates WhatsApp group also. We invite all of you to join in and make this engaging conclusion to the day's program.
Respected seniors, teachers, colleagues, dear friends and students, a very good evening to one and all present here. And we, Dr. Tirumurugan Seran, Dr. Madhumati and myself, Dr. Kritika, bestow our heartfelt gratitude to the Kongu Pedicon organizing team for this opportunity and welcome you all to this quiz program. Sorry, should I say it as a quiz game? Actually, it is a quiz game being played with your mobile. Hope all of you have scanned the QR code or clicked the link or enter the passcode. Once you do this, you will be taken to a Mentimeter page. You have to enter your name in it. If you are very hesitant to enter your name, you can even enter the faculty number. And once the session starts, a question will be projected in the slide and we will be reading out the question along with the options. And once we complete reading out the options, and options will be displayed in your mobile screen and you can click on it. The time duration will be 10 seconds. Not only the right answer, but also how quickly you answer surges you ahead of your competitors in the leaderboard. So not only the right mind, but also the quick mind is essential to play the game. And having said this, I want to disclose the source of this question. So all of us know Kattralin Ketal Nandru. A meaningful conversation with a learned colleague gives you more knowledge than surfing through 50 textbooks. So having this in mind, IAP-TNSC past and the present had so much of online lectures, so much of online sessions from the doyens of the field across the country, which is beneficial not only to the students, also to the faculties and also practitioners. So out of these questions, 75% of the questions have been taken from those YouTube channel. And there will be total of 6 rounds comprising 40 questions. At the end of each round, the leaderboard will be shown. And here I want to offer my heartfelt gratitude to Dr. Balakrishnan sir, neonatologist of KMCH, who has allowed the access to this Mentimeter app. Thank you so much, sir. And offering our prayers over the lotus feet of Lord Sri Krishna on his Janmashtami, we are starting the quiz, hoping that everything goes on well with the app. Dr. Madhumati will be conducting the first 3 rounds. Over to you, Madhumati.
Thank you, ma'am. Good evening, respected seniors. I thank Dr. Rajendran sir, Kritika ma'am and Tirumurugan sir for their guidance. So the first 6 questions will be on neonatology. So everyone ready? Shall we start, sir? Yes. So there is a code also. You can use the number code also. Ma'am, you have to log in and then we can use this code, ma'am. Now, whether we want to... Next. Shall I start, sir? So now you are able to see.
Is it coming? You couldn't register your name. Oh, then what can we do?
Now whether we want to show the QR code again.
So could you please give us 5 minutes?
Stop and leader would at the end of
And see how it works. That we will sort it out, sir. Present person.
Yes. So the first 6 questions are from neonatology. The first question, what does IKMC stands for? The options are A, intensified, B, immediate, C, intact, and D, intra-hospital. So next slide we have options.
Are you now able to see the options?
So you can see the options.
இல்ல இங்க வராது சார். உங்க மொபைல்ல வருமே சார். Oh, you are not able to click it.
ஃபர்ஸ்ட் எடுத்தோட நேம் கேட்கும் அந்த ஆப்ஷன் யாருக்கும் இல்ல.
So now we got again a code, so please try with this. So which we will project in the screen now, sir. Sir, this lab.
This is a new code. Can you please
I think Lord Sri Krishna has answered my prayers and had sent Balakrishna sir to rescue us. Thank you so much, sir.
Sir, share. Code is
So it's better that you go to menti.com and use the code 27903127. That will be much easier. Go to menti.com and just type this code. Does that work? Ashwat sir?
Menti.com. Ma'am, go to menti.com. Illa ma'am, new code has been generated.
New code, madam.
New number 27. புதுசு நாங்க எல்லா கோட்டையும் அழிச்சிட்டு மறுபடியும் முத இருந்து ஆரம்பிச்சிருக்கோம்.
okay.
Illa ma'am, now we have changed the code. Change the code. We have to go to menti.com.
Ma'am.
Name, you have to enter your name. No. Oh. ஆமா இன்னைக்கு என்னாச்சு?
Now it's working. Now it's working, sir. So you have to answer. So you got answers. You can answer quickly to get more points.
Sir, it's working, sir.
It's working. Yeah, yes, madam. Yes, it's anonymous.
Okay, ma'am. What was the name given to you, ma'am? Super, ma'am.
இப்போ okay.
No, it's okay. It's okay. So nearly 86 have answered. Yeah. Good.
So the right answer is immediate. So IKMC means immediate, which we have to start once the baby is stable, ideally within 2 hours, and it can be continued up to 20 hours per day. So the next question. A term newborn born to an unbooked mother with rheumatic heart disease, what is the most likely cause? So we have shown a picture here. So option A, AC inhibitors. Option B, warfarin. Option C, heparin. Option D, alcohol.
Working, ma'am.
Working. Working, sir.
It's working, ma'am.
So 82 people have answered warfarin. It is correct. So in this picture we can see depressed nasal bridge, so which is suggestive of warfarin embryopathy. So the next question. A term baby with no history of perinatal asphyxia presented on day 5 with multifocal seizures. So the MRI picture shown here shows symmetrical diffusion restriction involving corpus callosum and periventricular white matter of bilateral, frontoparietal and also temporal lobes. So what is the most likely etiological agent? So the options are option A, E. coli, option B, coronavirus, option C, rotavirus and option D, HSV. Actually, the right answer is rotavirus. So the symmetrical diffusion restriction is characteristic of rotavirus, and it can also happen in paraechovirus and also enterovirus. So the next question, question number 4. Which of the following malformation occurs earliest in the development? So option A, cleft lip, option B, omphaloceal, option C, anencephaly, option D, hypospadias. So most of you has answered correctly. So this will happen around 3 to 4 weeks, whereas cleft lip is around 5 to 7 weeks, and omphalocele is around 10 weeks, and hypospadia is later around 12 weeks. So next question, question 5. So we have shown an image for which condition this procedure is done. So we can see the image clearly. Option A is cystic hygroma. Option B, hydrops fetalis. Option C, CDH. Option D, CPAM. So the right answer is CDH. It is fetoscopic endoluminal tracheal occlusion, which we will do around 28 weeks, so that by occluding the trachea there will be proper lung expansion and also type 2 alveolar maturation, and they will remove before delivery around 34 weeks. So the last question in neonatology. So you can see an image. The characteristic hand findings is seen in which condition? Please everyone look closely. Option A, Down syndrome. Option B, fetal hydantoin syndrome. Option C, fetal alcohol syndrome. And option D, Patau syndrome. I think everyone has seen the image. Actually, everyone could see cleaner dactyly clearly, but the right answer is fetal alcohol syndrome, because in that we can also see there is hockey stick palmar crease. So where the palmar crease will widen and it will join between second and third. So it is hockey stick palmar crease with cleaner dactyly, which is classical of fetal alcohol spectrum disorder. So the next round is about germs versus jabs, that is immunization. So after this round, you can see the leaderboard. So, and to Annie. So, along with the number, we can find out the leaderboard at last. So, fastest is Casper's. So, the next round is, next 6 questions is about immunization. So, first question, 18-month-old unimmunized child is brought to you as the elder sibling diagnosed to have hepatitis A infection 5 days ago. So what is the preferred action for this child, for this younger sibling? So option A, give immunoglobulins now, give vaccine now. Option C, check IgM ELISA. Option D, give vaccine after 2 weeks. So the infection is only diagnosed for the elder sibling 5 days ago. Yes, most of you has answered the correct answer. So you have to give the vaccine now. So any exposure before, within 2 weeks from the exposure, always we can give the vaccine, because the seroconversion rate is almost around 100% by 90th day. So it is always better to give vaccine than checking for IgM ELISA. So the next question, which is easy, identify the device. So option A, digital thermometer. Option B, infrared thermometer. Option C, digital data logger. Option D, analog data logger. I think anytime others can also join using the number code. Yes, most of you have answered correct. It is digital data logger. So CDC recommends for digital data logger everywhere in vaccine storage because it will not only monitor the temperature continuously, but it also tells how long the machine has run than the required temperature, out of the required temperature. Next question. 1 year, 2-month girl with Kawasaki disease was discharged home after treatment. She received IVIG 20 gram, that is for her weight 2 gram per kg as a single infusion. Mother wants to give the vaccine due at 15 months. So what advice will you give regarding vaccination? So option A, to take the vaccine after 8 months. B, to take vaccine as per schedule. C, to take vaccine after 12 months. And D, to take vaccine after 11 months. Yes, the right answer is to take vaccine after 11 months. So according to our IAP guidelines, so 2 gram per kg they have to take after 11 months. If it is for ITP like 400 milligram per kg, they can take after 8 months. So the next question, what is the age at BCG vaccination in UK as per the latest recommendations? So options A, 0 to 7 days, option B 7 to 14, option C 14 to 28 days, and D after 28 days. This question has been discussed by our immunization expert, our IAP program, sir, in the series. So after 28 days, because they will do routinely primary immunodeficiency screening and then they will give, maybe in future we will also do the same. So question 11, cocooning vaccination strategy is used to prevent which disease? Option A, pertussis, option B, influenza, option C, both A and B, option D, varicella. Yes, for both influenza and pertussis, we will follow this. So when we are not able to immunize the baby, so we can immunize the all possible contacts. So the last question of immunization, SIPV is preferred from. Option A, Sabin attenuated strains type 1 and 3. Option B, Sabin attenuated poliovirus strains type 1 and 2. C, Saccot attenuated poliovirus strain type 3. D, Sabin attenuated poliovirus strains type 1, 2 and 3. So what does SIPV stands for? So the right answer is Sabin strain of all the three, type 1, 2 and 3. So when compared to our conventional IPV, this is less virulent strain and it is also equally, the efficacy and immunogenicity is also the same. So at the end of immunization round, so the leaderboard, who's Elsa? I don't. So metal, Elsa. So they have a number also. Yes. Points. Logo. Okay, the next round is about systems. So which is based on from our IAP program, chat with specialists. First question, a 6-year-old girl presented with fever for 3 days. There is no focus on examination. Urine routine showed turbid urine with 50 to 60 pustules. Culture was sent and she was started on cefixime. On follow-up, she is asymptomatic and afebrile. So urine culture showed E. coli, resistant to cephalosporins, sensitive only to injectable antibiotics. So what will be the next plan of management? So option A, whether you will admit the child for IV antibiotics, whether you will repeat the urine culture, whether you will continue cefixime, and option D, whether you will repeat the urine routine. So the right answer is to continue the cefixime because in vivo and in vitro sensitivity are totally different. Here the child is asymptomatic. So it is always better to continue the same drug. So next question. Identify the biblical character shown in this image. And he is linked to a immunodeficiency syndrome. Name the condition. So option A, DiGeorge syndrome. Option B, Wiskott-Aldrich. Option C, Job syndrome. Option D, Ivy Mark syndrome. So just we want to include the history also. Yes, the right answer is Job syndrome. So he is Job from Book of Job. So his faithfulness was tested by giving so much of skin abscess, sores and boils from head to toe, which is like our hyper-AG syndrome. That's why it is named after him. Next question, a very practical question. A 10-year-old girl was treated for pediculosis capitis with 1% permethrin last week. So mother complains that it is not cleared completely. What would you do now? Option A, repeat 1% permethrin after 1 week. Option B, give malathion 0.5%. Option C, give 5% permethrin. Option D, repeat 1% permethrin after 3 weeks. Yes, the right answer is we have to repeat the permethrin after 1 week from the last dose because the nits will hatch around 1 to 2 weeks. Question number 16. Identify the milestone shown in this image. Option A, parallel play. Option B, object permanence. Option C, pointing to objects. Option D, joint attention. I think everyone has seen the image carefully. So the right answer is joint attention. So usually this is affected in autism spectrum disorder, and we can identify it as early as soon as 9 to 12 months, between 9 to 12 months. So next question again, history. Which syndrome is related to this place? I have put a picture on the top and also the flag. So option A, Robert syndrome. Option B, Smith-Lemli-Optis. Option C, Cornelia de Lange. Option D, Appert. Yes, the right answer is Cornelia de Lange. So formerly it was called as Amsterdam syndrome because it was described by a Dutch pediatrician, Cornelia de Lange, in Amsterdam. Question number 18. Cystic encephalomalacia mimicking HIE is caused by which IEM? Option A, non-ketotic hyperglycemia. B, maple syrup urine disease. C, molybdenum cofactor deficiency. D, fatty acid oxidation defect. Yes, the right answer is molybdenum cofactor deficiency. It is also seen sulfate oxidase deficiency also. So at the end of 3 rounds, Elsa and Anand is leading.
May we know who is Elsa?
No one wants to raise. Okay. So we will move on with next rounds. So next 3 rounds will be done by Kritika ma'am.
So question number 19. A 7-year-old girl sustained 8 cross 5 centimeter laceration in the scalp by a road traffic accident which is actively bleeding. Her vital signs as follows. Heart rate is 160 per minute. Respiratory rate is 36 per minute. BP is 70/50. Fast ultrasound done in ER shows no significant abnormality. What would be your management? Option A, normal saline bolus 60 ml per kilo per hour. Option B, PRBC, FFP and platelet transfusion. C, check hemoglobin and then decide about the transfusion. Option D, start inotropes after first bolus of normal saline. So you may ask me, it is a hypovolemia that kills the child, not the anemia. Why not normal saline first? Of course, the first drug is normal saline, the first 20 ml per kg. But it is how much you are giving decides. Because too much of normal saline gives a particular condition, it causes a particular condition in hemorrhagic shock. That is dilutional coagulopathy. So here not only the fluid that is lost, but there is RBCs, coagulation factors, plasma, everything is lost. So also the bleed is very massive. And you may ask me, why not starting ionotropes? Because here it is one condition where there is permissive hypotension is allowed. If we shoot up the BP, there will be dislodgement of the newly formed clot and rebleeding can occur. So here, because of loss of all these things, in shock, because of hemorrhage, the ideal choice will be PRBC, FFP and platelet transfusion in the ratio of 1:1:1. This is based on lecture by Dr. Shija Sugunan ma'am. Question number 20. A 3-year-old boy has put a plastic whistle into his mouth. He has aspirated. We are hearing some gurgling sounds. Child is crying and coughing. What would you do immediately? Option A, do Heimlich maneuver. Option B, put your gloved finger into the mouth and attempt to remove the whistle. Option C, give 5 back blows and then 5 chest thrusts. Option D, encourage the child to cough. So this is a 3-year-old child. So the option of giving 5 back blows and then 5 chest thrusts in infant is out. 2, it is not a full obstruction. It is only a partial obstruction because the child is coughing and crying here. So no role of Heimlich maneuver. And in a case of only full choking sign, when the foreign body is visible, we can put our gloved finger and attempt to remove. Here in this case, the child may get panic and it will result in a full obstruction. So the only thing we can do is encourage the child to cough. Question number 21. It is a 20-month-old girl noticed to have jaundice since 7 months of life. She has this symptom. You can see, even when she is posing for my photograph, she is itching at the groin and also at the back. She is having such intense itching. Liver and spleen are palpable. Her LFT is as shown. Total bilirubin is 8.9, direct 3.1, indirect 5.8. SGOT is 210, SGPT is 500. Alkaline phosphatase is 840 and GGT is 45. What is the most probable diagnosis? A, Wilson disease, B, PFIC1, C, PFIC, progressive familial intrahepatic cholestasis 3, D, Langerhans histiocytosis. Have you seen the slide? Brilliant. The correct answer is PFIC1. Wilson is out because of the age. Langerhans histiocytosis has high GGT. That is a cholestasis. In any cholestasis, both ALP and also GGT should rise because GGT is a more sensitive marker than ALP because here GGT is normal. It happens in 2 conditions. One is bile acid synthesis disorder or bile acid transport disorder. So PFIC1 is the bile acid transport disorder. Question 22. A 7-year, 11 months old girl presents with pain abdomen only for the past 2 weeks. Loss of appetite, fever for the initial 3 days, later became afebrile, altered sensorium for 1 day with doubtful jaundice. Her liver function tests are total bilirubin 3.3, direct 3.01, indirect 0.29. OT is 78, PT is 130, albumin is 3, INR is 3.3. What is the pathological status? Option A, acute liver failure. Option B, chronic liver disease. Option C, hemolytic disease. Option D, obstructive jaundice. Brilliant. So here albumin is normal, so it is not a chronic liver disease. And indirect bilirubin is not raised, only the direct bilirubin, so it is not a hemolytic disease. The definition of acute liver failure is not the rise in the SGOT or PT, but is encephalopathy with more INR of more than 1.5 or any INR more than 2. Here I want to recollect Neelam Mohan ma'am's 10 commandments. Thou shalt not miss the silent rise in the synthetic function of the liver. Next question, a couple who are physically normal with average stature has come to genetic counseling for their next pregnancy as their first child has been diagnosed to have achondroplasia. They are asking about the chances of next sibling being affected with the disease. What would be your reply? Option A, 0%, option B, 1%, option C, 50%, option D, 100%. So the chances of 50% transmission is there if one parent is affected. Here both the parents are not affected, it is a de novo mutation. So the chances will be negligible. It should not be 0% because there is 1% chance that some mutation may be in the germ cells. So the answer is 1%. Other questions, stuff? The final question of this round. This boy has been brought for evaluation of speech delay, intellectual disability, behavior problems, and macrocephaly. But there is a history of similar disability in maternal uncle is also there. What would be the preferred genetic test? Option A, triplet primed PCR. Option B, chromosomal microarray. Option C, whole exome sequencing. Option D, Sanger sequencing. Have you identified the condition? That was suggestive of autism spectrum disorder. But we had another clue, that is maternal uncle. So some X-linked, what could be the probable? Fragile X syndrome. It is a triplet nucleotide, triplet repeat disorders, CGG. So triplet prime PCR. So had you recognized the triplet nucleotide repeat, you would have chosen it. Congratulations, 30 have chosen it. So the end of this round, Elsa leads. Magical Rhino has surged ahead. Next. So next round, question 25. Yes, this is from Back to Basics by Thangavelu sir and team. A 3-year-old boy weighing 15 kilos has been brought with low-grade fever and rhinorrhea for the past 2 days with acute onset of inspiratory noisy breathing for the past 6 hours. Physiological status is airway obstructed with stridor but stable, breathing, respiratory distress, circulation stable, disability nil. What would be your management among the options given below? A, intramuscular adrenaline 0.15 ml of 1:10,000 dilution. B, 7.5 ml adrenaline nebulization. Option C, 9 mg of intramuscular dexamethasone. Option D, none of the above.
So this round is taken completely from Back to Basics IAP series.
Whoever has watched will answer.
So this is a tribute to Dr. Thangavelu sir and team. So why it is none of the above? Because only adrenaline nebulization has got a role, no role for intramuscular or intravenous adrenaline in croup. That is acute laryngotracheobronchitis. And what is the ceiling dose of adrenaline? It is 0.5 ml per kilo, maximum 5 ml. Here I have given 7.5 ml. Then intramuscular dexamethasone, the ceiling dose is 8 milligram. Here I had given us 9 milligram. So the answer is none of the above. Hope all of you are awake by now. So next question. 10-year-old girl has been brought to the emergency room with abdominal pain and inability to walk for the past 6 hours. There is a history of double vision. Examination reveals bilateral ptosis and absent deep tendon reflexes. Child sustained thorn prick on the evening of the previous day for what she was given TT. So she had been immunized, though she had been immunized with Tdap before 3 months. Look at the child's picture before and after treatment. Before treatment, she is pathetic, looking drowsy, lying down, whereas after treatment, she is standing and posing for the picture. What could be the possible treatment given? Option A, intravenous immunoglobulin. Option B, edrophonium. Option C, anti-snake venom. Option D, pralidoxin. Excellent. Actually, it is not GBS. It is not GBS. Though there is a ptosis, cranial nerve involvement, how will you account for the abdominal pain? So we have to take that thorn prick. It was not thorn prick, but the fang prick. And pralidoxin has got nothing to do here. Edrophonium in myasthenia gravis, we won't have any abdominal pain or absent reflexes. So this is question 20, and this is my most favorite question. Only one among the 4 pictures is correct. What are they doing? They are measuring the mid-upper arm circumference. What is it? Which only one is correct. Is it A, B, 2, C, 3, D, 4?
We will give 1 minute to look at the picture.
This was by Dr. Hemchand and team lecture on growth charts. Actually, in mid-upper arm circumference, there are 2 crucial points. One, noting the midpoint and measuring the circumference. So, to note the midpoint, we should have the elbow flexed like this. And we have to measure the midpoint between the acromion process and the olecranon process. But the measurement should be taken with the elbow extended. All the other things were correct. My PGs were totally clueless when I asked to take all these pictures. They had sent 12 pictures for me, and only option 2 is correct. So this is commonly done, but see how many intricate mistakes we are making. So question 28, all of the following are indications for circumcision except A, hypospadias, sorry for the spelling mistake, B, balanitis xerotica obliterans, C, recurrent balanoposthitis, D, ballooning of the prepuce. Brilliant. Actually, hypospadias is in fact contraindication. The procedure we will be doing is urethroplasty. For that, we need foreskin. If we cut it with the circumcision, there will not be any use. Excellent.
So at the At the end of back to basics round, so again Elsa and we have a newcomer Tinky.
I like the name.
I know. And the next the hustler.
Shall we go to the next one?
Ma'am wants to ask question for PGs and the updated guidelines.
Instruments. This is from Instruments by Dr. Thangavelu sir. Look at the, I think you have to cut our, look at the given ECG and pick up the diagnosis. In that, there is a 10-year-old boy with left-sided chest pain. He is an athlete. There is no history of syncope or LOC. What is the diagnosis and findings? Oh, option A, pericardial effusion. Option B, R-kappa, anomalous origin of right coronary artery from pulmonary artery. C, technical dextrocardia. D, dextrocardia. Can we change? Yes. Actually, how we can differentiate technical dextrocardia and dextrocardia, we have to look at the limb lead and at the chest leads. In the limb leads, usually AVR will be reversed and AVL will be upright. Both in technical dextrocardia and in dextrocardia, it will be reversed. That is, AVR will be upright and AVL will be reversed. How to differentiate these two things? It is the normal progression of R waves from V1 to V6. In case of technical dextrocardia, there will be a normal progression. Whereas in case of dextrocardia, there will be reversal. On the TCG, the tall R waves were seen in V1 and small R waves were seen in V6. So it is real dextrocardia. Sir quote one thing, because whoever wants to read ECG, first you must be able to take ECG. This was Thangavelu sir's quote. This is again my favorite question. How do you name this growth chart? A, IAP modified WHO growth chart. B, IAP modified CDC growth chart. C, pediatrician friendly growth chart. D, intergrowth 21 or growing children. IAP modified WHO growth chart is for children less than 5 years, where IAP has included all the parameters in a single sheet: weight for age, height for age, and also for head circumference, to make it easy for us. Whereas this is pediatrician friendly. Why it is so called? Because IAP knows that we are all allergic to calculations. So there was a BMI tool and also the MPH calculator. So this is pediatrician friendly. Other two are Uttalakadi names. So question 31. So from this, it is for PGs. It is from the latest IAP PG masterclass. A 6 weeks newborn born term is brought to you with concern of development as the child had neonatal depression. What would be your take? A, assess by Pritchell assessment. B, do Hammersmith infantile neurological examination or Heinz score. C, use ICF model and classify with 6 Fs. D, would ask to come by 3 months of chronological age for exact assessment. Hammersmith Heinz score is used for babies more than 3 months. And 23 have answered option D with A pediatrician, one pediatrician for each street, I never expect you to do this. Whatever we have to do, or else they won't come to us. So it is Prestel assessment is nothing but assessing the gross motor movements of the child. The first 6 to 9 weeks, a child will be having writhing movements, and later on the child will be having fidgety movements. So this is a beautifully given. Early diagnosis of CP is possible with this assessment. I want every postgraduate to know this. Hall AC off பண்ணிட்டீங்களா? So this is a latest leaderboard. Tinky, good. Elsa, Tinky. They're neck to neck. Question 32. A 4-year-old child with uncorrected TOF has been brought to you for advice regarding infective endocarditis prophylaxis before dental extraction. What would be your advice? Option A, no need for antibiotic prophylaxis. Option B, intramuscular ampicillin 50 mg per kilo 1 hour before the procedure. Option C, oral amoxicillin 50 mg per kilo 1 hour before the procedure. D, intramuscular clindamycin 15 mg per kilo 1 hour before the procedure. What is the best answer?
This is the last round, sir. So this is the last round.
We have only 8 more questions. Very good. It is oral amoxicillin. If it is an intramuscular ampicillin, it is half an hour before the procedure. And we have to give antibiotic prophylaxis only for one condition, that is dental extraction. So AAP 2022 guidelines have cut off the other surgery prophylaxis, that is for genitourinary and other conditions. So regarding new bronchopulmonary dysplasia, which of the following is false? A, seen in extremely premature infants. B, less inflammation and fibrosis. C, due to oxygen toxicity by mechanical ventilation. Option D, due to arrested alveolar development, which is false. We are very glad that 120 players are still ready. Thank you so much. Oh, wait. The old BPD is only because of oxygen toxicity by mechanical ventilation. This new BPD, it is for extremely premature infants, and here the alveolar development is arrested. I want you to kindly check the differences between old and new BPD. It is a potential question in your exams. We'll skip it. Question 34. Which of the following does not form part of nephrotic syndrome definition? Option A, urine albumin more than 40 mg per meter squared per hour. Option B, urine albumin more than 1 gram per meter squared per day. Option C, serum albumin less than 3 gram per deciliter. Option D, serum cholesterol more than 200 mg per deciliter. ISPN 2021 has taken serum cholesterol more than 200 from the definition. So now we have only 3: edema, nephrotic range of proteinuria, and hypoalbuminemia. Intensive phototherapy is option A, irradiance of more than 30 microwatts per centimeter squared per nanometer. Option B, using triple light phototherapy. Option C, giving intravenous fluid along with phototherapy. Option D, all of the above. Actually, intensification is based on three things. One, increasing the irradiance. Two, increasing the surface area exposure. And three, reducing the distance between the baby and also the phototherapy unit. This 888 phototherapy is our new identification. And adjunct is giving the intravenous fluid. It's only an adjunct. It does not form the part of intensification of phototherapy. This is a 5-year-old child is brought with inability to walk and fever. Before a week, the child had a respiratory illness, following which the child had headache and photophobia. Examination shows a conscious child with right-sided facial weakness, dysphagia, dysarthria, meningeal signs, and motor paralysis of the right leg, proximal more than the distal, without any sensory involvement. What is the probable diagnosis? Option A, atypical Guillain-Barré syndrome. Option B, transverse myelitis. Option C, acute demyelinating encephalomyelitis. Option D, acute flaccid myelitis. It is not ADEM because the child is conscious. There is no features of encephalopathy. It is not transverse myelitis because there is no sensory disturbance. Atypical GBS is a Uttarlakadi term. And this is a new thing, that is a acute flaccid myelitis. It has been given in recent Nelson and also in Piyush Gupta. So where they have meningeal signs and also there is a motor weakness, asymmetric weakness. So in GBS it will be mostly symmetric. So next we have 4 pictures and we thank Thirumurugan sir for his contribution. So identify the syndrome here. Oh God. Identify the condition. Have you got the options? Option A.
It's coming now.
Pectus excavatum, carinatum, holtorum, pollan. Excellent. So, this is a 10-year-old boy who had severe cough for the past 1 week and presented with this condition. Option A, ataxia telangiectasia. Option B, pertussis. Option C, inflamed pinguicula. Option D, episcleritis. Brilliant. How will you treat this condition? Option A, oral cephalexin. Option B, topical mupirocin. Option C, topical corticosteroids. Option D, reassurance. யாரோ க்ளூ கொடுக்குறீங்க, எனக்கே கேட்குது. This is a penultimate question and we are coming to the final question. So this child had been treated with all appropriate anti-diaper rash measures but without any cure. So what is the probable diagnosis? Option A, hemangioma. Option B, cutaneous fungal infection. Option C, streptococcal infection. Option D, atopic dermatitis. Brilliant. This is hemangioma because the distribution does not favor atopic dermatitis and streptococcal infection and cutaneous fungal infection. Thank you so much for the opportunity. Hope you had a interactive session, and also hope you have something to take home with you useful. Thanks a lot.
Sir. Sir, it's adding up, sir. So, Tinky, then Elsa, third one, Anand.
You have to come with the appropriate
Please,
logo.
appropriate logo also, please. Please stand up.
Tinky,
Who is Tinky?
Elsa,
Elsa with this blue logo.
Anand,
Anand.
Anand,
Who is Anand?
Anand, please.
Sir, please, all three of you, please come forward. Please.
Tinky, Elsa, and Anand.
Please come forward. Sir? Sir, your position, sir, it will show the first 75 avatars only. And after
Actually, it will come in your mobile. Sir. It will come in your mobile. You can see your results. I'm not sure. So please, Tinky is Tangavel. Elsa, your name? Huh? Sweta from? Tangavel is assistant professor in Government Trichy Medical College, and Sweta is Elsa from ICH Chennai, and sir, Anand sir from Thoothukudi Medical College. So see, assistant professors have got 2 good ranks. PGs, you have to start reading.
So when we have created this question, many told it was very tough, but finally practitioners only got. So we really thank who stayed through this quiz. We're really, really thankful for this opportunity.
Thank you so much.
Thank you, Kritika ma'am and Dr. Madhumita for the wonderful session. The winners of the quiz will be felicitated at Kongu Pedicon validatory session tomorrow.
Sir, please come to the
Congratulations
stage.
to the all the
Tangavel,
winners.
Anand sir and Sweta, please come to the stage. All of you, please
Tangavel.
give a good round of applause to them.
I request Jayashree ma'am to hand over the memento to Kritika and ma'am and Madhumita. Thank you, ma'am. Congratulations to all the participants. We'll get the details here. We thank all the delegates for their enthusiastic participation and come to the conclusion of what has been an enlightening day. We thank you all for your presence here today and look forward to seeing you at the banquet dinner at 7 p.m. We wish you all a pleasant evening. Thank you.